Hi, good evening students and welcome to these deliberations in Obs and Gynae. And I can see a lot of you have already joined and it's lovely to see. Hi, good evening. Good evening everybody. I'm very much here, Ankit. I'm just waiting for all of you to come in. So great to see all of you and I hope you're reading very well. This is that moment where सब कुछ भूल जाओ यार. अब खाना पीना मरना जीना सब यही 5 दिन. Don't look at anything else. Just keep revising and revising. Do not pick up a new book. Do not pick up a new teacher. If you are liking some other teacher, then you should not be watching this, all right? And if you have already picked up all your notes from one particular teacher, hopefully it is me or the app which we are giving you with PW, I hope you have done all of that and you just sit and revise. And wherever you have the notes, all the 19 subjects, you must be only revising now. Okay, and aram se just put your legs on the table and dhire dhire padhte raho. Bas keep reading and sleep at least 6 hours every day and get to the routine of reading in the morning now around 8 o'clock to evening, so let's say 3 o'clock, and then you can take a little bit of rest and then start reading the night, not beyond 12 o'clock, so that you can just do like this during your exam also, because in the exam you must stay up properly with a fresh mind in the exam hall. All right, you should not be a tired mind. Do not have a all-nighter just before the exam. Chalo, great. Okay, fine. I can see a few students which are already here, and I think we could stop. Paper leak कर देता हूँ यार. Yes, ये तो बोलने में भी कुछ problem हो सकती है आजकल, guys. So yes, I hope whatever we're discussing now, a few of these come in the exam. Okay, chalo. Let's not get distracted too much. We have a lot of work to do and we'll try to see as many topics as possible. And today I'm trying to concentrate on giving you the answers to most of the questions rather than going into much depth of teaching, because when we did the predictor, I did 50 topics. We taught you 50 topics at that time. But today we are planning to teach you, inform you all the answers, what you should be answering, and not trying to confuse you too much with theory. Chalo, let's start with the first question. I'm trying to divide into gynae first and obs next, but after some time I've seen the question, there are a mix. Okay, so you can ask me anything else. I'm looking at the chat also. Those 50 high yield questions are important for everybody. Yes. How many questions are expected? All are expected. Yaar. Kaise? You guys, you want me to actually tell the paper. I wish I had the capacities to tell you all the questions which are coming, but unfortunately I don't have. And even if I had, you think I'm going to tell you. So yes, guys, come on. Yes, jokes apart, please sit and revise as much as possible. Yes, those 50 topics are very important. Those are the general topics which are coming in the exam. Today we are going to do a few more topics and of course revise those 50 topics as well. Chalo, bahut ho gaya introduction. Let's start. A 38-year-old patient visits OPD with a complaint of mass descending through the vagina. A 30-year-old patient. On examination, there's a second-degree uterovaginal prolapse. She has previously undergone 2 vaginal deliveries, one 8 years ago and the other 10 years ago. All of the following factors contribute to her condition except. They're asking you what all can cause prolapse and which one of this does not cause prolapse. So remember precipitate labor. Precipitate labor, I'll be telling you more just in the next screen. But remember, precipitate labor is a delivery which has happened within 3 hours. The pains have started and the delivery has happened within 3 hours of starting the pain. That is precipitate labor. Classically, we used to say within 1 hour. But yes, the definition is 3 hours. So if something goes so fast, it is likely to cause lot of vaginal trauma and muscular trauma of the perineum. And yes, this is a predisposing cause. Prolonged second stage. Yes, second stage should be 1 hour in a case of a primary gravida and 30 minutes in a case of a multigravida. More than 1 hour in a multi and more than 2 hours in a primary is definitely a prolonged second stage. And you know, when there's a prolonged second stage, you know the perineum is here. If you see the perineum here like this, if I'm showing you the pelvic floor with my hand, this is the pelvic floor, right? And the head is here. If the head is on the pelvic floor, let's say it has to come out like this, isn't it? So head is on the pelvic floor. If it is on the pelvic floor more than 1 hour in a multi and more than 2 hours in a primary, it's going to be hitting the pelvic floor for a long time and causing muscular compression and neuronal damage. Neuronal damage is the reason which causes the muscles to become very weak. Neuronal damage. So prolonged second stage also cause premature bearing down. Yes, premature bearing down before full dilatation of the cervix. If the cervix is not fully dilated, suppose it is only 7 centimeters dilated, and you want to go and watch a movie tonight, and you're making her push even before she has fully dilated her cervix. And if the woman is made to dilate through a 8 centimeter cervix when the cervix is not totally dilated, you can imagine ye jo head hai, it is going to press on the cervix and stretch on the ligaments and tear the ligaments, and that's why also it can cause a prolapse. So all of these can cause prolapse, and episiotomy will actually prevent a prolapse. It will prevent perineal injuries, it will prevent perineal compression. So episiotomy is actually going to prevent a prolapse. All right. So yes, quite a few of you have written D, and a lot of you have saying D to the power 15. All right. Okay. So if you know the answer, very good. So I just wanted to tell you a little bit about precipitate labor. It's a rapid birth where entire process from the start of regular contraction to delivery lasts less than 3 hours. That is the definition. And excessive force and pressure in the precipitate labor is driven by exceptionally strong, rapid, turbulent uterine contractions, and it can cause acute mechanical damage of the levator ani muscle complex. So that's why a precipitate labor is not very good. Yes, things finish fast, बहुत जल्दी हो गया, delivery हो गया फटाफट. The resident is very happy, but it's not very good for the mother. Right, let's pick up another question. A 30-year-old primigrada delivers a full-term baby. However, she chooses to formula feed a newborn. After that means she's not breastfeeding the child. That's what we are trying to give you the information here. After how much duration can she start using combined oral contraceptives for avoiding a pregnancy? So remember that combined oral conception with estrogen and progesterone, it works on the principle of suppressing the pituitary. The FSH is for estrogen and LH is for the progesterone. When you give COCPs, this estrogen will suppress the FSH and progesterone will suppress the LH, and the pituitary sleeps, and that's why the woman does not ovulate and she does not have a pregnancy. But what happens when you give COCPs in a woman who is actually breastfeeding? The estrogen component is supposed to inhibit the lactation. The estrogen component is supposed to inhibit the lactation. That's why we do not give COCPs, because estrogens are going to reduce the alpha lactalbumin production also, and it's going to inhibit the GnRH also in an indirect way. That's why we say please do not give estrogens. So progesterone only pill can be given if she's breastfeeding the child, but if she's not breastfeeding the child, then we can give the COCPs. So remember, no COCPs if she is breastfeeding the child. Now this patient has decided not to breastfeed the child. So when can you start COCPs? So in this patient we can start COCPs once the uterus has regained its normal size and the local discharge has stopped, all the vaginal bleeding has stopped, and the woman has regained her normal physiology. So we say after 6 weeks, you can start. In this, when she is not breastfeeding, she is formula feeding the child. If she is not breastfeeding the child, you can start after 6 weeks. But yes, if she is breastfeeding given, if she is giving breastfeeding, then after 6 months, of exclusive breastfeeding, yes, then we have to wait for 6 months, because a lot of people prefer COCPs to any other method of conception, and that's why we can give it after 6 months. Okay, right. So this answer is B. I'm sure all of you got that correct. Which of the following infections is frequently associated with infertility? Now remember, pelvic inflammatory disease is a frequent cause of infertility. Like in my department of IVF, a lot of people don't just come for IVF every time, they come for infertility. And when they come for infertility, invariably when we do a general examination, the infertility definition usko pehle satisfy kar lo, pata chalna chahiye ki bhai infertility hai. When do you say couple is infertile? After 1 year of trying, and after 1 year of regularly trying. You cannot say that they're married for 3 years or 4 years. They should be trying for 1 year at least, coitus around the fertile period for 1 year. Now when she's having coitus for this 1 year and still not conceiving, we say infertile. And first thing when I examine her, invariably we do a pervaginal examination, of course before that perspecular examination, and we rule out pelvic inflammatory disease. And even if there is some mild tenderness, of course we'll send the swabs, we'll send the cultures, but empirically we mostly give the kit 6 jo aap log ko pata hai. We give one cefixime tablet or injection ceftriaxone. In the OPD itself we can give one injection for the gonorrhea, and then you give doxycycline for the chlamydia and metronidazole for the anaerobes. We empirically give PID treatment to quite a few of our patients, because PID treatment every month. I've seen at least 2 or 3. I'm not saying many. At least 2 or 3 patients, or maybe 1 or 2 patients conceive just by giving PID patient on a monthly basis in most of the infertility practicing doctors. Yes, if they don't conceive, there could be semen factors, there could be uterine factors. Of course, the whole infertility is a very big chapter. So always remember, PID treatment is given. And what PID is known to cause infertility? Chlamydia. Chlamydia, only one symptom which the patient will have is infertility. Otherwise, there's no pain, there's no vaginal discharge. Yes, most of you give an answer A, but I was trying to give you some background about it, because chlamydia is an indolent PID, symptomless PID. And if there is no symptom, how do you know that the patient has infection? So yes, gonorrhea will come with pain, abdomen, some vaginal discharge, cervicitis, fever, urethritis, all of that will be there in gonorrhea. But there'll be no pain in chlamydia. So the patient just walks in and says, sir, we've been trying for the last last for 1 year, we are trying for a pregnancy, not having, and then we see that the chlamydial serology might be positive in a few patients. So chlamydia can cause infertility. Yes, most of you written that. So let's move on and see another question. Yes, sir, क्वेश्चन करें कि नहीं? क्वेश्चन करना है यार, क्यों नहीं करना है यार? क्वेश्चन तो जरूर करना है यार, है ना? क्वेश्चन करते रहो, अभी क्वेश्चन ही करना है और कुछ नहीं करना है, अभी नए टॉपिक्स नहीं पढ़ने हैं. हाँ, कुछ मैंने कोई क्वेश्चन पढ़ा है, जैसे कि आज मैं 100-150 क्वेश्चन जितने भी करता हूँ, और उसके बाद तुम्हें लगता है कि यार ये तो टॉपिक पढ़ा ही नहीं, वो टॉपिक जरूर पढ़ लो. क्योंकि अगर मैं पढ़ा रहा हूँ, इफ आई एम टीचिंग यू समथिंग एंड दैट इज गोइंग टू likely come in the exam, because these are the common things which you see in the OPD on a daily basis. Rare things won't come in this exam or even in the NEET PG exam, because we want you to pass for what you know, and what you should know the regular concepts. So याद रखो उसको, ठीक है? तो क्वेश्चंस करने हैं. चलिए आगे बढ़ते हैं. What is the most probable reason for a 26-year-old woman visiting a clinician with delayed cycles, abundant facial hair and hair growth on her upper back, arms and thighs? So 26-year-old with hirsutism. बस ये क्वेश्चन है. ज़्यादा मैंने आपको रिंग ऑफ पर्ल्स अपीयरेंस नहीं बताया है, मैंने ये नहीं बोला है कि उसको एनोवुलेशन है, ये सब कुछ मैंने बताया. मैंने बस ये बताया डिलेड साइकिल्स विद हेरी गर्ल. So if a girl is hairy, most common cause of hirsutism is PCOS, which now is called PMOS. Okay, polyendocrine metabolic ovarian syndrome. Looks like some PM fund something kind of a thing now, but we have to say PMOS now, because देखो PCOS में क्या होता था कि PCOS में polycystic ovarian disease, we used to keep saying, and we used to teach you that PCOS does not have any cysts. अब वो पढ़ाने की जरूरत नहीं है मुझे. I don't have to say that it is PCOS, but polycystic ovarian syndrome does not have any cysts. It became a misnomer. But let's give respect to Steen and Leventhal in the 1950s when they told us about PCOS. That time the definition of cyst was not very well defined. You know, we used to say that there are multiple small follicles which are not ovulating. We know now. But then they thought that they are small cysts. The definition of cyst technically is 3 centimeters and more now. So anything more than 3 centimeters is called a cyst. So that time it was not a very clear definition. That's why they call it polycystic ovarian syndrome. So let's give them a lot of respect, because they discovered some problem in which is there in almost 15 to 20% of women. But now the nomenclature has been simplified, that polyendocrine metabolic ovarian syndrome. Obviously, we know the woman is having anovulation and she's having hirsutism and she's having ultrasound picture. If that is there, PMOS, we are going to say it. And polycystic ovarian syndrome is not used anymore because we are not having any cysts. Okay, so that is most common cause. Remember, hirsutism can be also, in addition to PMOS, it can be because of congenital adrenal hyperplasia, it can be ovarian tumors, it can be adrenal tumors, and it can be idiopathic also. So remember that PCOS or PMOS, don't get upset if I keep saying PCOS, because that's engraved into my genome. Okay, I've been saying PCOS all my life as a gynecologist, so time लगेगा मेरे blood circulation में निकलने को. So PCOS जब हम बोलते हैं, PCOS is a normal looking woman who's got hairy disturbances. She is absolutely normal looking woman. She's feminine. She's a normal woman, but she's got some hairy disturbances like upper lip hair and chin hair and upper back hair, body hair, all that. But hirsutism, because of congenital adrenal hyperplasia, A girl is virilized. She's broad shoulders, hardly any breast tissue. Breast will be flattened and there'll be a very muscular body and V-shaped chest, like the, the latissimus and all those will also become very prominent. And then she'll have male pattern modeling. She'll have a very coarse face, not a very smooth feminine face. And she'll have a hoarseness of voice. So that is what is a very typical adrenal hyperplasia, which is late onset. We actually call it adult onset adrenal hyperplasia. Adult onset adrenal hyperplasia. CH is when we say a newborn having a congenital adrenal hyperplasia. A girl having virilization because of high amount of androgens around puberty, we say adult onset adrenal hyperplasia. So that is a very virilized kind of a girl. So masculine looking girl. That is congenital adrenal hyperplasia. And then adrenal tumors and ovarian tumors, this is known as the rapid onset. This is known as a rapid onset hirsutism. So a girl who was very feminine and there was nothing wrong, and she was a 25-year-old normal looking woman, but she has a ovarian tumor which is making androgens, androgen producing ovarian tumor, like a Sertoli Leydig cell tumor, and that will give her rapid onset hirsutism. Suddenly she'll become very hairy and very masculine. So that is a rapid onset hirsutism. So be very careful in the question sometimes. So a girl who is hairy, first answer is always PCOS, but that's a feminine person. It's a normal looking woman with hairy disturbances. But adrenal tumors and ovarian tumors, rapid onset hirsutism. Adrenal hyperplasia is a masculinized, a virilized girl. All right. CH how? I'm not saying this answer is CH. I'm saying it is PCOS. I'm just telling the other causes of hyperandrogenism. That's all. Adrenal hyperplasia, which is coming late in onset, is adult onset adrenal hyperplasia, which was earlier called late onset congenital adrenal hyperplasia. Now it has been correctly called adult onset adrenal hyperplasia. All right. प्रिडिक्टर क्वेश्चन से कितने क्वेश्चन आने वाले प्रिडिक्टर बुक से? यार हम प्रिडिक्ट कर रहे हैं, उससे सारे आ जाए तो कितनी अच्छी बात है यार. ऐसे क्वेश्चन मत पूछो, तुम लोग मुझे जेल कराओगे यार. प्लीज प्रिडिक्ट से कितने, मैं बोल देता हूँ यार, उस 250 क्वेश्चन में से 200 तो आने ही वाले. यार क्या बात कर रहे हो? प्लीज कम ऑन, यू आर नॉट दैट डेस्परेट, यू बीन रीडिंग मैन. ऐसे क्वेश्चन मत पूछो. प्रिडिक्टर से कितने आएंगे, आज जो पढ़ा रहे हो उसमें से कितने आ जाएंगे यार? ये टॉपिक्स, इन टॉपिक्स में से क्वेश्चन आएंगे. और बताओ, ये जो मैं पढ़ा रहा हूँ इन टॉपिक्स में तो आ ही जाएंगे. Come guys, come, you're better than this. Do not get into desperation. You have read यार. थोड़ा सा इनसिक्योरिटी होना चाहिए, बट डेस्परेट नहीं होना चाहिए. इनसिक्योरिटी नहीं होगा तो एग्जाम का महत्व क्या रह जाएगा? बहुत ही इजी एग्जाम आ गया, सभी पास कर जाएंगे, सभी एकदम से डॉक्टर बन जाएंगे, तो इसकी वैल्यू क्या रह जाएगी? थोड़ा सा तो टफ होना चाहिए ना, लगे कि हम पढ़े थे एंड फिर एग्जाम पास किया था. कुछ तो चैलेंज होना चाहिए ना लाइफ में. If it is too easy, then you don't like it, isn't it? You don't enjoy it. अभी जब पास करके सब आओगे पार्टी करने के लिए, कितना बढ़िया लगेगा. हमारे पीडब्ल्यू ऑफिस आ जाना सारे के सारे, क्या मजा आएगा वहां पे पार्टी करेंगे, है ना? एंजॉय करोगे ना, एकदम सेंस ऑफ इलेशन. इजी होगा तो क्या फायदा होगा? चलो ज्यादा डेस्परेट नहीं हो. अब वो सब क्वेश्चन छोड़ दो, पेपर लीक कर दो बस. अब और कुछ बात करो. चलिए लेट्स मूव ऑन. सो मैं आपको पीसीओएस का फिर से एक बार रिवीजन करा देता हूं. रिमेंबर दैट फॉर द डायग्नोसिस ऑफ पीसीओएस रॉटरडैम एक कॉन्फ्रेंस हुई थी 2003 में. तो दैट कॉन्फ्रेंस दे डिसाइडेड द क्राइटेरिया फॉर पीसीओएस एंड इट हैज बीन एक्सेप्टेड by all the societies, the American Society for Reproduction, and then the European Society, and also the Androgen Excess Society. Everybody accepted those findings, and that is hyperandrogenism with anovulation and ultrasound picture of PCOS. So hyperandrogenism can be clinically that she is hirsute. That is what is the clinical this thing of hyperandrogenism. और दोनों नहीं होने चाहिए, और दोनों हो सकते हैं, एनी वन ऑफ दिस इज इनफ. और लेबोरेटरी में इंक्रीज एंड्रोजन लेवल्स अगर आ जाए. सो दैट इज व्हाट इज द हिर्सुटिज्म डायग्नोसिस. एनोवुलेशन इज द मोस्ट स्पेसिफिक, इट इज द मोस्ट स्पेसिफिक पार्ट ऑफ पीसीओएस. तो अगर आप बोले विच इज दैट वन मोस्ट स्पेसिफिक, यस, ये क्वेश्चन आ चुका है. प्लीज रिमेंबर, नीट एग्जाम इट हैज कम. Most specific finding of PCOS is the anovulation, and then ultrasound picture. Ultrasound picture means the peripherally arranged multiple small follicles, more than 20 or more than 12 नहीं बोलना है यार, ancient है वो. नोवाइक्स के 2 एडिशन में आ चुका है. तो जब किताबों में आ जाता है, then it becomes something which we must teach you with lot of vehemence. It has come in a journal It has come in some update in the Royal College or American College or Canadian and New Zealand Society. ऑस्ट्रेलियन न्यूजीलैंड सोसाइटी भी एक है, कहीं किसी जर्नल में आया तो मैं नहीं पढ़ाता हूं आपको. इफ इट इज कम इन अ बुक देन वी हैव टू फॉलो इट. ओके, सो अल्ट्रासाउंड पिक्चर में मोर देन 20 फॉलिकल्स पर ओवरी है. प्लीज मोर देन 12 अगर आप बोल रहे हो तो रॉन्ग है. बहुत पहले it has become 20 follicles, right? So what are the serotypes, sorry, what are the phenotypes? I'm sorry for that error. So yes, what are the phenotypes in PMOS? 4 phenotypes are seen most commonly. All these 3, A, B, C, all these 3 are seen. That is the most common phenotype. And then it can be combination of any of these 3: hyperandrogenism with anovulation, hyperandrogenism with PCOS morphology, or anovulation with PCOS morphology. Any of these can be there, but most commonly it is the phenotype. The woman's appearance has all these 3 findings. All right, chali. So a 52-year-old woman visits a physician complaining of experiencing warm spells followed by excessive sweating. So 52-year-old है, sweating है, hot flushes हैं, तो menopause की बातें हो रही हैं, and has not had menstrual periods for the past 3 years. What is the most likely hormone profile? So what happens in menopause? So उससे पहले हम देख लेते हैं what happens normally. तो ये quick revision करना बहुत जरूरी है. ये मेरा favorite part है class का. All of you know that when the hypothalamus sends GnRH, which is a pulsatile release, once in 90 minutes, it is longer in the luteal phase and it is faster in the follicular phase. So once in 90 minutes in the luteal phase, once in 60 minutes in the follicular phase, and that acts on pituitary. Pituitary makes the FSH, FSH makes a follicle, follicle makes estrogen which proliferates, proliferate the endometrium. And then the high estrogen gives a message to the brain that the follicle is ready, you should reduce the FSH. So this estrogen gives a message to the brain to reduce negative feedback for the FSH, but it gives the message to the brain, the high estrogen gives the message to the brain to send the LH. So it is positive feedback for the LH. So the LH comes because the follicle is ready and makes a lot of estrogen. So the brain sends LH. LH comes and ruptures this follicle, makes a corpusculum, which makes progesterone, which makes the endometrium secretory. All right, and this high progesterone gives a message to the brain to stop the LH. So yes, this is the basics. We should always remember that the FSH increases in a woman to make the estrogens, and the LH increases in the woman to make the progesterones. So this basic, always remember the punchlines in gynecology: FSH for estrogen and LH for progesterone. So what happens in a menopausal woman? The ovary is old. You know, the ovary is going to work only for 50 years. After that, when she's in menopause, there's no production of estrogen, there's no production of the progesterone also. So the brain is always young. Brain is still young. Brain is always young. Just give me a minute, please. There was some problem. And yes. I'm so sorry. Yes. So what is the hormonal profile? If a woman has gone into menopause, we know that if a woman has gone into menopause, there will be no ovarian function, no estrogen, no progesterone formation. But the brain is always young. Brain is always young. The brain is going to tell the ovary, make estrogen, make progesterone. So it's going to increase the stimulation from the brain. The brain is going to increase the FSH and increase the LH because the brain is always young. The ovaries have become old. So yes, what happens in menopause? There will be high FSH and there will be high LH. So increase FSH, increase LH, and increase. This is wrong. Decrease FSH, wrong. Decrease FSH, wrong. Increase FSH, increase LH, and decrease estrogen. This something similar came in a man who's got testicular failure also. Something similar came if a man has testicular failure also. This came in the INICT exam, right? So if a person has menopause, high FSH, high LH, and there will be less estrogen. Now somebody has asked me this question, which is a very good question. So just now you told that the LH surge is because of the high estrogen, and menopause has no estrogen, so why will the LH be high? So very good question. Those who are reading with me properly, please listen to this segment properly. LH surge is because of the high estrogen. Yes, the LH surge, the LH level is like this. This surge is because of the high estrogens. Correct. But in menopause, there is a tonically high level of estrogen. The level of LH is very high. The tonic elevated LH, I think I said estrogen by mistake. So the level of LH is constantly high. I'm saying that. I'm not saying surge. There's no surge like that, because there is no estrogen giving a feedback to tell the brain to increase the LH. No, 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 that is not happening. But the basic level of LH is high. So there is no LH surge. It's just that the basal level of LH is high and the basal level of FSH is high. So yes, it's a very good question. Somebody asked me recently in one of the live classes somewhere. So remember that LH surge is because the high estrogen, which is going to cause the ovulation. In menopause, obviously there is no estrogen, so there is no LH surge. There is a constant, a tonically elevated LH and tonically elevated FSH and low estrogen. I think all of you got that correct. Chali. What are you asking me? Okay. Right. Which of the following has the least risk of causing endometrial cancer? Positive family history. Yes, you should know familial cancer syndrome. If a woman has CA endometrium, CA ovary, and CA breast, then the first degree female relatives can have any one of these. A woman has CA breast, then her mother, her sister, her daughter can have CA breast, but also CA endometrium and CA ovary. Look, this does not follow with CA cervix. CA cervix because of human papillomavirus. Okay. Now, what else will predispose to endometrial cancer? Obesity, yes. Late menopause, yes. So early menarche and late menopause, more estrogens. Obesity, more fat. Fat makes estrogen. But multigravida means she's getting pregnant many times. Suppose she's pregnant 4 times in her life. So she's got a pregnancy 9 months. There is no estrogens. Then she's breastfeeding the child. Again, she's not ovulating. There is no estrogens. Roughly because of one pregnancy, there is a protection of 2 years. Yes, because of one pregnancy, there's a protection of 2 years from the action of estrogen. So Indian women get pregnant many times. Hai na? In our, I think the family size, I don't know, your PSC people will tell you is 2.6, right? So yes, number of children is 2.6 even now. So हम लोग जानते हैं कि we have traditionally a lot of babies more than other countries. अरे यार, we have 140 million. We must be having a lot of pregnancies, isn't it? So we traditionally have multigravidas in our country, and multigravida prevents endometrial cancer. If a nulligravida is there, a woman who has never got pregnant, she's not got any break from the action of estrogen. So nulliparity promotes CA endometrium. So yes, the answer to this question is the multigravida will have the least risk. Of course, family history, obesity. So yes, corpus cancer syndrome, diabetes mellitus, hypertension and obesity. That is what is known as the corpus uterine body, corpus cancer syndrome. Corpus cancer syndrome, uterine body को हम corpus भी बोलते हैं. चलिए, let's move on and see. Okay, yes, I think mostly you are just reminding me. Okay, fine, thank you. According to the WHO 2021 values of semen, that is, what is the minimum sperm concentration required for a semen analysis? Yes. So please remember that these things have changed in 2021. 2010 के values मत बोल देना. Recently somebody was telling me even before वाले values. So please, 2021 the semen parameters have changed, and obviously now 5 years down the line. So you must definitely know. So which is the minimum sperm concentration? 20 million was earlier, then it became 15 million in 2010. Now it is 16 million per ml, the concentration. Okay, at least itna hona chahiye. At least this much. It can be more than that, and any amount. Long back when I was reading in my MD days, we had an upper limit also. We were taught that okay, 2 to 5 ml is normal, and we used to be taught that up to 60 million to 100 million is normal. So all of those things have now gone. We now are taught that at least this much, more than that, whatever is excess is not going to cause a problem. So yes, this is the semen parameters. I've given you the comparison with 2010 and 2021 values. Remember, the 2021 values are coming in the exam, and the concentration is now 16 million. The volume has also reduced, guys. Remember, the volume is now 1.4 ml. And total motility has increased to 42%, active motility has reduced to 30%, vitality has reduced to 54%. And three things are still the same. That is, the total count is the same, and the morphology is the same as before, and pus cells is same as before. So that's why they are mostly asking you the morphology, because the single best parameter, yes, the single best parameter is actually the morphology. That is the best parameter if you want to assess a man's fertility. What is the single best parameter in a woman's ovarian reserve? In the ovarian reserve, we just comparison के लिए पढ़ा रहा हूँ. Ovarian reserve. What is the single best parameter? Anti-Mullerian hormone in ovarian reserve. So AMH is the best, single best parameter in the ovarian reserve, and in the man, the morphology is the single best. तो अगर morphology ठीक है, just 4% morphology ठीक है, मतलब 96% abnormal भी चल सकता है. Are you understanding the meaning of that? अगर a man has only 4% normal sperms and 96% are abnormal, he can father a child. So even if one sperm is morphologically normal, then I can pick up that sperm from his semen and put it directly into the egg. So we can inject that morphologically normal live sperm, put it into the oocyte, and we can give his own biological child to him by ICSI, intracytoplasmic sperm injection. We do that on a regular basis, okay? So ICSI is the boon for infertile men. Sometimes they don't have any sperms in the semen. Azoospermia भी होता है, तो हम लोग testicular aspiration कर लेते हैं, and testes में से भी take out the sperms, and if they are morphologically normal, we can put them into the oocyte and give them a pregnancy. So we do that regularly. All right, chali. So some other things I want to tell you. The semen, the prostatic fluid is acidic, and the seminal vesicle fluid, it is alkaline. And this seminal vesicle fluid is 70% of the semen, and prostatic fluid is 10% of the semen. Of course, semen will also have bulbourethral gland secretions, will also have the sperms, but the major constraint is this. So remember, because of this, the net pH is alkaline. The net pH is alkaline, 7.3 to 7.4. That is the net pH. It is good. Semen alkaline होना चाहिए, so that vagina की acidity को neutralize कर देगा. Every time a couple have sex, this alkaline semen goes and neutralizes the acidity in the vagina, so that the sperms don't die because of the acidity, and the sperms will survive the vaginal acidity and they'll go into the cervix. Only the sperms go into the cervix. Semen doesn't go into the cervix, you know that. So the sperms can easily go into the cervix because the vaginal acidity has been neutralized by the alkaline semen. It's a very good arrangement by nature. Right, चलिए आगे बढ़ते हैं. A 26-year-old woman presents with infertility. She has regular cycles of 28 days with no dysmenorrhea. Her LMP was 8th of June 2026. When should her endometrial biopsy be planned? By बड़ा सिंपल सा क्वेश्चन है, बट इसमें थोड़ी डेट्स डाल दी मैंने आपको कंफ्यूज करने के लिए, क्योंकि ये क्वेश्चन केम इन नीट एग्जाम अ फ्यू years back. Come. So she has infertility. What is the purpose of doing an endometrial biopsy? It is to know whether she is ovulating or not, and if she is ovulating, the progesterone will increase, and if the progesterone will increase, the endometrium will become secretory. So what do I do to check whether she is ovulated? I can do serum progesterone. I can also do ultrasound by follicular monitoring to see whether she is ovulated. But to know the endometrial health, I go into the uterus and do a curettage, and on the endometrium I can see for secretory changes under the microscope. So when do you want to do it? Yes, when you want to do it. So we do the endometrial biopsy premenstrually, because day 1, day 14, day 28. So these are the days. I'm not saying the date, days. So day 14 is ovulation, day 28 के बाद there will be periods. So if I do the biopsy in this phase, premenstrual phase, this is the phase to do the endometrial biopsy, premenstrual we say. So generally around 20 to 24 day we do it. So which is the best day? 28 to 24th day. So let's see if she had periods on June, क्या डेट था, 8th of June, प्लस 20 डेज कितना आएगा, 28 डे. सो 28 डे, अराउंड डे 20 टू डे 24 करते हैं. वी डू अराउंड डे 20 टू डे 26 तक कर लेते हैं. वी कॉल इट द प्रीमेंस्ट्रुअल एंडोमेट्रियल बायोप्सी बोलते हैं. सो डे 20 अगर लगाते हैं, 20 प्लस 8th of June विल बी 28. सो 28, हाँ यहाँ पे 29 दिया हुआ है, तो डे 21 को बायोप्सी का डेट दिया हुआ है इन्होंने आपको. तो ठीक है, 28 जून को आप लोग एग्जाम लिखो, पास हो जाओ और आ जाना यार. इंटर्नशिप करना शुरू करते ना नेक्स्ट डे से. पास हो रहे हो तुम लोग वैसे ही, आके सबसे पहले मेरे साथ करो एंडोमेट्रियल बायोप्सी. आई विल अलाउ माय इंटर्न्स टू डू एंडोमेट्रियल बायोप्सी. एटलीस्ट ये तो हम पहले हफ्ते से ही दे देते हैं. और अच्छा काम करोगे, वर्क प्रॉपरली, रेगुलरली आना है, बंक नहीं मारना इंटर्नशिप में. इंटर्नशिप का मतलब ये नहीं होता है कि 8 बजे की जगह 10 बजे आओ और आके फिर साइन करके 12 बजे खसक जाओ, फिर कुछ नहीं मिलेगा करने को. सुबह 8 बजे आओ, मेरे साथ राउंड्स लो और उसके बाद पेशेंट्स देखो ओपीडी में, और फिर जब ओटी डे होगा और मेरे को असिस्ट करो. 1-2 हफ्ते 3 हफ्ते देखेंगे तुम्हें. अच्छे से काम करोगे तो फिर आपको एब्डोमिनल क्लोजर्स मिलने लग जाएंगे, फिर आपको यूट्राइन क्लोजर मिल सकता है अगर आप अच्छे से काम करोगे. डीएनसीज तो मिल ही जाएंगे. एंड ओवरजीलस क्यूरेटाज नहीं करना है. ओवरजीलस करोगे तो एशरमैन हो जाएगा. अच्छे से करना है जैसे आपका बॉस करता है. ठीक है. सो लुकिंग फॉरवर्ड टू डू इंटर्नशिप, आई मीन टू एंगेज यू इन इंटर्नशिप विद मी. ऑलराइट, वहां पे थोड़ा टफ होता हूं मैं. ठीक है, चलो आगे बढ़ते. सो अ पेशेंट हु वाज, क्या लिखा है तुम लोगों ने? ओके, डन. यस, a patient who was using copper T IUCD for conception now presents with 20 weeks of pregnancy. The IUCD tail is visible at the os and she wants to continue the pregnancy. What is your next step in the management? तो IUCD के साथ अगर फेलियर हो जाए तो प्रेगनेंसी होती है. रिमेंबर, एक्टोपिक ज्यादा नहीं होता है. IUCD के साथ प्रेगनेंसी होगी नहीं. What happens when I give IUCD? She doesn't get pregnant. So if she doesn't get pregnant, what will happen to the number of ectopics? That will also reduce. If at all she gets pregnant, relatively more ectopic होता है. Absolute number of ectopic अगर बढ़ जाता है तो हम लोग पागल हैं क्या गायनेकोलॉजिस्ट? हम लोग क्यों देंगे भाई IUCD? एब्सोल्यूट नंबर कभी नहीं बढ़ता एक्टोपिक का. प्रेगनेंसी नहीं होता है तो एक्टोपिक कैसे बढ़ जाएगा यार? सो प्रेगनेंसी नहीं होता है, एक्टोपिक भी नहीं होता है. इफ इट ऑल शी गेट्स प्रेग्नेंट, relatively, not absolute, relatively more chance of ectopic. So if a woman with IUCD is pregnant, do an ultrasound and rule out an ectopic. ये पढ़ाते हैं. चलिए, अभी ectopic नहीं भाई, चलो वो थोड़ा मेरा इमोशनल सा टॉपिक है, मैं बीच में डाल दिया वाला टॉपिक. अगर IUCD है और पेशेंट प्रेग्नेंट है और आपको टेल दिख रही है, सो व्हाट डू यू डू? लीव IUCD इन situ, कंटिन्यू प्रेगनेंसी. नो, अबॉर्शन हो जाएगा. डू मेडिकल टर्मिनेशन? नहीं, चॉइस दो ना. पहले तो IUCD के साथ है उसका मैनेजमेंट करो, फिर उसको चॉइस दो. तो रिमूव IUCD एंड कंटिन्यू प्रेगनेंसी. डू हिस्टोस्कोपी इन लोकलाइज IUCD. प्रेगनेंसी में हिस्टोस्कोपी तो कर ही नहीं सकते. तो यहां पे देयर इज ओनली वन चॉइस व्हिच इज कमिंग क्लोज, एंड दैट इज remove the IUCD in the OPD and continue the pregnancy. Yes, she may also say, sir, I took the IUCD because I wanted to not have pregnancy and the IUCD has failed. I'm pregnant now, so I don't want this baby. So first I'll remove the IUCD again. करना क्या है? IUCD तो हटाओ, दिख रहा है ना, टेक द IUCD आउट एंड देन टुमारो मॉर्निंग पोस्टर फॉर एन MTP. पहले तो यू हैव टू रिमूव द IUCD. तो दैट इज द आंसर टू दिस क्वेश्चन. चलिए थोड़ा सा आगे पढ़ते हैं और पढ़ लेते हैं कि क्या मैनेजमेंट है. इफ IUCD इज विजिबल एट द ऑस इन अ प्रेग्नेंट वुमन, सो IUCD इज विजिबल, शी इज प्रेग्नेंट. Let's say she's pregnant and there's the IUCD, let's say a copper T inside, I can see the thread. So take it out and continue the pregnancy. All right. So first is, first is remove the IUCD and then give a choice. She can continue the pregnancy or she can do a MTP. Mind you, if she continues pregnancy, still there is still around 25% abortion chance is there. because IUCD was there and he removed it, there's a chance of 25% that she may abort even after removal. So IUCD visible at the os in the pregnant woman, remove the IUCD and then give her a choice. Then IUCD is not visible, change kar de question. So IUCD is not visible. The woman has got pregnant and patient has an IUCD and the thread has gone up. Aapko thread nahi dikh raha hai. So if it is like this, then what do you do? Not visible, then give her a choice that she can continue the pregnancy. If she wants to continue, there's a 50% abortion chance, more than 50% abortion chance if she wants to continue with a IUCD inside the uterus, which you cannot remove, or she can give a MTP. MTP में हम लोग बेबी एंड IUCD साथ में निकाल देंगे जब हम कर रहे होंगे. So IUCD with pregnancy, this is what we do. Right. All of the following are classified. Question पूछ रहे हो 20 weeks fetus in the uterus won't be troubled by the IUCD. Yes, it can happen, obviously. Abortion हो सकता है, मैंने तो बताया ना. That's what I told you. Okay. All of the following are classified as a cause of secondary amenorrhea except what is primary amenorrhea? Never had periods. So same as delayed cycle. What is delayed cycle? No periods till delayed cycles. या primary amenorrhea, no periods. Primary amenorrhea, delayed cycle और primary amenorrhea एक ही चीज है, गड़बड़ मत करना उसमें, ठीक है. 13 years is primary amenorrhea, but 15 years with pubic hair, secondary sexual characters के साथ we say it is 15 years primary amenorrhea. Now secondary amenorrhea is कि उसको period आ रहे थे, she was regularly having periods, now she is not having periods, she is 25 years, she stopped having periods. Can happen because of tuberculosis, can happen because of PCOS also. PCOS, there are women who don't get periods for 6 months so many times. I have patients who get periods once in a year. Yes. So PCOS, tuberculosis, the cause of secondary amenorrhea. अब ये मत बोलना कि pregnancy, अरे भाई pathology की बात कर रहे हैं. Pregnancy is a cause of secondary amenorrhea, I know that, but we are asking you pathologies. If a woman doesn't have period, obviously I'll rule out a pregnancy. Yes, pregnancy is not a pathology, na? Pregnancy is a normal thing to happen to any woman. It's part of being a woman to have a pregnancy. So we don't say pathologies mein pregnancy. So if it is secondary amenorrhea, we're talking about a pathology. So rule out pregnancy obviously, and we are talking about the pathology. So what are the pathologies? It can be Sheehan syndrome. Yes, Sheehan syndrome is postpartum pituitary necrosis. So it is a case of secondary amenorrhea. Kallmann syndrome is hypothalamic amenorrhea. Hypothalamic amenorrhea plus anosmia. So this is a disorder. This is not a cause of secondary amenorrhea. This is a cause of primary amenorrhea. Intrauterine adhesion, SMN syndrome, because of overzealous curettage by interns who are very muscular and they want to do a DNC first before assisting. Always assist first, guys. Otherwise, you'll do overzealous curettage. नहीं यार, PG से भी होता है, हम कंसल्टेंट से भी हो सकता है, बट हम इंटर्न्स को ज़्यादा बदनाम करते हैं ना, बिकॉज इंटर्न्स को अगर कुछ बोल भी दोगे तो बेचारा बोलेगा चलो ठीक है सर, अभी तो सीख रहे हैं, हमारा एक्सप्लॉयटेशन कर रहे हो. बहुत पीजीज भी करते हैं, ऐसी बात नहीं, इंटर्न्स को ज़्यादा बदनाम नहीं करना चाहिए. देन ट्यूबरक्लोसिस कैन ऑल्सो कॉज. सो प्लीज, शीहान्स, इंट्रायूटेराइन एडिशंस, ट्यूबरक्लोसिस, PMOS, which was PCOS earlier, all of these can cause secondary amenorrhea, but Kallmann syndrome does not cause secondary amenorrhea. चलिए, which progesterone is preferred for emergency contraception? तो देखो, progesterone is preferred for emergency contraception. याद रखो, एक हमारे पास यूलिप्रिस्टाल भी है. अब यूलिप्रिस्टाल मैंने चॉइस में नहीं दिया, बिकॉज अभी तक मैंने पढ़ा नहीं. अगर कुछ आ गया है तो मुझे मैसेज कर देना आप लोग. अभी मैं देख रहा हूं आपकी चैट. यूलिप्रिस्टाल इज अ वेरी गुड सेलेक्टिव प्रोजेस्टेरोन रिसेप्टर मॉड्यूलेटर. ये 5 days तक काम कर सकता है. इट कैन वर्क फॉर 5 days, बट इट इज नॉट अप्रूव्ड by the government of India for use as a emergency contraceptive drug. So till 2 months back it was not approved. तो अगर approve हो भी गया तो आपके एग्जाम में नहीं आने वाला है. Okay, so यूलिप्रिस्टाल is a good drug, may become a drug of choice once it is approved. So it is not approved. So IUCD, since it can be given up to 5 days, देखो IUCD is the most effective emergency contraceptive measure. Most effective, सबसे अच्छा काम करता है. But IUCD every time when a woman has unprotected sex and unplanned sex, तो बहुत बार होता है. Yes, sexual life is becoming very prolific in our country even, and when people have intercourse, so many times they are not using any contraception. So every time they have unplanned sex, they'll keep coming to me for an IUCD. IUCD is painful. It requires a prescription and it requires a doctor to place it inside the uterus. So nobody would want that kind of a method. So it is the most effective method. Yes, IUCD is the most effective method. Definitely not the method of choice. इसमें confuse कर जाते हैं. Yes, it is most effective contraceptive method because it works for 5 days. It can given up to 5 days. Most effective, but please don't say it is the drug of choice or method of choice. Not at all. Norethistron can be given, but the best drug which has shown मिनिमल साइड इफेक्ट्स बिकॉज क्या होता है नॉर्थिस्ट्रॉन में थोड़ा सा एंड्रोजेनिक इफेक्ट्स होता है और अगर फेल हो गया हमारा इमरजेंसी कॉन्सेप्शन मेथड इफ इट फेल्स and it's a female child that may have some androgen effects because of norethistron. So we don't give norethistron. We give levonorgestrel. So levonorgestrel 1.5 milligram, one tablet. Yes, it works only for 3 days. It does not work beyond 3 days. Even on the third day, the effectivity is not as much as the first and second days. Mifepristone is one of my favorite tablets which I give to the patients for the emergency conception. But yes, most people don't come to us for emergency conception. Purpose ही है ना, emergency conception is over the counter drug. So patients don't come to us asking for it. They have unplanned intercourse, they just go to the market and there are few, there's an easy pill, EZY pill given by the government of India. There's an I pill which is a commercial preparation. I mean, it's a brand which is there. So most people know about this drug. So they generally don't come to us because that's the purpose, over the counter drug. But IUCD, she'll need a doctor. That's why it is not the best method. Okay. But remember, in an emergency conception, what are you doing? You're reducing ovulation, preventing ovulation. अगर ovulation के बाद they have unplanned intercourse, then we can reduce tubal motility. We can reduce the implantation, but we are not causing an abortion because it is within 3 days, maximum 5 days. So when intercourse happens, earliest implantation, this question is very specific, is on the 6th day. It's on the 6th day. Yes, earliest implantation. So that's why emergency contraception definition is 3 days. We can use it up to 5 days with the IUCD, but not on the 6th day because 6th day there's an implantation. Can happen implantation. So emergency contraception definition is 3 days, can be extended to 5 days with IUCD, but not on the 6th day because after 6 days she's pregnant. So if the definition is only 3 days, in the 3 days there is no implantation. So can you do an abortion in emergency conception? You can't. Emergency conception is within 3 days and she gets pregnant earliest on the 6th day. So abortion आप चाहोगे भी तो नहीं कर सकते. That's why it's over the counter drug. That's why, because abortions can be done only by a gynecologist. But emergency conception, you cannot do an abortion because it is within 3 days. That's why it is over the counter. Please, अगर नहीं समझ में आया, please pause and rewind and re-listen to what I said. If you're especially seeing this as a recording. Remember, emergency conception does not employ abortion as a method. Solid MCI question है ये वाला. Emergency conception में, why do we say it is over the counter? Because it does not employ abortion as a method. चलिए, बहुत बार repeat कर दिया, आगे बढ़ते हैं. So what is the preferred treatment of Trichomonas vaginalis? Trichomonas बहुत ज़्यादा itching करता है because it's got a trophozoite which is 30 to 40 microns. It keeps running in the vagina, cause lot of inflammation and red macules बन जाते हैं. Yes, red macules, inflamed vagina. Yes, strawberry vagina, strawberry cervix, very good. So that is happening in Trichomonas vaginalis. So preferred treatment is always metronidazole. So Trichomonas vaginalis and bacterial vaginosis, dono mein metronidazole is the drug of choice. So yes, I think somewhere else I've given you the complete pictures of vaginitis. We'll come to that later. चलिए next question देखते हैं. Both partners have to be treated. We are just coming to that. There's another question on that, so we'll discuss. A 26-year-old lady presents with infertility and is diagnosed with a bilateral corneal block on hysterosalpingography. What is the next step? She's having infertility. She's come to us and we check for semen analysis first. First investigation infertility. What do you do in the woman? Check for ovulation. All that is fine. Still not getting pregnant? Look for tubal patency. Now, one of the sasta badhiya tikau tests. I'm not saying the best test. Sasta easily done on OPD basis is the HSG. Not the best test, please. Laparoscopy and hysteroscopy is the best assessment of the anatomy, but HSG you can do. Now HSG में ट्यूब बंद आ रही है तो क्या करोगे? IVF कर दोगे सीधा? Not at all, because this is done under IV sedation. Patients many a times have a lot of pain, and there could be some spasm of the fallopian tubes at the cornua. Uterine muscle spasm can cause a false positive. You may think that the tubes are blocked, but may actually be open. So you must do a laparoscopy and a hysteroscopy. I'm so happy that all of you sent that. A lot of you used to answer IVF. No, IVF is the last thing. Look, IVF सबसे पहले नहीं आंसर देते. What is the success of IVF? In the best of the institutes, it is 45%. If you come to my hospital, I'll tell you 45%, and I'll be happy that I do IVF in batches. In my hospital, we do like next batch, I have around 32 cases. Every 35 days, we do it in a batch. So when we do like that, we have lesser infections and we control the hospital. Now, when we do so many patients, we tell all of them individually, we counsel them that IVF is not a 100% procedure. The indicated cases, you need IVF, then only we do IVF, and that सक्सेस ओनली 45%. सो अगर आईवीएफ का सक्सेस ही 45% है तो सबसे पहले वो थोड़ा करेंगे. We'll try to do ovulation induction, we'll try to do intrauterine insemination, and if that doesn't work, then we'll assess the endometrium by hysteroscopy, and the endometrium should have normal proliferation and no endometritis, and then we go for IVF. IVF is the last thing. अगर IVF 100% होता तो मैं सभी का कर देता ना. 100% है, अरे यार तेरे थोड़े पैसे लगेंगे, पहले IVF कर देते हैं. IVF is also not 100%. So that's why don't say IVF first. First, try to do the normal process of checking the tubes by laparoscopy and hysteroscopy, because HSG is blocked. So let me just show you a little bit about HSGs. So let me show you the first picture here. Is it working? एक मिनट स्टॉप करके शुरू करते हैं. Yeah. So normal HSG, if you see, the uterus gets opacified with the dye, and the tubes, you can see the thin tubes, and the spill is there on both the sides. Now see the next one. Next one, I am doing the HSG. In the next one, the dye has gone inside. Look here, this is around 4-5 days back. Yes, 19th of June, you can see 19th of June we have done this. So this one, we are not getting the dye to come out. So this is a cornal block. You think I did IVF for her? I posted her for laparoscopy next month. Yes. So first we do a laparoscopy, and if a laparoscopy shows me a blocked tube, many times we push the dye with a lot of force, because laparoscopy the patient is totally anesthetized, and when the patient is totally anesthetized, what you can do, you can push the dye with force. It still doesn't open, then I can go inside the uterus. I can go with a hysteroscope, and with the hysteroscope I have a cannulation tube. I can go into the tubes and open this cornal block. The cornal blocks are the easiest to open. Okay, if there's a terminal block, then we don't try to open also, because the tube is very badly damaged. If it's a cornal block, I can open it also. So many times we've done that. So if it is a blocked tube, let's do a laparoscopy and a hysteroscopy. Right. तो ये हो गया. Now what is the dye I used? Yes, ये dye में तुम लोग गड़बड़ करते हो. अब इसमें मिथिलिन ब्लू मत बोलना यार, ठीक है ना? There is no methylene blue here. You don't see any color. This is a recording, live recording, so there is no color in it. ये color में ही recording किया है, phone से recording किया है मैंने. So don't say that it is methylene blue. The dye used here is meglumine. The dye is meglumine dye 308. Okay. Tazografin, urografin, these are trade names. Nobody is asking you trade names in anything in pharmacology or in any drugs in medicine. Meglumine diazoate. Now laparoscopy. In laparoscopy for the dye test, there is the dye methylene blue. Methylene blue is used for the laparoscopy, ठीक है? Not for the HSG. Methylene blue for laparoscopy and dye test. Right. Okay. Identify the findings in the hysterosalpingogram. Okay, I'll come here. What is happening in the hysterosalpingogram? You're seeing the dye has gone into the uterus, uterine shape, you can see nicely here. But look at the tube. The tube is looking like a big bag kind of thing. So yes, the tube is having fluid accumulation and there is no spill. Can you see there is no spill here? We cannot see any spill here. There is no dye spill. So tube is blocked, and if I put dye, the tube is getting filled up. It is making a fluid filled tube. Fluid in the tube, hydrosalpinx. So that is what is a hydrosalpinx. Okay. Yes, it becomes as big as a bag sometimes, you know. Oh, sorry. It becomes like a tobacco pouch, they say. एक pouch के जैसा बन जाता है इसमें, जिसमें आप एक तंबाकू रख सकते हैं. So that is what is a tobacco pouch, hydrosalpinx. Yes, I think I don't know, where's the tobacco pouch gone? Yeah, I think it is here. Yes. See, it looks like this. See, exactly like this. That's a tobacco pouch. Yes. See, this is exactly what a tobacco pouch looks like. Yes, of course, I don't take tobacco. This is a pouch in which somebody gave me a gift. If that doctor is watching this, thank you so much. It's a brooch the doctor gave me. So, thank you so much. And that's a tobacco pouch. Anyway, so this is a bilateral hydrosalpinx. Okay, bilateral hydrosalpinx and tobacco pouch hydrosalpinx you see in a case of tuberculosis, tobacco pouch hydrosalpinx. Now, what should be the subsequent course of action in a case of a hypertensive and diabetic woman of 49 years presenting with irregular vaginal bleeding for last 6 months and not responding to regular treatment? Now, this is that hot shot question of the evening. Irregular bleeding, and the question is between 40 years to 50 years. There is only one thing. Examine the woman, and if the vulva, vagina, cervix, what all you can see in the OPD? Yes, uterus, vagina. So, what you can see in the OPD? In the OPD, you can see the vulva, you can see the vaginal canal with the speculum, and under the speculum, you can see the cervix also. So, you can see the vulva, vagina, and the cervix. So, examine the woman in the OPD. Examine the woman in the OPD, and you see vulva, vagina, cervix is totally normal. Then, what is the next thing you can do? Next thing you have to do in the OPD itself is go into the uterus with a very small, very thin, you know, like a pipe. You can take a very small pipe, you can take and go into the uterus and take a biopsy. A very thin pipe which has a cut on it, that is known as a Pipel biopsy. You can take a biopsy in the OPD. So remember, if a woman has irregular bleeding, the first thing is a endometrial sampling. Remember, endometrial biopsy. And do not, for God's sakes, don't say hysterectomy. पता नहीं क्यों ये आंसर तुम लोग देते हो. Irregular bleeding in a 49-year-old woman, hysterectomy. अरे यार, she could be just having some endometritis. Treatment is antibiotics. She could be having hyperplasia without atypia. Treatment is to give just progesterones. It could be an anovulatory endometrium that happens regularly in a woman who is 47, 48, 49. Anovulation hoga. So please try to stop the bleeding by NSAIDs and tranexamic acid. That is different. So what is the management? Always do the endometrial biopsy first. So yes, let me just write that for you. I want all of you to remember this. Irregular bleeding, and the woman is around 40 to 50 years. Mostly this is the question which you get. So do endometrial sampling. You do an endometrial sampling. You will also get a choice sometimes like endometrial histopathological examination, or you will get a choice like endometrial biopsy. Any one of these choices, you know, all of these mean the same. One of these you're going to do. What is the method of endometrial sampling? You can do a Pipel. You can do a Pipel biopsy. Pipel biopsy, OPD basis, and it is very simple, painless procedure. Small, exactly जैसे आपको refill होता है ना पेन में जो ball pen की refill है, just as thin as that. Put it into the uterus. It is very painless OPD procedure. It is 80 to 90% sensitive. And you can also do a DNC, that is done in the OT, obviously under anesthesia, or you can do a hysteroscopy, hysteroscopic biopsy. That is also done in the operation theater. Of course, it can be done on in a daycare basis. She comes to the OPD, irregular bleeding, so we plan, okay, तुम्हारा hysteroscopy biopsy कर देंगे. We don't have to admit her. We give a IV anesthesia, total intravenous anesthesia we can give, TIVA, which you people have been taught, and with that we can do a hysteroscopy, and by evening, afternoon, she can go home. So this is the method of what you have to do with irregular bleeding. Examine the woman, rule out local lesions. If there are no local lesions, do a endometrial sampling, endometrial histopathology or endometrial biopsy. How you do this? PPL, DNC, hysteroscopy. And hysteroscopy is the best assessment. This is 100% sensitive. 100% sensitive. Matlab, if there is endometrial hyperplasia, you'll diagnose it 100%. If there is endometrial cancer, you'll pick it up 100%. If it is there. Okay, DNC is 95 to 99% sensitive. तो ये आज का सबसे इंपॉर्टेंट क्वेश्चन है, बता रहा हूं गायनी में एटलीस्ट, वेरी इंपॉर्टेंट क्वेश्चन. ओके, डोंट गेट दिस रॉन्ग. Best option is always hysteroscopy. Yes, that's a good question you asked. Okay, chali, let's move on and see something else. A woman has persistent amenorrhea. A woman has persistent amenorrhea after curettage was done 4 months back for her for a 10 weeks abortion. FSH is 3 international units, which is normal. 2 to 6 is normal. And TSH and prolactin levels are also normal. Ultrasound shows a normal size ovaries with a dominant follicle. So ovary में भी ovulation हो रहा है, मतलब dominant follicle मतलब ovary is working and a follicle is formed, so it is making estrogen. What is the likely diagnosis? So she had a curettage 4 months back and now she is not having periods. And hormonal profile is normal, ovary is working, there is a follicle, why still not having? So yes, that is because there is a Escherman syndrome. Uterine synecdoche is also known as the Escherman syndrome or the uterine adhesions or uterine fibrosis because of overzealous curettage. Pituitary failure will not have a normal ovarian function and formation of the dominant follicle. Ovarian failure, again, there will be no growth of the follicle. Pregnancy, ultrasound में दिख जाएगा, ठीक है ना? तो हमने जब abortion कर दिया है तो ongoing pregnancy भी हो सकता है, but ultrasound में they have not mentioned that to you. All right, adhesions. So what is the best diagnosis? Escherman syndrome. Escherman syndrome, the best diagnosis, please do not get this wrong. Do not say HSG. There is a wrong tendency of you to say HSG. Best diagnosis by a hysteroscopy. ये simple questions आते हैं exam में. And treatment is also hysteroscopic. Hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis is the treatment. And after that, after doing the adhesiolysis and the pink tissues, when I see, I stop the procedure all over the place, all over the uterus, I have to take out the adhesions. And after that, post-op, I give a high dose of estrogen progesterone to rebuild the endometrium. See, normally also she is making, but I give very high dose of estrogen so that the endometrium definitely rebuilds. Mostly we are able to help patients. They have had periods and Escherman syndrome के बाद periods कम से कम आने लग जाता है. But yes, a lot of them have very badly destroyed lining. So period शुरू हो जाता है, बाद में pregnancy होगी कि नहीं होगी, उसमें थोड़ा सा problem होता है. Not everything is so clear. Right now, I am having a patient who is having Escherman syndrome. She came to me around January 2026. I did a procedure in January and gave a high dose of estrogens. From March, she's having regular periods now without any drugs. High dose estrogen progesterone diya. From April, she's having periods. But I've done 2 cycles of IUI. The second one has just been done. First one failed. I hope the second one works. And remember her in your prayers. Maybe when she gets pregnant, आ रहे हो ना पार्टी के लिए, तब मैं आपको बताऊंगा. PW में जब पार्टी हो रहेगी, we'll discuss that patient also. ठीक है, चलिए, let's move on and see something else. A 20-year-old lady presented with a complaint of irregular spotting and also of postcoital bleeding. Irregular spotting and postcoital bleeding. देखो, postcoital bleeding, you're already thinking of CS cervix, I know that. On post-spectral examination, the following is seen. It bleeds on touch. What is the possible diagnosis? तो cervix के ऊपर एक छोटा सा एक lesion है यहाँ पे in the internal os. एक और picture दे दी. ये cervix है, एक छोटा सा यहाँ पे cervix पे एक growth है. It is a very smooth growth and it is not growing from the tissue of the cervix. तो आप लोग सब लोग कह रहे हैं polyp. I'm so happy you're saying cervical polyp and most of you are not saying cervical cancer. Please remember, postcoital bleeding can happen in many other conditions. Then, yes, what is the most common presentation of CS cervix? Postcoital bleeding. but postcoital bleeding can happen even with a polyp. So this is classically a polyp, okay? This is classically a polyp. Yes. So let me show you something. This is a normal cervix. This is what a normal cervix looks like. And this is what is a cancer cervix. Can you see? There's a growth. So cancer cervix, you will not miss. You know, this is a huge proliferative growth on the cervix, and you cannot miss this growth on the cervix. Okay, cancer cervix ऐसे दिखेगा. It will be irregular proliferative growth, will be cauliflower type of growth, and friable growth होगा. You know, when you're doing a PV so many times, she starts bleeding with my PV, and in my fingers I'll get some tissues of the फ्राइबल ग्रोथ. मेरी फिंगर्स से टूट के बाहर आ जाता है और उसको और ब्लीडिंग हो जाती है. तो वी जनरली पैक द सीए सर्विक्स. तो एग्जामिनेशन करते हैं हम लोग, बिकॉज हाउ डू यू डू द असेसमेंट ऑफ सीए सर्विक्स? द स्टेजिंग इज डन क्लिनिकली. तो पीवी करना ही पड़ता है टू सी द वेजाइनल इन्वॉल्वमेंट, and then do a per rectal examination to see the parametrial involvement. So that's why you'll know a friable growth, and polyp is a very smooth growth. So that's why I'm sure. Does CA cervix happen in old age or any age? CA cervix generally doesn't happen after 65 years. If it has not started, till then it will not start after 65 years. It can happen in young women also, but it happens only after sexual activity starts, because HPV gets into body after sex. I mean, mostly that is what is correct. More than 99% of patients will have that story, that sexually active, HPV goes inside, and changes start happening after 3 to 4 years. That's why we do pap smear after 3 years of sexual activity. Right. So common confusion sorted. Let's see. अब यहाँ पे मेरे को थोड़ा सा आपको समझाना है, ध्यान देंगे, गड़बड़ नहीं करेंगे, ठीक है? सो सी एंडोमेट्रियम का मोस्ट कॉमन प्रेजेंटेशन क्या है? सी एंडोमेट्रियम का मोस्ट कॉमन प्रेजेंटेशन इज इरेगुलर एसाइक्लिक ब्लीडिंग, विच इज आल्सो नोन एज मेनोमेटोरहेजिया. मेनोमेटोरहेजिया. Then in a menopausal woman, it is postmenopausal bleeding. So yes, CA endometrium comes with irregular acyclic bleeding, but if the woman is menopausal and has CA endometrium, she can come with postmenopausal bleeding. Now, what is the most common presentation of CA cervix? CA cervix most common presentation is postcoital bleeding. You know that very well, but this can also come with postmenopausal bleeding. So पहले तो ये पढ़ लो, फिर postmenopausal bleeding के कारण क्या है वो भी पढ़ाना है. That is, उसके बिना तो तुम मुझे छोड़ोगे नहीं. Yes, we have to read that. So CA endometrium, irregular acyclic bleeding. CA cervix, postcoital bleeding. Both can have postmenopausal bleeding. ये खत्म हो गया. अब woman comes with postmenopausal bleeding, what is the most common cause? वो अलग क्वेश्चन हो गया. If I'm telling you CA cervix का presentation क्या है, CA cervix can happen even at 30 years, 35 years, and most common presentation at that time will be postcoital bleeding. Now, I'm asking another symptom. Postmenopausal bleeding का सबसे कॉमन कारण क्या है? तो वो गलती नहीं करना. गलती करोगे भी तो बैठा हूं तो मैं आज समझा के भेज रहा हूं, और इसको अच्छे से समझना. तो मोस्ट कॉमन कॉज इन इंडिया इज सीए सर्विक्स, और कोई कारण नहीं है. अब अगर इंडिया नहीं पूछा है, मोस्ट कॉमन कॉज पूछा हुआ है, तो भाई तुम इंडिया का एग्जाम लिख रहे हो, एमसीआई लिख रहे हो ना, नीट पीजी लिख रहे हो ना, आईएनएससीटी लिख रहे हो. कहां पे मिलेगी सीट अगर पीजी एंट्रेंस लिख रहे हो इंडिया में? वे विल यू गेट द सीट? इन कनेटिकट, इन बॉस्टन, सेंट्रल लंदन में पीजी मिलने वाला है तुम्हें. इंटर्नशिप तुम लोग कहां करोगे? मेडागास्कर में करोगे. अरे यार, हमें बताने की जरूरत नहीं है. व्हेन वी आर आस्किंग यू एनीथिंग, इट इज मेंट ओनली फॉर योर कंट्री. व्हाई डू यू हैव अ डाउट इन दैट? नहीं सर, जब नाम नहीं लिखा हो तो वर्ल्ड का पूछते हैं. अरे नहीं भाई, इंडिया का ही पूछते हैं हम आपसे. अभी वर्ल्ड का मतलब क्या है वो भी पढ़ा रहा हूं. तो गलती मत करना प्लीज. व्हेन वी आस्क postmenopausal bleeding, we mean only for India. Yes, and India it is CA cervix. If I don't write India, it's still CA cervix. Now, most common in Western countries, developed world, which is only 15 to 20%. If a woman in London comes to with postmenopausal bleeding, she's taking HRT regularly. So 30% can be HRT, but it can also be something called endometrial atrophy in the West. We Indians also have endometrial atrophy, but not as the commonest cause. So it can be an atrophic endometrium. An atrophic endometrium can get infected easily, and that presents as senile endometritis. So yes, in the Western data, in my novice gynecology, it is clearly given that in their country, 60 to 70% of patients who have postmenopausal bleeding will have senile endometritis. They'll also have hyperplasia of the endometrium. It can be hyperplasia of the endometrium as a cause, CA endometrium as a cause. इन दोनों को मिला के 10% each है, around 20%. It can be hormone replacement therapy in around 25 to 30% of cases. It can be HRT also, because women in the West take HRT. In our country, HRT penetration is hardly there. In every live class, if some of you are my students from the live classes, you know that every class I make you raise your hands if your relatives are on HRT. And every batch, you know, I think in 6-7 batches, some 2 or 3 hands will get up. Total, I'm saying. So in this session which I did classes, out of the 4,000 odd students we would have been in touch with, 2 students raised their hands. Yes, of course, 2 more students raised their hands, but their relatives are my patients. So totally 4 out of 4,000. ठीक है ना? It is less than 0.01% the penetration of HRT in our country. In doctors, तो common population में क्या होगा तो आप समझ ही जाओगे. So HRT is not common in our country. So these are Western datas. Western data से confuse नहीं होना है. All right? चलिए. तो India लिखा है तो CA cervix, India नहीं लिखा है तो C cervix. I'm showing you the Western data from Novak's Gynecology, 16th edition. This is an American data, and endometrial atrophy is 60 to 80%. Hormone replacement therapy is 15 to 25%. Polyps, hyperplasia, endometrial cancer around 10%. And CA cervix mentioned ही नहीं है क्योंकि it's a lifestyle disease. They have a lot of intercourse, they have a lot of infected intercourse, but they regularly come to the hospitals. Anything goes wrong, they are coming to the hospitals regularly. So CA cervix से पहले, in the stage of CIN, we treat them in West. So they don't have so much of CA cervix as much as we have. Now, what is the Indian data? Indian data, I've shown this to you many times. Those who are seeing this lecture for the first time, this is the Indian data. I'm showing you from a journal, and Indian doctors have given this data about India. So I'll just highlight this part. This part I'll highlight, the result I'll highlight to make you understand the Indian data, that part. You know, this part is magnified here, the result. Exactly, it's a photo which has been magnified. That's why it's a little blurred. So result number 3, histopathology was sensitive atrophic endometrium only in 2.3%. Endometrial hyperplasia 6.4, C endometrium 12.2%, proliferative endometrium 9.4, endometrial polyp 2.9%, and CA cervix 39.5%. Indian data. What is written? The result, conclusion. Most common cause of postmenopausal bleeding in India is CA cervix, and the histopathology of squamous cell carcinoma, large cell keratinizing type, large cell keratinizing type. इससे क्लियर हो क्या दिखाऊं यार तुम लोगों को? तो हम आपसे वेस्टर्न डेटा नहीं पूछ रहे, वी आर आस्किंग ओनली इंडियन डेटा. Well, I've taught you this many places. I've had a separate lecture on postmenopausal bleeding in the app with PW. Now I'm showing you one more thing. Last thing, most common in the world. Nobody's going to ask you this question first of all. Most common in the world. But पूछ भी लिया तो क्यों डरते हो? पूरे वर्ल्ड में कैसे लोग ज्यादा कॉमन है? White people are the commonest in the world. अरे you and me, we are the commonest people, 140 million. Huh? So many of us Indians are there in the world. We are the most populous country in the world. And China, India and China is 55% of the world population. So yes, developed countries account for roughly only 15 to 25% of the world. Developing countries are around 60 to 75% of the world. And underdeveloped nations are around 10 to 15%. So developed is only 15 to 25%, and the developing countries, this is, I think your PSM people also teach you this, the demography. So developing countries and underdeveloped, together they make 80% of the world. Developing and underdeveloped, 80% of the world. तो हमें क्या होता है? Developing and underdeveloped को हमें CA cervix होता है. That's all. कितना सिंपल है यार. कोई नहीं पूछेगा आपसे वर्ल्ड का डेटा. अगर पूछ भी लिया तो क्यों घबराते हो? People like you and me, China and India, we are the commonest in the world. And then Afghanistan, Pakistan, Bhutan, Sri Lanka, all of these are people like us. So yes, please do not. But the answer was senile endometritis? No man, answer was not senile. इतना पढ़ा दिया उसके बाद भी senile endometritis बोलना है तो जरूर लिखो यार. Answer is not senile endometritis. Come, I'll show you. Okay, what I taught you? Yes, in the of course, that question is not discussed here, so that's why. So yes, it is not senile endometritis. In India, we have to say any question comes to you, it is CA cervix. Please don't get that wrong. And if they don't give you CA cervix as a choice, matlab that will be I mean, I'll be surprised. A question comes without CA cervix as a choice. Maybe they ask you the Western data. That also I've given you. Western data है तो लिख देना senile endometritis किसने मना किया? वो तो मना नहीं कर रहा हूँ मैं आपको. Go ahead and write. Okay. But it is CA cervix. I mean, ये सब ना तुम जब जाओगे ना internship में, जब घुसोगे अभी 3 महीने बाद, all of you doing internship, you get into the gynae OPD. If you're in the government hospital, first day you will see CA cervix. And पूरी internship खत्म हो जाएगी. मैं बता रहा हूँ. Please, on the same forum, you answer back, okay? PW Marathon, June 2026. इसके नीचे दिखाना मुझे 3 महीने के बाद, write and tell me. In 3 months of your gynae posting, if you see one case of senile endometritis, you write to me. Yes, those who are regularly working interns, all of you in a government hospitals, if you see one case of senile endometritis, you write to me on this same forum. Yes. अच्छा, I'm not saying you will not see at all, but you are saying it is the commonest ना, तो एक भी देखोगे तो मुझे बता देना. But CA सर्विस सब देख लोगे, सब देख लोगे, विदिन 1 वीक देख लोगे, ठीक है? तब ये सब बोलोगे यार हम लोग कितना इस पे टाइम वेस्ट करते थे. एनीवे, इस बार भी हो गया टाइम वेस्ट, आगे बढ़ते हैं. चलो, लेट्स सी समथिंग एल्स. Contraindication of the device shown in the image. Yes, see, this is a copper device. Any IUCD also, they will say, what is the contraindication? Previous ectopic pregnancy is not a contraindication, please. Ectopics बढ़ते नहीं है, pregnancy नहीं होती तो ectopic भी नहीं होती है, ectopic बढ़ेगा नहीं, please. Okay, what are you writing? Let me see. I confirmed with 2 friends. Question bank is not made by. Okay, चलो आगे बढ़ते. Okay, so previous ectopic is not a contraindication. Nulliparous woman is also not a contraindication. I don't know why do people say, if a woman does not have child, she chooses not to have a child and she is married, she is sexually active, can she not take IUCD? I don't know why you say that. ये भी एक wrong है, wrong notion चल रहा है. Nulliparity में IUCD नहीं डाल सकते. क्यों नहीं डाल सकते हैं? रेगुलरली डालते हैं हम लोग. मतलब नलिपैरिटी तो मतलब अगर वेस्ट में तो नलिपैरिटी होती. पीपल इन द वेस्ट डोंट हैव मेनी चिल्ड्रन वेरी अर्ली. दे हैव चिल्ड्रन ओनली व्हेन दे आर 35-40, बट दे एक्टिव एज अर्ली एज 20. So 20 to 35 till they have the first child. For this 15 years, no Westerner will use IUCD. Please, nulliparity, you can give IUCD, no contraindication. Hypertension, if it is controlled, even uncontrolled, what is the problem with an IUCD? No contraindication. Active PID, you should not give. Active PID, you should not give. So, what is the medical eligibility criteria? This is there for all the contraceptives. One means no contraindication to this method. Like a woman is having one child, she wants an IUCD, there is no infection, she has regular periods, can I give IUCD? MEC1, आराम से दे सकते हैं. A woman has deep venous thrombosis, can I give her OC pills? No, you cannot. MEC4. So OCPs में क्या हम DVT वाले patients को दे सकते हैं? No, we cannot. It's MEC4. So MEC1 you can easily give, MEC4 cannot give, and 2 and 3 are in between that. Have a look on this. I'm telling you, medical eligibility criteria may come in the exam. Definitely in the NEET exam they've asked. So what is the medical eligibility criteria when we're talking of IUCDs with ectopic? This is what I'm teaching you. IUCD with ectopic. Past ectopic pregnancy. To start, it is MEC1. To continue, it is still MEC1. What is the meaning of this? If a woman had previous ectopic pregnancy, can she have an IUCD? MEC1, no contraindication. If she is having an ectopic and still an IUCD is there in place, she can continue. Still it is MEC1. This is from the AUGD. You can read, go online, AUGD bulletin, which is that time, that year. You can go online and see. I think 2021 या 2022 का October November का edition है. Online it is available. AUGD, you can read it's a free booklet, and that year the AUGD was under the Amesonians. Okay, and that's a very good book. You should read that. So all these confusions will go out of your head. Okay, there is no contraindication. Chali, for ovarian malignancy, active PID is the answer, correct. For ovarian malignancy management, all of the following can be done for treatment with good results, except. So they are asking which of the following cannot be used for the management of ovarian malignancy. Debulking surgery can be done. Adjuvant chemotherapy is chemo after surgery, and neoadjuvant is chemo before surgery. neoadjuvant. This came as a MCI question some, I think 2-3 exams back. Radiotherapy is not given. Radiotherapy is useless as a primary treatment in ovarian cancer. The only radiosensitive, RSM writing, only radiosensitive ovarian tumor is dysgerminoma. But the most common cancer is not dysgerminoma. Most common cancer is epithelial ovarian cancer, and in that also serous cystadenoma and serous cystadenocarcinoma are the commonest. So radiotherapy is not used for that as a primary treatment. Yes, it can be used for metastasis from ovarian cancers and all that, it can be used, but not for this. Only radiosensitive ovarian tumor is the dysgerminoma. Right. A 16-year-old girl presents with cyclical abdominal pain and primary amenorrhea. Favorite question in MCI. Local examination of the patient is seen in as in the picture. Oh, I'm hiding myself the picture, I think. What is your diagnosis? So you can see that the girl has primary amenorrhea. She's 16 years and she's not having periods. When I examine, you can see the hymen is not open, but the hymen is bulging, you can make out. So this is obviously a case of a imperforate hymen presenting as a primary amenorrhea. It is not a Bartholin cyst, it's not a polyp, it's not a sebaceous cyst, it is bang in the middle of the perineum. So that is the imperforate hymen. So imperforate hymen and transverse vaginal septum, that is sometimes you get confused. So when there's an imperforate hymen is here at this stage and transverse vaginal septum is a little higher. So when there is an imperforate hymen and a transverse vaginal septum, similar symptoms can be there. But in an imperforate hymen, see here, there will be bulging of the hymen. But here in a transverse vaginal septum, you will see the lower part of the vagina will be normal and there will be a bulge higher. So what we can do with a per rectal examination, we can distinguish. This question came in NEET, that when you put a finger in the rectum, of course you can't do a PV because the vagina is blind. So put a finger in the rectum, you will see a bulge throughout the vagina. That is imperforate hymen. When you do a per rectal examination, you will see the bulge only in the upper part of the vagina. So with the PR, you can make a distinction between the imperforate hymen and the transverse vaginal septum. So yes, this is a case of imperforate hymen, and we are doing what we keep telling you, a cruciate incision. Yes, we're doing a cross-shaped incision. This is happening in my hospital. My fellow doctor friends are doing this. We are recording this here, and you can see just a cross-shaped incision like we always say. And when you make this cross-shaped incision and then you deepen it, you'll see that the pent-up blood will come out. Yes, all that pent-up blood. She was not getting periods for the last, from 12th year, and she was 16 years not getting periods. Almost 2,400 ml of 2,200 ml of blood came out, the menstrual blood in this patient. A lady is diagnosed with recurrent genital infections. In which of the following condition does a male partner need to be treated? Yes, male partner needs to be treated. In trichomoniasis, definitely. Herpes genitalis also. So there is a problem here, that when there is a herpes, the preferred treatment is to give to the partner also. So that थोड़ा सा गड़बड़ हो गया यहाँ पे. दो आंसर हैं, but trichomoniasis is the better answer. Bacterial vaginosis, candidiasis, you don't have to treat. Okay. Now herpes also you will give, but yes, trichomoniasis definitely, because herpes may not transfer, but trichomoniasis 70% chance. So out of these two, I will say 70% chance. One act of intercourse. If a couple have intercourse and if the woman has trichomoniasis, then the chance of transfer is as much as 70%. So answer is trichomoniasis. Something else I want to tell you. Bacterial vaginosis, there is a new development that it is better to treat the man also. There is a trend now to say that. Many journals, they are talking about it. If you do a PubMed search on the NCBI, you will get to know a lot of journals are saying that we must treat the man also in a case of bacterial vaginosis. Well, let that recommendation be accepted by my country, or at least come in the books like Shaw's and Novak's. I'll teach you that. There are recommendations. Latest update आ गया. तो अगर if they are asking you latest update क्या है bacterial vaginosis के बारे में, go ahead and write that man can also be treated. But nobody is going to ask you a question like that. We'll ask you pakka basic core principles, and the core principle is you should treat only the woman and not the man in a case of bacterial vaginosis. Basics आते हैं भी. आपसे जो हम लोग के PG लेवल पे जो डिस्कशन चल रहा है वो तो बहुत कुछ है. Endometriosis, nobody operates these days, medical management. But we are teaching you primarily do the surgery, get your diagnosis done by laparoscopy, and then give the suppression. That's what we're teaching, because that is still the core basic teaching. What we do in the postgraduate level, what we do on latest updates, what my PGs keep teaching me after reading new journals, then what my fellows of IVF they teach me, because they read more than us. And then we have clinical meetings on obviously at least 3-4 times a week. So we will keep learning with them and keep discussing. All that is not for the basic MCI and PG entrance exam. So remember, bacterial vaginosis is the new update, but remember, only the woman has to be treated in bacterial vaginosis. That's the bottom line. And trichomoniasis, both man and woman. So yes, Amsel's criteria is used for which of the following conditions? Amsel's criteria having 5 findings is used for the bacterial vaginosis. Yes, all of you know that. And I think your microbiologist friends will also teach you something called the Nugent's criteria. That Nugent's criteria is also for the bacterial vaginosis, but the Amsel's criteria is the one which is used. All right. So in that Amsel's criteria, we have the clue cells, alkaline pH. This is the clue cells, the vaginal epithelials with embedded bacteria, clue cells and alkaline pH, whiff test, creamy discharge, and the fishy odor. All these 5 are the criterias, and any 3 or more, 3 of these and more is diagnostic of the bacterial vaginosis. Of course, there will be absence of leukocytes in the vagina. That's what can also happen in bacterial vaginosis. Absence of leukocytes. You will have a lot of clue cells. Right. So clue cells. This is the clue cell here. Some other things I thought I'll tell you. This is the flagellate trichomonads. 30 to 40 microns in size होते हैं ये. 30 to 40 micrometers, okay, microns or micrometers. So they'll be running up and down in the vagina, causing a lot of itching and irritability. So that is going to cause this red macules. So we call this the colpitis. We call it the colpitis macularis. Colpitis macularis, which is basically colpos. Colpos infection is known as colpitis. So colpos is known as vagina also, so vaginitis with red macules. These red macules are known as the strawberry cervix. Yes, the vagina is also with strawberry. Cervix agar strawberry, to vagina mulberry nahi hoga bhai, hai na? Don't get confused with these things. If the vagina is looking like a strawberry, the cervix also look like a strawberry. Both can be there in trichomoniasis. Okay, so colpitis macularis. Okay, that is what is seen in trichomoniasis. Yes. चलिए आगे बढ़ते हैं. Oh yeah, this is the complete chart which I always give you in my classes, and now here also. Most common vaginitis is bacterial vaginosis, and this is the Amsel's criteria: the alkaline pH, creamy white discharge, fishy odor more after sex, and whiff test. When you add potassium hydroxide, it releases amines, the secretions in bacterial vaginosis, and the clue cells. So, oh sorry, ये तो आ गया here. And the clue cells here. So these 5, any 3 of these, 3 or more is diagnosis, and the treatment is metronidazole. The man is not treated, only the woman is treated because there is no sexual transmission. Trichomoniasis is also alkaline pH. It causes the colpitis macularis and it causes severe pruritus, but there is no itching. No itching in a case of bacterial vaginosis, and the treatment of trichomoniasis is also metronidazole, both man and woman. Now, candidiasis, it is a curdy white discharge and it has got a lot of itching again, and the diagnosis by Sabrot's rectus agar, also by nucleic acid amplification test. Remember, local antifungal is better rather than switching to oral antifungals first. We always say local creams and local tablets are better than giving oral. But yes, only approved oral drug is the fluconazole. And what is complicated candidiasis? Complicated candidiasis means candidiasis by non-albicans species. So Candida gibraltar tropicalis, difficult to treat and it is recurrent, and it is by immunocompromised. It is seen in immunocompromised people like HIV and pregnancy and chemotherapy patients, diabetes patients. All right, see, have a look on that. With cuff impulse, in a imperfect hymen, obviously you will not see the cuff impulse, and in this you may see. Correct, that's fine. But अगर थोड़ा सा नीचे वाला transvaginal septum होगा तो वहाँ पे भी confusion हो सकता है. So I rely more on the per rectal examination. A nulliparous woman at 19 years presents to the OPD with uterine prolapse. 19-year-old girl, nulliparous. So she is not delivered, it's a nulliparous prolapse. No cystocele or rectocele was noted. What procedure you will perform? So yes, if the uterus is hanging out, you will pull the uterus back inside with a rope. You tie a rope. So this uterus, you can see that if this my hand is the sacrum, this is the uterus which is out in prolapse. So what do? You take a rope, tie it to the uterus and pull it inside, and pull it inside and tie it to the sacrum. So when the uterus goes inside, you can take a rope, tie it here to the cervix and tie it to the sacrum here. So that is what is a sling surgery. So sling surgery, okay, the abdominal sling surgery is the best one. Now Shirodkar's many surgeries are there, so that's why giving Shirodkar here may confuse you. There is a Shirodkar sling also, there is a Shirodkar's cerclage also, there is a Shirodkar vaginal hysterectomy also. I think these choices were just recalled by my student friends, maybe, but remember, one of the types of sling is the Shirodkar sling. The most common sling is the sling which is tied to the sacrum, which is the Shirodkar's. So yes, if you said Shirodkar C and D, both are correct, but Shirodkar sling should have been given as the choice. And what is the Fothergill surgery? It is also known as the Manchester surgery, and that is done for women who want to preserve the uterus. So we do tightening of the ligaments. They have one child, they want to have more children, but she has a prolapse, so we do a Manchester repair or a Fothergill's repair. Now Leafold's repair is done for older women who cannot withstand a major surgery. Vaginal hysterectomy नहीं करा सकते. Hysterectomy के लिए जब anesthesia देंगे तो माता जी की तबीयत खराब हो सकती है. She can not withstand the anesthesia itself, forget the surgery. So when there is a old debilitated woman, then what we do? We make a double barrel vagina. So the vagina suppose is like this and the uterus is coming out. So we push the uterus back inside and we make this big vagina, we make it a double barrel vagina like this. So double barreling surgery we call it. The Leafold's repair is called the double barreling surgery. All right, so that is done for old women, unfit for surgery. Some relief will be there because of this double barreling, or we also call it partial closure of the vagina, partial colpoclysis. That's also a word which we use for this Leafold's. So yes, sling surgery is the best for this patient. What is the location of the Bartholin gland? This was also a question which came in the exams. Medial one half of the vulva, junction of the anterior 2/3 and posterior 1/3, junction of the anterior 1/3 and the posterior 2/3, and lateral 1/2. So remember, this question has come in the exam, and it is the anterior 2/3 and the posterior 1/3 of the vulva. Okay, so if you see the vulva here, the opening of the Bartholin gland is here. You know, Bartholin gland will lubricate during intercourse, and if you see this, this is the anterior. Don't say superior 2/3 and inferior. Anterior and posterior, anterior and posterior 1/3. So this is the place where you see the opening. Bartholin gland, the epithelium of the gland, the Bartholin gland epithelium is the columnar epithelium, and of the duct is transitional to squamous. That is, the beginning of the duct will be transitional and the tip might be squamous. So gland is columnar and the duct is transitional to squamous, and if there is a Bartholin abscess, we say marsuplize it. You know, any abscess, you are taught that you should do a incision and drainage. So suppose there is a Bartholin's abscess, you make an incision and let the pus come out. Now the vulva will be between the legs, and the vulva, this incision may get closed and may stick each other, the cut edges may stick to each other, may cause another abscess very soon. So what we do, we make an incision and the pus comes out, and then we evert the edges. We tie the edges to the vulval skin so that the edges are always open, so that this cavity is exposed. So it will slowly, over the next 2-3 weeks, it will dry up. So marsupialization is the better answer for Bartholin abscess. Marsupialization, that's the word which we use for Bartholin's abscess. Right. Where is ovoid? Where are, rather, grammatically wrong, where are ovoids and tandem used in radiotherapy? Ovoids and tandem. This was a NEET exam question. So ovoid and tandems are the radiation brachytherapy methods. How do we insert the radiation into the to give for the CA cervix? So yes, it is for cervical cancer. These two words are used. So what are the ovoids and the tandem? So tandem are the rods. Tandem are the rods in which we put the radioactive pellets. We put the radioactive pellets here in this. Earlier it used to be cesium, nowadays we say cobalt, and iridium also is used. And then we have the ovoids. These are the tandems and these are the ovoids. Yeah, tandems and the ovoids. So yes, radiation for cancer cervix. The modern standard is now to give the high dose radiation by brachytherapy. Brachytherapy means therapy from inside. Teletherapy means tele means from far, television, dur se vision na. So teletherapy is from outside, brachytherapy is from inside. So when we do high dose radiation, that is brachytherapy, primary source is nowadays iridium, but alternative source is cobalt 60. Yes, traditionally it was low dose brachytherapy and then cesium was the source. So generally they don't ask you what source is used, because a lot of people still prefer using the low dose for many days it's given. Okay, so that is the cesium source. So yes, the latest is to use iridium. So generally what can be used as a treatment, one of these choices will come. Mostly cobalt and cesium are the choices, and cobalt is more recent and cesium is the traditional method of giving radiation. Which concentration of ethanol, I think it's a little small in font, I'm sorry, I'll read it for you. Which concentration of ethanol is used as a fixative in conventional pap smear? So fixative for pap smear is ethanol. It is not absolute alcohol, it is 95% alcohol. So don't say 100% ethanol. A lot of people say 80% ethanol also. No, it is 95%. So not this, 95%. So when you're using a pap smear, you have this Coplin's jar. This is the Coplin's jar. Coplin's jar to hold the slides. There are ratchets here. So when you make a slide, those slides when you make, you put them, they are vertically held in this, and this has the 95% alcohol. You will immediately, moment you make a smear, immediately put it into the jar. No drying. If you dry it, then the cells, the epithelial cells of the cervix will get spoiled. So we'll do the Coplin's jar in which the slides are put. Okay, and this is the Ayer spatula. So what is this assembly used for? It's used for pap smear. This question also came in the exam. Now, oral contraceptive pills prevent the following cancers except. So oral contraceptive pills, please read the chapter properly. We have done a very good discussion in the app, but remember, if you've not read, at least read the notes which you made, and in the notes you should know that there are so many benefits of the COCPs, and it reduces the proliferation, so it reduces hyperplasias of the endometrium and cancer of the endometrium. So it reduces cancer endometrium, correct? It reduces ovarian cancer, correct? It also reduces colorectal cancer. This is what is the hotshot question which is coming in NEET and MCI. It reduces colon cancer because it reduces the bile acids in the gut. So yes, it is reducing colorectal cancer, but it does not reduce cervical cancer. Now please do not get confused. I told you CA cervix is because of HPV, and that is squamous cell carcinoma. Now OCPs, if you give for a long term, very rarely, it's not common at all, very rarely they can be CA cervix, and that is adenocarcinoma cervix. So that is adenocarcinoma can happen. But please don't say that sir taught that OCPs cause adenocarcinoma of the cervix, so we will not give OCPs to anybody. These are very rare. So please, the complications, if at all happen, are very rare. I've yet to see adenocarcinoma of the cervix because of COCPs. I've been giving COCPs ever since I got into MD. I've been giving to hundreds and hundreds of patients. I've yet to see a CA cervix adenocarcinoma coming. So these are theoretical findings. Yes, it has been proven, but I'm not saying that this is going to happen. So adenocarcinoma can happen. So for your choice of MCQ, the answer is CA cervix. But what about breast cancer? Yes, breast and CA cervix. Please remember, breast, it does not cause. Remember, CA breast, I have to tell you more. CA breast, it does not increase. There is no increase, but there is no reduction also. So it does not prevent breast cancer. This much is correct, but does not cause breast cancer also. That is also you must remember. If you have any doubts in these things, you must always refer to Williams Obstetrics for the fundamentals of contraception, because Williams is the reference book which is generally seen by all the teachers, all medical colleges. So if there is a doubt about contraception, read the Williams Obstetrics. It is clearly giving in the book, the latest edition, whichever is there, read, and it is giving that OCPs do not increase CA breast. It does not reduce definitely. However, whatever little bit chance is there of CA breast will reduce if the OCPs is stopped. So don't say it increases, don't say it reduces CA breast. There is no protection of CA breast, there is no protection of CA cervix. That's what somebody also wrote there. Okay, chaliye. A woman in labor is in the active phase with cervical dilatation of 6 centimeters. Now, when does the active phase starts? Yes, always remember after equal to 4 centimeters. Okay, WHO has said in the labor care guide in 2021 that it is 5 centimeters. American College has been saying it is 6 centimeters. But in all the hospitals, even now, the WHO partogram with 4 centimeters is being used. So, as and when it is replaced in the medical colleges by the Ministry of Health and Family Welfare, we shall teach you the new one. The labor care guide is there. So, if they ask you labor care guide by WHO, what is it? Go ahead and write 5 centimeters. Otherwise, active phase of labor is 4 centimeters and more. वो controversy में अब नहीं जाना है, ठीक है? 8 hours have elapsed. 8 hours have elapsed since the onset of the active phase. Per vaginal examination, the sagittal suture is felt in the oblique diameter. The sagittal suture is felt in the oblique diameter. The posterior frontal is at 8 o'clock position and the anterior frontal is easily palpable. What is the most likely cause of delay in labor? So, posterior frontal is at 8 o'clock position. Posterior frontal, okay, posterior frontal is at 8 o'clock. Is that all right? Is it looking like 8 o'clock for you? Yes. Posterior frontal is at 8 o'clock position. So, is it on the right or the left of the patient? You can see it is on the right of the patient. So, if the posterior frontal is at the right of the patient and the anterior frontal is easily felt, so this will look like a occipito-posterior towards the right. This is a right occipito-posterior. So, what is the cause of delay? So, lot of patients with occipito-posterior will come, but occipito-posterior will rotate and become occipito-anterior. It may take some time. The most occipito-posteriors will become occipito-anteriors and deliver. So, let me show this same question with a picture. See, the same question with a picture you can make out. This is a right occipito-posterior. See, it is 8 o'clock. It is at 8 o'clock here. So, this is a right, the triangular, the posterior front. See, the sagittal suture is found in the oblique diameter and the posterior frontal is at 8 o'clock position. See here. So, this is triangular. The posterior frontal is triangular and the occiput is here. This is the occiput. O I have written for occiput. Right occipito-posterior. So, occipito-posterior will deliver, but it will take some time. So, occipito-posterior, see, right occipito-posterior. Okay, there is no mirroring now. Yes, right occipito-posterior hits the pelvic floor, rotates to right occipito-transverse, right occipito-anterior, and totally occipito-anterior and delivers by extension. Now, occipito-posterior in an anthropoid pelvis will not rotate. That's your MCI question. It will stay occipito-posterior. Even if it stays occipito-posterior, it will deliver by extension. But that time, the face is looking at pubis. So, we say face to pubis in a persistent occipito-posterior. That can happen, a face to pubis delivery. So, yes, occipito-posterior will rotate in a nice gynecoid pelvis, but if it is an anthropoid pelvis, there is no rotation possible. All right. I have mentioned the pelvis in some other question later on. So, yes, we are having a transition of questions. We've done a lot of gynae. Some obs will come and again some questions in gynae will come. Okay, don't worry. A para 2 live to woman desires a permanent method of contraception. Which of the following is the most appropriate method? Permanent method of contraception to children. So, salpingectomy, total removal of tube should never be done. Why? Because sometimes when a woman has a tubectomy, she may want to re-anastomose the tube if she loses her children or she has, her husband divorces her and gets the custody of the children, then she may want to get married again and have more children. So, never cut the total tube off. So, salpingectomy, partial salpingectomy? No. Salpingostomy, this is a surgery for ectopic pregnancy. So tubectomy by Pomeroy's method is the best method, which is I'm so sorry, it is the most common method. Okay, best के ऊपर थोड़ा सा controversy है, so we're not talking about that. But where do you ligate the tube? We always ligate the tube in the ampulla or in the isthmus. We always ligate in the isthmus. Why do we ligate in the isthmus? Because the cut ends are uniform. These will be the cut ends. So the cut ends are uniform, they are like this. Then if at all she requires a reanastomosis later, we keep that in mind. Then the reanastomosis is up to 80% successful. Reanastomosis is up to 80% successful. All right. So that's why the Pomeroy's method of tubectomy, the most common method in a country, is what is done. All right. A woman with twin gestation delivers the first baby vaginally. Now this is interesting. First baby has delivered vaginally, which was cephalic in presentation. The second twin is in transverse lie. What is the most appropriate method for delivery of the second fetus? The second fetus is in transverse lie. So we'll come to this. It's okay. Don't answer. Don't answer. Just wait. I'm just trying to give you a little bit of basics and then we'll come back to that. So in a relaxed uterus, let's say if there is a breech, this is a breech presentation and this is a transverse lie. So in a relaxed uterus at 36 weeks and this also 36 weeks, in a relaxed uterus, I can hold the baby head and the buttocks and turn the baby like this. Okay, we turn the baby like this and make the baby cephalic because the uterus is relaxed. At 36 weeks, I can do a external cephalic version in a breech, but I can do an external cephalic version even for a transverse lie. So both of these patients, we can do external cephalic version when the uterus is relaxed. The only time when you can do a version is when the uterus is relaxed. That's why we don't do it 38 weeks or 39 weeks. So 36 weeks in a primary gravida. Primary gravida में 36 weeks में करते हैं. Multi gravida में we can even go multi gravida में we can go as much as 37 weeks also. But not after that, because the uterus becomes irritable. So 38 weeks, 39 weeks, if you try to move the baby, then the uterus will go into labor. So when the uterus is relaxed, we can do versions. What is the punchline here? When the uterus is relaxed, we can do a version. When the uterus is relaxed, we can do a version. So when the uterus is relaxed, we can do version for a breech and a transverse lie. Now, suppose the patient is in labor. Suppose the patient is in labor. If transverse lie in labor, please do not do anything called a version. Then in labor, you have to do a cesarean section. If a transverse lie is in labor, cesarean section, MCI में यही क्वेश्चन आता है. इसको गलत मत करना, थोड़ा एडवांस पढ़ा रहा हूं. But do not think that versions will come more to you. Basic question will come. If a patient is in labor with transverse lie, do cesarean section. If the uterus is relaxed at 36 weeks, you happen to see a transverse lie, you can do a external cephalic version. Otherwise, transverse lie in labor is cesarean section. End of discussion. Now, when a breech comes in labor, you will deliver a breech. Breech will deliver. Yes, of course, it will be delivered only in a institutional setup, in let's say a big hospital with the senior doctors. You can deliver a breech vaginally in labor, but a transverse lie in labor, you do cesarean section. Both of these, if the uterus relaxed, you can do external cephalic version. Now, the question is different in our discussion today. A patient is having a second of twin in transverse lie. The first baby has delivered vaginally and the second of twin is transverse lie, and between two labors the uterus is relaxed. So when can you do a version? I told you, remember this, version can be done only in a relaxed uterus. So external cephalic version can be done when the uterus relaxed at 36 weeks. Now, when the first baby is delivered and the second baby is in a transverse lie, I can put my hand into the vagina and go in and hold the leg of the baby. With the other hand on the top of the abdomen, I can turn the baby like this. Go and hold the leg, and the lower pole, podalic pole, will come to the internal os. So go and hold the leg and turn the baby like this. The lower pole will come to the into the internal os, and then you will pull the baby out. So internal podalic version with breech extraction can be done for a second of twin. For a second of twin. So second of twin, you can do a internal podalic version. So you already deliver the first baby vaginally, the second baby will come vaginally. No cesarean, no external cephalic version in labor. External cephalic नहीं करना होता है, internal podalic करना होता है. Okay, so internal podalic version can be done. Only indication, yes, only indication in modern obstetrics of internal podalic version is the second of twin in transverse lie. All right. Pinard maneuver is not for this. No, Pinard maneuver is not for this. Pinard maneuver is for breech with extended legs. Don't get confused. We are talking about transverse lie if it comes in the second of twin. Okay. This also we'll discuss a little bit more in detail. Okay, आगे बढ़ते हैं. A woman with twin gestation delivers a first baby vaginally, which was cephalic in presentation. The second twin is transverse lie. What is the most appropriate method for delivery of the second fetus? I just now told you. Now, what happens in twins? Let me tell you that. Twins may, if both are cephalic, that is the most common. Most common is both are cephalic. But it can also be the second most common. The second most common, first is cephalic, second in breech. And then they can be first cephalic, second transverse lie. All these three, yes, all these three can deliver. Just now you learned, yes, breech, second baby can deliver vaginally. Transverse lie second baby can deliver by internal podalic version. Now, first is breech in twins. If first is breech, first is transverse lie, both will have a cesarean section. Both will have a cesarean section. So, twins, remember that we will not do a normal delivery if the first baby is non-cephalic. Non-cephalic. First baby. Non-cephalic cesarean section. First baby, if it is cephalic, second can be breech, second can be transverse lie, you can deliver vaginally. You can deliver vaginally. All right. So, yes, I know if you're getting confused, please stop, rewind and look at this question once again. Okay. पहली बार सुना आज? Contracted uterus. I don't know what is a contracted uterus. IP second twin, breech and transverse. Transverse lie में IPV होता है. Breech में IPV करने की जरूरत नहीं है. बीच में तो बेबी सीधा ही है ना, तो ब्रीच डिलीवरी तो कर सकते हैं हम लोग. पोडाली की तो है, ब्रीच इज पोडाली, उसमें आईपीवी क्या करोगे? ट्रांसवर्स लाई में करते हैं. चलो, व्हाट इज फर्स्ट बेबी इटसेल्फ इज ब्रीच और ट्रांसवर्स, बता दिया ना, फर्स्ट बेबी ब्रीच और ट्रांसवर्स. बिफोर यू आस्क मी द क्वेश्चन आई गिव यू द आंसर. चलिए आगे बढ़ते हैं. It is yeah, almost 2 hours. You want to take a short break, water break, because ऑब्स एंड गायनी थोड़ा मिक्स चल रहा है. एक वाटर ब्रेक ले लेते हैं, ठीक है? तो यस, वी आर डूइंग फास्ट. इनिशियली थोड़ा सा ज़्यादा पढ़ाने लग गया था, मेरे को लग रहा है. यस, बट पढ़ाने वाला टाइम नहीं है. 10 मिनट्स दे दूं, ठीक है? एक वाटर ब्रेक ले लेते हैं, वहां से शुरू करते हैं. व्हाट इज द इंडिकेशन फॉर दिस प्रोसीजर? अच्छा, ये वाला खत्म कर लेते हैं ना, ये क्वेश्चन कर ही लेते हैं, उसके बाद एक वाटर ब्रेक लेते हैं. सी, व्हाट इज द इंडिकेशन फॉर दिस प्रोसीजर? सी, यू आर होल्डिंग द लेग्स एंड पुलिंग इट आउट. दिस इज अ केस ऑफ ट्रांसवर्स लाइन, यू पुलिंग इट आउट. सो वही क्वेश्चन है, उसको यहाँ पे बता दिया है. डिलीवर फीट इन cephalic? नो. डिलीवर ऑफ फीटस इन ब्रीच? नो. यू विल नॉट पुट द हैंड इनसाइड एंड डिलीवर ब्रीच. नो, दैट इज रॉन्ग. यूजुअल मेथड डिलीवरी ऑफ अ सेकंड ट्विन? नो. IPV ऑफ सेकंड ट्विन इन ट्रांसवर्स लाई, ये अभी मैंने आपको बताया, वही क्वेश्चन यहाँ पे आई हैव आस्क्ड यू नाउ. So it is for the internal podalic version के बाद you can do a breech extraction. IPV के बाद breech extraction. चलो, so we'll stop here. I'll give you a water break. Okay, water break, guys. All right, Hyderabad people, great. छोटा सा break, okay, छोटा सा break लेते हैं, and then we'll come back. Okay, I'm not stopping the transmission, so I'll go on. I'm just putting the audio off. So I'll just see you exactly in 10 minutes. It's yeah, 7:55, 7:56. Okay, let's meet at yeah, 6 past 8. Okay, okay, 10 past 8. छोटा सा break ले लो. Don't go away, guys. We have more discussions coming up. All right, guys, let's get back to work. All right, guys, starting in 1 minute. Wherever you are, please come back fast. Yes, yes, I'm very much here. Just checking a few things. Right, students, let's get back to work. Okay, so in twins, we discussed that if a baby, the first baby is cephalic, then we can do second breech and transverse lie also vaginal delivery ho sakta hai. But the first baby is transverse lie or breech, we'll have to do a cesarean section again. Okay, chalo. What are you asking me? Pubococcyges. Pubococcyges. Yes, yes, pubococcyges. Gitish. Am I visible now? I hope I'm visible. Chalo. There's, I think, some delay. Chali. Come, let's take another question, guys. A woman with an IUCD in situ presents with mild intermittent vaginal spotting for 2 months. She has no abdominal pain. On examination, the IUCD is correctly positioned. IUCD is correctly positioned and threads are clearly visible. What is the most appropriate management? So, IUCD dala hai, mild intermittent vaginal spotting is there. So, what is the most common complication of an IUCD? The most common complication of IUCD is increase in bleeding and can have some spotting. But there is no pain, there is no discharge, there is no fever. Then please do not take out the IUCD. Please counsel her. And generally, kya hota hai, during the first 2-3 periods, what we do, we give them some NSAIDs during the periods. That will reduce the bleeding also. So, what we do? We do a pelvic X-ray to rule out IUCD perforation? No, not at all. She's not having any pain and no excessive bleeding. So, that is not required. Remove the IUCD? Not required. Start antibiotics? Not required. Continue IUCD without any intervention? Yes, that is the answer to this question. I hope you all got that correct. A 28-year-old primary graduate, 28 weeks, undergoes a 75 grams oral glucose tolerance test. Her values of fasting are 96 milligrams per deciliter, 1 hour is 184 milligrams per deciliter, 2 hour is 156 milligram per deciliter. She never had high sugars earlier prior to the pregnancy. What is the most appropriate diagnosis? 1 minute. I'm getting a call. Wait a minute. From my studio. I hope I'm not missing something. Right. So, my studio guys, the screen went black for a moment and my studio guys got worried whether I have left the studio. Okay, guys. So, GTT is done with the 75 grams of glucose. So, fasting in GTT should be less than 92. Then you give 75 grams of glucose. And after that, 1 hour should be less than 180 and 2 hour should be less than 153. तो इस पेशेंट का the fasting is also high, and the 1 hour is also high, and the 2 hour is also high. So please remember, we do the GTT now with the 75 grams of glucose. We don't do the GTT with the 50 grams of screening and the 100 grams of diagnostic. That's why this is called the one-step screening test. Why it is called the one-step screening test? Because when we're doing it for screening, we're doing it for after 24 weeks we do this GTT, and any one abnormal value, any one abnormal value is equal to diagnosis. It is diagnosis of gestational diabetes mellitus. So GDM happens after 24 weeks because the human placental lactogen from the placenta is going to destroy the insulin. That's why it is called 24 weeks and beyond, the GDM. That's why screening is done after 24 weeks. That's why we call it GDM, gestation. What is happening in gestation? The placenta is formed. What is the placenta is going to do? It's going to make human placental lactogen at 24 weeks, and that is going to destroy the insulin, and the sugar is going to increase. That's why it is gestational diabetes mellitus. If the sugars are high in the first trimester, it is pre-existing or overt diabetes. And overt diabetes, first trimester sugars will cause anomalies, because the first trimester is the time when the organogenesis is taking place. Don't say GDM causes anomalies. GDM never causes anomalies. GDM happens after the organogenesis is over. GDM happens after 24 weeks. So ये गलतियां नहीं करना है, ठीक है? चलिए. Now, this is obviously the gestation diabetes mellitus, a simple question. I'm sure all of you got that correct. Now remember the okay, fine. Let's go to the next question. GDM पे और आएंगे questions बाद में. The image shows the cervix of a woman at 8 weeks of pregnancy with bluish discoloration of the cervix. Identify the classical sign shown in the image. So bluish discoloration of the cervix is the classical Chadwick sign. The Chadwick sign, or the Jacquemus sign also we call it. Jacquemus sign. And Hagar sign is something else. So bluish discoloration of the cervix and also of the vagina. This cervix का नहीं है, vagina भी blue होगा obviously. If the cervix is blue, the vagina won't be, magenta. Please, I hope you don't get into this confusion. Last time also this question came, nahi sir, my books are saying that Chadwick is classically for the vagina. It is actually classically only for the cervix. And Williams Oxford is categorically giving it only for the cervix. So don't say it is for the vagina. But yes, common sense says if the cervix is blue, the vagina also will be blue. Okay, so it can be blue there also. Hagar sign is the soft isthmus. Hagar sign is soft isthmus. Goodell sign is the soft cervix. And Palmer's sign is the rhythmic uterine contraction in the first trimester. Early pregnancy mein, uterus mein, when you do a bimanual examination, you will feel some rhythmic contractions in the early first trimester. Look, around 18-20 weeks ke aspas, there is a uterus getting hard. That is known as Braxton Hicks. Palmer sign is the first trimester, early pregnancy. Okay, so I'm just giving you the list of the signs which generally keep coming in exam. The presumptive signs, the probable signs, and the positive signs. So amenorrhea, nausea, vomiting, and then the patient having frequent urination, quickening, and the fatigue, linea nigra, and the stria gravidarium, cloasma. All of these are the presumptive signs. Now, what are the probable signs? What we discussed, this can come in exam. The Chadwick sign, which we just discussed, is a probable sign. Now, Chadwick sign is at 8 weeks. Goodell sign, soft cervix, 8 weeks. Hagar sign is the only one which is at 6 weeks. So, this comes in the exam because it's a soft isthmus. Braxton Hicks is around 18 weeks to 20 weeks. You will start seeing the Braxton Hicks. Ballotment, the external ballotment, internal ballotment, positive pregnancy test. These are the probable signs. And definitive pregnancy here, positive sign, ultrasound showing a fetus, heartbeat sunne lag gaya, fetal movements feel ho gaye by the examiner. That is classical positive signs. So all of these are presumptive signs. Okay, quickening can be felt as early as 16 to 18 weeks in a multigravida and around 20 weeks in a primigravida. After 20 weeks in a generally 24 weeks bhi ho jata hai primigravida mein. So we say after 20 weeks, generally 20 to 24 weeks mein primigravida will feel the movements. So please remember these signs. Okay, chalo. Hagar may cause abortion. Yes, if you are doing Hagar is bimanually, you put one hand in the vagina, one hand on the abdomen, and you try to feel the isthmus through your vaginal hand and abdominal hand, you can go and compress the isthmus and you can make your fingers touch each other. I think that's a very distasteful sign made by anybody, because if you go and compress, you get to know the patient is pregnant because the isthmus is very soft. Look, the cervix is also very soft in pregnancy. That alone should be enough. When you try to compress, you may actually compress a gestation sac if you're not very polite in doing your examination, and you may rupture a sac. So that's why please don't do Hagar's, okay? Not unless you become a super specialist in obs and gynae and your hands are now used to doing examinations. So let's not talk about this. Let's move on. An early pregnancy ultrasound shows twin gestational sacs. Identify the type of twin gestation shown in the image. So you see that there is a placenta here. There is one placenta here, and that's why it looks like a monochorionic pregnancy. But in this one placenta, there is a strip of placental tissue which is coming between the two gestational sacs. So that's what is known as the twin peak sign. It is a twin peak sign, like this it is. So twin peak sign means that there is actually two placentas which are looking like one, actually two placentas which are joined to each other. You know, always in pregnancy we want to see two placentas and two sacs. In twins we want to see that, two placentas and two sacs. Now sometimes the placentas are very closely attached in the uterus, so they look like one placenta. So when it is two placentas, it is obstetrically a safe pregnancy. So when there are two placentas but they look like one, sometimes when there are two placentas and they look like one because they are stuck to each other, then some placental tissue will come between the two sacs. So it is basically looking like one placenta, but it is actually two placentas. So two placenta is obstetrically safe. So when we see the twin peak sign, it tells me that it is a dichorionic, diamniotic twin pregnancy. So identify the type of gestation. It is a dichorionic diamniotic pregnancy. That's why. So always in twins we want to see two placentas. So that's why I'm trying to teach you now the formation of twins. So if you see the monozygotic is not so common. Dizygotic is common. Monozygotic is 1 in 250 pregnancies, and if they divide before 3 days, you will see the dichorionic and diamniotic pregnancy, and if it is 4 to 8 days, you will see monochorionic diamniotic pregnancy. If it is 9 to 12 days, you see monochorionic monoamniotic pregnancy, and if it is after 12 weeks, you see conjoined twins. So yes, dichorionic diamniotic, two placentas and two sac. This is the safest obstetrically, dichorionic diamniotic. So in monozygotic pregnancy, 30 to 35% of cases will be dichorionic diamniotic and 40% will be monochorionic diamniotic. So in monozygotic pregnancy, that's what is your NEET exam question. In monozygotic pregnancy, what is the most common type of twin you see? The most common is MODI, monochorionic diamniotic. This is the nomenclature which is given in the books also, di, MODI, MO. But yes, I'm sure that you're not going to call it that. You're going to call it di, modi, and MO, you're going to call momo. So yes, it is an accepted nomenclature to write is at di and MODI. So yes, MODI is the most common type of monozygotic twin, but this is not safe. The safest is dichorionic diamniotic. So that's what I was trying to show you here. In dizygotic twin, you'll always see, they will be dichorionic diamniotic. So dizygotic twins will always be dichorionic diamniotic. In monozygotic twin, 30-35% will be dichorionic diamniotic. Right. So twin ke bare mein, delivery ke bare mein I've already told you. So let's move on and see something else. A woman in labor is undergoing augmentation with oxytocin. She has a breech presentation. Following spontaneous rupture of membranes, she suddenly develops fetal bradycardia. What is the most likely diagnosis? So what happens in breech? The chance of the cord coming out is more than in a cephalic presentation. So that's why we say it's more likely fetal bradycardia after ARM. Think in terms of cord prolapse. So cord prolapse, generally does not come out of the vagina every time. It may be a cord prolapse into the vagina, not outside the vagina. So if there is a sudden fetal bradycardia, put your hand in the vagina and see what is happening, and you can feel a cord. Okay, you can diagnose a cord that way also. So yes. Okay, all right. The Didi Modi. All right, all right, all right. We are not getting into politics right now. Sir, conjoined 12 weeks, not 12 days. Oh, sorry. Did I say 12 weeks? Sorry, sorry. Yeah, sorry, sorry. Thank you, thank you, thank you. Obviously, 12 days. 12 days. Yes, that's a mistake. Thank you. Thank you. Okay. So yes, that is cord prolapse. Now, cord prolapse is like this. It may be in the vagina, it may come out of the vagina also. So please never try to, moment you see this, lot of, have an idea that you were discussing with me. Sir, we've been told that you can hold the cord and push it inside. Nonsense. If you hold the cord, you're going to cause vasospasm of the blood vessels and cause bradycardia for the baby worse. You can kill the baby if you manipulate the cord. Sudden vasospasm can happen. So what you can do, you can put a hand in the vagina and push the presenting part up. So if you push the head up, the cord will not get compressed. See, between the head and the pelvic bones, the cord will not get compressed if you push the head up. So try to push the presenting part up by your hand or by filling up the bladder. If you fill up the bladder, then the bladder will fill up and push the head up and put the patient in a knee chest position. Knee chest, like you remember the Gaskin's procedure in shoulder dystocia, knee chest. The patient is on all fours. The hand is on the floor and the legs are on the floor, knee chest position. So the weight of the baby comes onto the maternal abdomen, and that will prevent the cord compression. So I've given you the recommendations by the Royal College because most of your books are not talking about the cord prolapse properly. So I thought I'll give you the Royal College recommendations, the green top guidelines which they say. So the assistant should be immediately called when there's a cord prolapse, and to prevent vasospasm there should be minimal handling. Don't hold the cord. Minimal handling of the loop lying outside the vagina. So to prevent cord compression, it is recommended that the presenting part be elevated either manually or by filling up the bladder. Cord compression can be further reduced by mother adopting the knee chest position or the left lateral position with the head down. थोड़ा head को low भी कर दोगे तो presenting part ऊपर चला जाएगा. So that's why we say that cord prolapse, you have to do a cesarean section. That is correct. Cord prolapse, you do a cesarean section, but before taking the patient, prepare. कहते हैं, if there's a cord prolapse, what do? Tell your friend, rush to the OT, get the anesthetist, start the preparation of the OT. I'm pushing the patient towards the OT you have to take the patient up, put her into a trolley, and when the patient is going, you have to tell the relatives that you're doing a cesarean section in immediate time. And meanwhile, it will take around 5 minutes to 10 minutes by the time the incision is made, because you'll take her to the OT and then the anesthesia person, even if he's giving a G, it'll take 2-3 minutes. So by the time you make the incision, 7-8 minutes would have passed, even if you're very fast. And that time the head of the baby or the breech of the baby should not compress the cord. So you should push the presenting part up, right? Chali. A 55-year-old woman, 3 years postmenopausal, presents with severe hot flushes and sleep disturbances. She has an intact uterus and no contraindication to hormone therapy. What is the most appropriate treatment? Menopausal woman, hot flushes. The treatment is estrogen therapy. But if she's got an intact uterus, she has a uterus present, so the estrogen can cause hyperplasia. So to prevent hyperplasia and cancer, you must give estrogen and progesterone therapy. So the answer is HRT, having estrogen, progesterones both. But if hysterectomy was already done, that was your question. If hysterectomy was done already, hysterectomy done earlier in this woman for whatever reason, and now she's having hot flushes, if the hysterectomy was done earlier, then give only estrogens. So please, this is the time for me to tell you that when we're talking about a patient with menopause, so menopause, remember, HRT should be started to every patient, but before that you must see if the liver is fine and the sugars are fine, the lipids are fine, pap smear is okay, and the endometrial thickness should be less than equal to 4 millimeters on transvaginal sonography. This is solid MCI question, ET in a menopausal woman. If all of that is fine, start the HRT. Now, the problem is osteoporosis, and there is no doubt, I spent a lot of time on this. I'm not doing in this lecture. You can see my previous 50 predictor ones and 6 months back the marathon. You can see all of that, and I've done a lot of discussion with you to tell you that osteoporosis drug of choice is always the hormone replacement therapy. After 60 years, it is bisphosphonates after 60 years, and it is given just like this in your Shaws and in your Novaks. These are the reference books. Gynecologists will teach you from these books. Gynecologists will manage the osteoporosis in women. Yes, orthopedicians also manage, but mostly they'll come to us because they are coming in menopause to us. And the Federation of Obstetricians and Gynecologists Society of India, FOGSI, also says the drug of choice for osteoporosis is the estrogen therapy. If you give estrogen therapy for more than 10 years, it can cause coronary artery disease. So after 60 years, it is bisphosphonate. And exactly that question came in INSET 3 years back. So this has come as a question. It is there in Shaws, it is there in your Novaks, it is there in the FOGSI guidelines of the country. And still, if you want to write that bisphosphonate is the best treatment of osteoporosis, then I cannot say anything. Remember, it is given in all the books and the books which matter and what we do as practice. There is a controversy, we are not getting into that. Okay. Bisphosphonates after 60, excellent drugs. Before that, drug of choice for prevention, drug of choice for treatment of osteoporosis, hormone replacement therapy. All right. Dose of HRT. Which HRT you want to ask me? Dose of HRT, if you're giving for estrogen and progesterone, then the ethinyl estradiol, the estradiol tablet is given as 1 to 2 milligrams per day. And then along with that, you can add progesterone. Now, progesterone depends on many types. Medroxyprogesterone, you can give 10 milligrams or 5 milligrams also per day. Then that is estradiol, but the tibolone, T-I hai, tibolone is a synthetic estrogen plus progesterone, that is 2.5 milligrams per day. Now, this synthetic estrogen, tibolone, is a very good drug because synthetic estrogen tibolone has its own metabolite which forms in the body after it goes inside, and that metabolite has a progestational action. So rather than giving estrogen and progesterone, tibolone is a drug which has estrogen and progesterone actions both in the same drug. So that is my favorite drug for the patients with HRT in my clinic. Now, woman is in labor, has the following fetal heart trace. What type of deceleration does this present? So please remember, we are talking about deceleration and not distress. So yes, what type of deceleration? So the heart rate, you can, I'm sure you cannot read from that distance. Heart rate is at 150 and it is gone down till 130. So heart rate is like this and the uterine contractions are like this. So can you see, it is not coinciding, it is somewhat late. So uterus contracts, heart rate goes low, then it takes time to go low and time to pick up also. So that's why it is called the late deceleration. This is a late deceleration. It is seen in placental insufficiency. Placental insufficiency, you see this, and it is not normal. This is not normal. The answer is late deceleration. Early deceleration is seen in head compression, and this is the safest. It is the safest deceleration, and variable deceleration is umbilical cord compression, and that is the most common deceleration. Is the most common deceleration, and this variable deceleration is mostly safe. I will not say it is always safe, but cord, umbilical cord can go around the hand of the baby, around the leg of the baby, and it can get compressed between the body and the uterine wall. It can go around the neck also. Cord can get compressed very frequently. That's why it is the most common deceleration. But cord gets compressed, it has got that Wharton's jelly, so it also gets released very easily. So that's why cord compression is the most common deceleration, and it is mostly normal. But if it is staying for a long time, if the variable deceletions are staying for a long time, repeatedly happening, then they can be ominous. Mostly variable deceleration is normal. Most common is variable, which is mostly normal. The safest deceleration is the early deceleration because of head compression, and the one which is not normal is the late deceleration with placental insufficiency, the one which I have shown you here. A 22-year-old woman at 35 weeks presents with nausea, vomiting, malaise and jaundice. Blood pressure is mildly elevated. Laboratory test shows hypoglycemia, elevated liver enzymes, prolonged prothrombin time and mild thrombocytopenia. What is the most likely diagnosis? Yes, now that's a good question. Blood pressure is mildly elevated. Labs show hypoglycemia, elevated liver enzymes. Okay, थोड़ा सा tricky question है. Nausea, vomiting, malaise, jaundice. हाइपरटेंशन में जॉन्डिस नहीं होता है जनरली, माइल्ड हाइपरटेंशन में जॉन्डिस नहीं होगा, एलिवेटेड लिवर एंजाइम्स में भी जॉन्डिस नहीं होता है, एलिवेटेड बिलिरुबिन में जॉन्डिस होता है. प्लीज नो, बी केयरफुल, इट इज नॉट हेल्प सिंड्रोम. No, it is not HELLP syndrome, guys. Yes, liver enzymes, thrombocytopenia, it is suggesting that it is like a HELLP syndrome. So yes, it's a case of acute fatty liver of pregnancy. This is what, around 35, 36, 37 weeks you get acute fatty liver of pregnancy. Yes, this also can come as your question, okay? So medicine people teach you this very well, but never mind, acute fatty liver of pregnancy, me and the medicine people together we manage. Of course, they are much smarter than us in managing all of this, but yes, acute fatty liver of pregnancy, there is a liver failure, hypertension with liver enzymes. The liver is working normal, although the liver is strained. Remember these lines, the liver is strained. When the liver is strained in hypertension, it is still working normally. So enzymes may be high. They could be hemolysis and elevated liver enzymes and low platelets. HELP is a finding in eclampsia, correct, but there is hypoglycemia here. There is jaundice in this patient. So think in terms of acute fatty liver pregnancy. If there is liver failure, the patient can go into failure and even die. So yes, what is the difference between that? So I've given you the list. I hope you can zoom in and see, and maybe once you pause it and see. So intrahepatic cholestasis of pregnancy, they will be a bilirubin of 1 to 5. In acute fatty liver of pregnancy, it will be 2 to 8, and that is direct hyperbilirubinemia. In HELLP syndrome, it will not be very high. Jaundice won't be there in HELLP syndrome, and I've written jaundice there. So that's why it is not HELLP syndrome. Viral hepatitis, I'm not going in detail. Between AFLP and HELLP syndrome, I'm teaching you this. Okay, so SGPT and SGOT is not very high in a case of a HELLP syndrome. It can be around 150 to 600, similar values in acute fatty liver. Now, platelets are low in acute fatty liver, they are low in HELLP syndrome also. Now, the coagulation profile is preserved. That is what is missed by all you students. You said that this is HELLP syndrome. No, the prothrombin time is prolonged. So, it is deranged coagulation profile in acute fatty liver of pregnancy. Okay, and this patient can have hypoglycemia and raise creatinine, DIC. So yes, acute fatty liver of pregnancy, the liver function is also compromised, and in this patient the liver function is preserved. That's why HELLP syndrome is a better of the two evils. Acute fatty liver of pregnancy, quite a few times we lose the patients. Okay, remember that, right? So I've given you the differentiation between these two, right? A woman has rectal bleeding every time she has menstrual cycle. She has no rectal bleeding on other days. So during menses, bleeding at any other part of the body. During menses, bleeding from any other part of the body, think in terms of endometriosis. So on per rectal examination, an anterior rectal wall nodule is felt. What is the possible diagnosis? Then that is a case of endometriosis. Yes, endometriosis. So endometriosis, most common site is the ovaries. Most common are the ovaries, and that's why in the NEET exam they asked you a slightly different question. Second most common is the pouch of Douglas. So when you put your finger in the vagina, one finger in the rectum, we call it PV and PR together, PVR. So between the vaginal finger and the rectal finger, you can feel the rectovaginal septum. So that will have some nodules sometimes. So in the nodules, if you feel, endometriosis diagnosis will be much easier for you to make. Right. Pregnant women in India are often advised not to consume which fruit due to common misconception. Now, I cannot predict such questions. Whatever predictor we are doing an effort in PW, I cannot predict that this question will come in the exam. Now, this came in the exam last time in January. Papaya is supposed to be an abortifacient, which is wrong. It's a misconception. So yes, papaya seeds cause abortion. Papaya by itself, papita kha sakte ho yaar. We give papita to so many patients. It's nothing is going to happen with papita. Please. These are all misconceptions. So papaya can be taken. Papaya seeds pregnancy में नहीं खाते हैं. Papaya seeds तो वैसे भी नहीं खाते हैं. I don't know anybody who's having papaya seeds. So please, we always use the papaya to eat, and in pregnancy papaya can be taken. Yes, if you take too much of papaya and too much of mangoes, anything too much of sweet if you take, you will get a osmotic diarrhea. That's a different thing. But it is not going to cause an abortion. Right. A para 3 live 3 woman presents with menorrhagia and undergoes a hysterectomy. She has a menorrhagia and undergoes a hysterectomy. Okay. The removed uterine specimen shows uniform enlargement with lakes of blood in the myometrium. So, this lakes of blood in the myometrium and uniform enlargement of the uterus. Uniform भी बोल सकते हैं, diffuse भी बोल सकते हैं. Diffuse enlargement means पूरा enlargement होना. Irregular enlargement is like this, irregular enlargement that you'll see in fibroids. So, diffuse enlargement or irregular or regular, uniform or diffuse means the same. So, uniform or diffuse enlargement of the uterus with lakes of blood in the myometrium is classical adenomyosis. But the question which has come in your exam, remember the size is always less than equal to 14 centimeter, never more than 14 centimeters. So, the question which came in your exam was, what cannot be the disease if there is a 30 centimeter mass in the pelvis? If there is a 30 centimeter mass in the pelvis, it can never be adenomyosis. It can be an ovarian tumor, it can be a mesenteric cyst also, can be a fibroid also. Fibroids can become huge, but it will never be a adenomyosis. A 60-year-old girl presents with primary amenorrhea. She has well-developed breast, scanty pubic and axillary hair. So remember, any intersex question, they will tell you about pubic hair. If the pubic hair is present, means androgens are working. If the pubic hair is absent, means androgens are not working. This is always told in all questions on intersex. So pubic hair is scanty, axillary hair is scanty, there is a blind vaginal pouch, absence uterus and ovaries on ultrasound, and serum testosterone is in the male range. So it's a classical condition where it's a normal male without having working androgens. Androgen level है, androgens का presence है, normal level है, but the androgens are not able to work. Androgen insensitivity syndrome. It's a classical case where it's a man who's looking like a beautiful woman. Yes, it's a tall girl who is very feminine because of the high estrogens. All these androgens are not working. They go to the fat in the periphery and convert into estrogen. So this person is very feminine. And this feminine person will have breasts also. But since there are no androgens, there will be no pubic hair and axillary hair. So classically distinguish करते हैं इसे Mullerian में. Mullerian is much more common. Mullerian is much more common than testicular feminization syndrome. But both will look like girls, both will have breast, both will have a normal looking vulva, both will have a blind vagina. But Mullerian will have a normal androgen production and they will have pubic hair. But testicular feminization or androgen insensitivity syndrome will not have any pubic hair. Alright, so answer is androgen insensitivity syndrome. Now, gonadal degenesis, Turner syndrome is also gonadal degenesis. This is also a type of gonadal degenesis. Another gonadal degenesis is Sware syndrome. So, Turner syndrome is a 45XO. Gonadal degenesis is a boy 46XY with gonadal dysgenesis. Okay, so gonadal degenesis is a huge chapter which I have discussed with PW, and I think you must see, if you've not read intersex, maybe quickly read it on 2x speed, but at least read that chapter if you've not read, because I've taken a lot of effort to teach you that very simply. Okay, chalo, let's move on and see something else. A 55-year-old diabetic hypertensive postmenopausal woman with postmenopausal bleeding. This is C endometrium. We've already discussed that earlier because something about C endometrium came, and this picture came in your 2026 January exam. This picture, uterus with the proliferative growth in the cavity, that is cancer endometrium. So diabetes mellitus, hypertension, obesity with postmenopausal bleeding, think of CA endometrium. A woman with a positive pregnancy test has a beta HCG level of 78,000. Ultrasound shows a snowstorm appearance with no fetus. Please, this is classical complete mole. Okay, there's a complete mole. In a partial mole, you'll see a fetus with a almost normal looking placenta. Histopathology में पता चलेगा कि प्लास्टा में थोड़े से degenerated vesicles भी हैं. So please, classical snowstorm appearance. This, I know you all of you know the answer, but this comes in two exams, INI-CT and MCI. Always this will come. At least there are 2 NICT exams and 2 MCI exam. एक या दो exam में every year this question will come. Snowstorm appearance. So that is a case of complete mole. So what is the evacuation of a complete mole? Complete mole is treatment is suction evacuation. Please do not say DNC. We don't say DNC. The treatment of a complete mole is suction evacuation. Okay, most of the places you can say DNC and get away in gynecology, but in a molar pregnancy, we always say a suction evacuation. Right. A woman has 2 second trimester pregnancy losses. What is the most likely diagnosis? So 2 second trimester pregnancy losses. And picture mein, they're trying to show the cervix. This is the cervical length. So this is the head of the baby here, and this is the cervical length. So I'm just magnifying it in the next picture. You see this one, this picture, I'm magnifying this. This I'm magnifying here to show how much it is. So it is 0.97 centimeter, matlab barely 1 centimeter ka cervix hai. That's what we are trying to show you here. It's a 1 centimeter cervix. So the picture in the exam will be much clearer. So if they're trying to show you a short cervix, which is just 1 centimeter, so that is what is known as a case of a cervical insufficiency. Okay, a short cervix or cervical insufficiency. Okay, so when there is a short cervix, what do you do? You can put a cerclage, and cerclage is applied. A cerclage is applied after 12 weeks, and it is removed after 37 weeks. Why do you remove it after 37 weeks? To allow a normal vaginal delivery. So you put a non-absorbable suture, and that's how a cerclage is done. We put a non-absorbable suture, right? So now, if the cervix is short, let's say I'll try to show you with a simple example. If the cervix is short, look, this is a short cervix, then I can put a stitch like this here, and you can remove it also after the patient is 37 weeks, and you can remove it to allow a normal delivery. Now, if the cervix is very short, it is so short that there is no cervix seen for you to put a suture. It is so short. So where will you put a suture? So yes, there is a pregnancy where the cervix is so short that you cannot put a suture. So this vagina, can you see this? This vagina has to be dissected away, and then I can go inside and put a suture. So I dissect the vagina away and then put a stitch on the cervix like this, and then I suture the vagina back to the anterior and posterior cervix. So very short cervix or previously failed cerclage. Very short cervix and a previously failed cerclage. That's where you do a modified Shirodkar. I don't know why they gave you this choice in one of the exam questions. It came in MCI only. So the Shirodkar which we do now is the modified Shirodkar. We bury the sutures in the vaginal skin so that it does not cause infection. If the cut-ends are in the vagina, then this suture is very high. So this can cause infections in the infections in the pelvis. That's why we bury the suture. So that is a modification of Shirodkar which is done, and now we call it as the modified Shirodkar. Like the Pomeroy's is not called Pomeroy's anymore. It is always called the modified Pomeroy's. Similarly, the Shirodkar is not called Shirodkar. The Shirodkar cerclage is called the modified Shirodkar, where we hide the sutures so that they are not hanging. But remember, when there is a Shirodkar suture, the delivery is by cesarean section. Now there are more modifications. We are not getting into detail of that. But remember, the classical modified Shirodkar, you hide the sutures in the cervical, in the vaginal skin, so that does not cause infections. Right. In which of the following conditions is the medical management with methotrexate contraindicated in a patient with ectopic pregnancy? Okay. Ectopic pregnancy, when do we give methotrexate? When you want to kill the baby so that the tube is saved. So ectopic pregnancy का फंडा क्लियर होना चाहिए. There are two things which will come in the ectopic pregnancy. As far as I am concerned, for the MCI exam, the NEET PG, only two things. The vague presentations don't come in your exams. So read only clear things. Ruptured ectopic pregnancy, resuscitate, cut the tube and throw it in the dustbin. That's all. Ruptured ectopic, cut the tube, total salpingectomy. Unruptured tube, you try to save the tube so that she can use the tube for another pregnancy next time. Unruptured pregnancy, you try to save the tube. You can save the tube surgically or medically. You can kill the baby medically, remove the baby surgically, but save the tube. That is the funda of the unruptured tube. So when there is an unruptured tube, medical management is done. So medical management is done with methotrexate. Classically, read only this. We are not teaching you KCL and prostaglandins, all that we are not teaching you. Remember, methotrexate. Medical management with methotrexate is contraindicated in patient with what ectopic pregnancy? So let me just tell you one thing first, that unruptured ectopic pregnancy, what do you do? Unruptured ectopic pregnancy, you can do a medical management and you can do a surgical management. The medical management, surgical management is to save the tube. That is the basis. So medical management is by methotrexate and surgical management is by a linear salpingostomy. Make a hole in the tube. This uterus tube, make a hole in the tube like this. Make a hole in the tube, linear, lengthwise hole. Lengthwise hole we make. We open the tube and the baby pops out. Of course, the edges are cauterized. You can do by laparoscopy, you can do by laparotomy. But that we are not asking you. What do you do when you enter the abdomen by laparoscopy or laparotomy? What do you do with the tube? We do a linear salpingostomy. You just take the baby out and cauterize the edges. We don't suture the edges. That's why it is called a salpingostomy. Sir is important. Gostomy. When you suture the tube, it is known as linear salpingotomy, which we are not asking you. It is not done. Nobody does it, and we don't ask you. We do linear salpingostomy. Look, thoda funda bana lo, please, guys. I think there's some 17-18 surgeries given in most of your books, and that is what is confusing. Funda bahut clear hona chahiye. Ruptured tube, throw in the dustbin. There's no saving the tube, no repairing the tube. Ek answer hai. Unruptured tube, you will save the tube. Now, unruptured tube you can save by the medical methods or by the surgical methods. Medical method is methotrexate, surgical method is linear salpingostomy, and linear salpingostomy looks something like this. See, I'll try to show you. See, this is a normal tube. Now, the tube is having a bulge here. So, this is a unruptured ectopic pregnancy. See, there is no blood. The patient is very stable, so there is no emergency. So, that is a unruptured ectopic pregnancy. So, what do? You make an incision here. You make an incision here, and that is what is known as a linear lengthwise incision. See that I'm showing you here. I'm using a cautery here just to show you. Make a lengthwise incision, and you can see at 7 o'clock, some products are going to pop out. See, some products are coming out. There's some smoke here you're not able to make out. So, that's what I've done for this patient, linear salpingostomy. So, how do you decide whether you want to do a linear salpingostomy or you want to do a methotrexate? So, it's based on the size. Size, if it is 4 centimeters se zyada, you do surgical. 4 se kam, you do medical. If the HCG is 5000 se zyada, surgical, come medical. Cardiac activity is present, surgical, absent, medical. So, this is how we decide whether to do a surgical management or a medical management. So, now what is the question which you have? The question which you have is, in which of the following conditions a medical management with methotrexate is contraindicated? So, medical management करना है और किसमें नहीं कर सकते हैं? So, serum HC level is 2000, you can do medical management. Gestational sac is less than 4, it is 3 here, you can do. Cardiac activity, you can't do, you have to do surgical management. Patient is a primary grada, that is no criteria. So, you can do in that also. So, yes, cardiac activity is indication for us to go ahead and do a surgical management. Sir, even in nulliparous and ruptured ectopic pregnancy, not to save. No, ruptured में कोई save नहीं है. इसलिए कह रहा हूँ क्लास अटेंड कर लिया करो, ये लाइव वाली क्लास में वी कैन ऑलवेज, जितने भी ऑनलाइन फोरम्स हैं बहुत बढ़िया है, सब लोग बहुत अच्छा काम कर रहे हैं, आप लोग जरूर पढ़ो. Wherever you did your MBBS from, I'm very happy that there were so many online forums which made you at least understand what you come and face. But live class जरूर किया करो guys. हम लोग PW में हमेशा स्ट्रेस करते हैं कि जो हमारी लाइव क्लास चल रही है इसको जरूर अटेंड करो, क्योंकि ये जो लाइव क्लास होते हैं इसमें वी हैव इंटरैक्शंस and then we can emphasize in a live class. So you are asking me, I'm telling you, all right? So please understand, if it's a ruptured tube, throw it in the dustbin. If it is an unruptured tube, then you can save it. Unruptured tube, see, ruptured अगर अब आप मुझसे ये बोल सकते हो अगर rupture हो गया तो सर सेव नहीं करोगे. If you save that tube will cause another ectopic next time. सर अगर 2 बार rupture हो गया, दोनों बार ट्यूब काटनी पड़ेगी. Both the times you have to throw the tube in the dustbin and then do IVF for the patient. Bad luck. So that's why you say any woman gets pregnant, find out before the tube ruptures, find out whether it's an ectopic or not. Do an early ultrasound. इतना ultrasound machines हैं, इतने सारे radiologists हैं, इतने सारे gynecologists हैं. I do my patients का ultrasound myself, at least pregnancy ultrasounds. Please, unruptured tube you try to save. Ruptured tube throw in the dustbin. Total salpingectomy. Clear? ठीक है? चलिए. A 30 weeks pregnant patient presents with vaginal bleeding and a mild abdominal pain. She has a history of 2 first trimester abortions. On examination, blood pressure is elevated. Abortion hai and they are making relation with high blood pressure also. The ultrasound image is shown as below. Here. Based on the history and correct findings, which are the following conditions most likely the underlying presentation? 30-week pregnancy, vaginal bleeding, mild abdominal pain. 2 first trimester abortions and now high blood pressure. Chronic hypertension, first trimester abortion में नहीं होगा. Antiphospholipid antibody is the answer. Plaster previa, gestational diabetes, ये तो ऐसी कोई choice, कोई relation नहीं इन दोनों choices का. So antiphospholipid antibody syndrome, we wanted to tell you, that's why this question was picked up, and the other 2 choices don't make sense also in this question. So antiphospholipid antibody syndrome, thrombophilias, the tendency to make a thrombus. So you can understand if there is a very early pregnancy, let's say a very early pregnancy here, there's a 8 weeks pregnancy and there's a small placenta here which will have very small blood vessels. See the small blood vessels which are the branches of the uterine artery which will giving the blood supply to this placenta. Now if the blood is having antibodies which will make thrombus, so there are some things called the thrombophilia. Thrombophilia, the tendency to make a thrombus. So if there is a thrombus formation in these blood vessels, don't you think the blood supply will stop and the baby will die? So thrombophilias, thrombus will cause abortions. Suppose this presents a little later in pregnancy. There's a bigger baby, let's say 24-week baby, 26 weeks baby, and now the thrombophilia is making thrombus. So the blood vessels will be narrow. So the mother will have to increase the blood pressure to force blood through these narrow vessels. So thrombophilia can cause hypertension also later. So this revision has been taken for you to understand thrombophilias a little bit. It is a classical medicine topic, but in pregnancy also thrombophilia can present and cause abortions and hypertension and IUGR. So yes, it's my impetus for you to go and read thrombophilias even for your medicine exams. It can happen to you and me also, yes. And it can cause, thrombus can cause brain injuries, it can cause cardiac injuries, renal injuries. Thrombophilias can cause many problems later in life. So in pregnancy, what it causes, I'm teaching you. So what are thrombophilias? Thrombophilia is the affinity to make a thrombus. It can be inherited and acquired. So antiphospholipid antibody syndrome is an acquired thrombophilia. इसके 3 antibodies क्या हैं? This is a solid neat question at least. If it does not come in exam, who knows, they may ask you this time. So acquired thrombophilia known as antiphospholipid antibody syndrome has these 3 antibodies: lupus anticoagulant, beta-2 glycoprotein antibodies, and anticardiolipin antibodies. You must know this, guys. And inherited thrombophilias are these 5: factor V Leading deficiency, antithrombin 3 deficiency, protein C deficiency, protein S deficiency, and methyl tetrahydrofolate reductase gene mutation. Excuse me. The thrombophilias can cause the patient, thrombophilias can cause the patients to have abortions, can have hypertension, IUGR, and even intrauterine deaths. So you must read this Sapporo's criteria for this. I'm so sorry, the antiphospholipid antibody syndrome criteria. There is a clinical criteria, there is a laboratory criteria, then there is a very extensive criteria I have mentioned in the app. If you have time, go ahead and see. But antiphospholipid antibody syndrome criteria, you can know there are clinical criteria, vascular thrombosis, and pregnancy morbidity. Pregnancy morbidity is fetal death, premature birth after 34 weeks, and severe preeclampsia, 3 or more consecutive embryo losses before 10 weeks of gestation. And laboratory criteria is the lupus anticoagulant, anticardiolipin antibody, and anti-beta 2 antibodies present in the blood in the lab estimation. Pause, rewind, and here again. Okay, chalo. A 50-year-old postmenopausal woman presents with postmenopausal bleeding. Ultrasound shows the feeding vessel sign suggestive of an endometrial polyp. What is the most appropriate management? So, a polyp will have a feeding vessel. So, you'll see a growth like this and see a blood vessel coming like this, and the Doppler you'll see the red and blue flow you'll see. So, you'll see just there will be a mass in the uterus with a single blood with the single flow which will be through the pedicle. The pedicle will be something like this, and usme se you'll see some flow coming like that. So feeding vessel, if you see, that is what is a polyp. So watchful waiting, medical therapy with progesterones, no, hysteroscopic polypectomy is the best answer for this. So come, let me show you that. So this is one of my patients where I am doing a polypectomy. This is how it looks. See, I'll try to go on the side and show you the the place where the feeding vessel. I can't show you the vessel; it's too thin to show you. But yes, I'm going on the side now. Yes, I'll go on the side here somewhere. Yes, see here. That is somewhere where the attachment of the polyp is, and through that you can see. This is I think a year-old patient's hysteroscopy. Before I was doing a polypectomy, I thought I'll make a video for my students here. That's a polyp inside. It's a little crumpled polyp. It's not a very healthy round polyp. It's looking a little flat, but it's soft. So that's why it's a polyp. If it was hard and round, it would have been a fibroid. All right, guys. So let's move on and see. A woman has delivered a stillbirth and wishes to stop lactation. Which drug is the most appropriate? So choice between bromocriptine and cabergoline. Oxytocin should not be given if you want to stop breastfeeding, because oxytocin causes the milk letdown, and misoprostol has got no relation. So cabergoline and bromocriptine. So classically we used to give bromocriptine, but nowadays cabergoline. We give 2 tablets. We give 0.5 milligrams. 2 tablets we give for stopping the breastfeeding. So why cabergoline? Because cabergoline is preferred because the high efficacy. It is substantially more effective at lowering the prolactin levels and better patient compliance. It causes lesser gastritis and lower blood pressure and lower side effects are much lesser, but better patient compliance. Say what I mean to say, it causes lesser headaches also, very important, the headaches, and it is once a week dose. That's why the compliance is better. You just tell her to take it every Monday or any weekday, every Sunday you can tell her. So better compliance. So fewer side effects, better compliance, and much lesser resistance. So that's why cabergoline is the preferred drug for stopping the breastfeeding. Now identify the maneuver used for the delivery of the head here. You can see when the head is coming out, then there is a hand of the doctor which is going to the chin of the baby. There's a hand of the doctor going, okay, like this. It is something, okay, you can make out. Yes, the doctor is putting a hand and pulling the chin forward. So the head delivers by extension. You remember that? Yes, sir. Yes, can you see this? The head will deliver by extension. So when the head delivers by extension, it stretches the vagina. See, I'm showing you the pelvic floor here, and it stretches the vagina. Which stretches the vagina can tear. So to prevent the sudden extension, sometimes the mother pushes very hard and causes sudden extension, and that sudden extension will tear the perineum. So that's why we put a hand through the perineum It is not in the anus or in the, you know, the area around the anus. So it may touch the anus. So that's why there's a cloth on our hand. So we go to the perineum, and through the perineum we hold the chin of the baby and pull the chin forwards. So it causes controlled extension. See, it causes controlled extension of the head, and that's what stretches the perineum in a controlled manner and prevents perineal tears. So that's why, to prevent perineal tears, we can do a controlled extension of the fetal head by pulling the chin forward. So that is what is known as the Ridgen maneuver. Lovset's maneuver is for the extended arms. It is for the extended arms in breech, and Pinard maneuver for the extended legs in breech. So breech में याद रखिए, legs and flexed arms come out easily. Extended legs we do Pinard maneuver, and extended arm we do the Lovset's maneuver. And Gaskin maneuver is for shoulder dystocia. So yes, shoulder dystocia I discussed in the the predictor 50 also. Just remember, shoulder dystocia, we always say Mack-Roberts maneuver first, and it came 2 weeks back in the INICT exam also. What is the first thing to do in a case of shoulder dystocia? It's always the Mack-Roberts maneuver, where you flex the hip joint more than 90 degrees, and then you can give a suprapubic pressure. If that doesn't work, you can do a corkscrew maneuver of the head, and if that doesn't work, you can do the Gaskin's all four maneuver. If that doesn't work, push the head back inside and do a cesarean section, which is known as the Javanelli's restitution. So that is there in the predictor 50 questions, just around I think it was on 13th of this month. So you can see that also if you want. Now let's move on and see something else. Outlet forceps is which of the following? Outlet forceps is a little lower station, +5, +4 station, +3 station. We can put an outlet forceps. +2 we do a low forceps. Above +2 we don't put forceps and vacuum. These days, please remember, modern obstetrics, we do forceps and vacuum at +2 and below. So when we say +2 and below, that is what is the forceps and vacuum. So +2 pe we do the low forceps. So low forceps is the Simpson's forceps. Low forceps, Simpson's will be a longer forceps because it has to go higher. Wrigley's forceps is known as the outlet forceps. This is a shorter forceps because it doesn't have to go too much inside. Okay. So this is Wrigley's forceps is when the head is on the pelvic floor. Head is on the pelvic floor. I don't know whether you can read that. Maybe I wrote it too small. I'm reading it for you. Head is on pelvic floor. So then we use the outlet or the short forceps, and +2 pe we call it the low forceps. The Simpson's longer forceps is used. Piper's forceps is for the after coming head in breech. I'll explain this. So what happens in breech? The baby comes out, the body comes out. Suppose this is the head of the baby and my arm is the body of the baby. So the breech has come out. The breech is here and the head is inside. So when the body of the baby comes out, and end mein there is a head which is to come out. So this head is now called the after coming head in breech. Head is coming after the breech, obviously. Pehle breech nikal gaya, now the head comes. So we call it the after coming head. So for the after coming head, we have these forceps known as the Piper's forceps. So Piper's forceps goes, and in a breech we can apply forceps, yes, but not on the breech. In breech presentation, can forceps be applied? Yes, but don't think that I am applying the forceps on the breech. The forceps in a breech delivery is for the head which is coming after the breech. It's called the after coming head. So Piper's forceps is for the after coming head. It's a phrase, after coming head. The head which comes after the breech comes out first. So after coming head के लिए Piper's forceps है. Keelan's forceps are the rotational forceps. I mean, this is all NEET exam questions, but what the hell? Why don't you think that they can come for you? They can come for you also. All right, guys, chaliye. A 34-week fetus with the intrauterine growth restriction has a biophysical profile of 4/10. What does this indicate? So, biophysical profile is 5 things, all of you know: NST, then fetal movement, fetal tone, fetal breathing, and the amniotic fluid index. So, 10/10, because all these 5 get 2 marks each. 10/10 is the best one. So, 10/10 is the best biophysical profile, and the 8/10 is the ओके चलो मान लेते हैं एक्सेप्टेबल है. 6/10 onwards, less than 6/10, we say there is compromise. So 6/10 is the one which we say equivocal. Okay, so 4/10 is not reassuring fetal status, it is not equivocal. High risk of fetal hypoxia is correct. No intervention required is also wrong. So 4/10 is a high risk kind of a baby. So I just thought I'll tell you that biophysical profile is the non-stress test, fetal movement, fetal breathing. See, the baby is not breathing inside the body of the mother. Baby is swallowing fluid. So every time he swallows, see, the chest will expand a little. So the swallowing movements look like breathing. So NST, fetal movement, fetal breathing, fetal tone, the act of flexion and extension, fetal tone, and the amniotic fluid index. So this is known as the biophysical profile. So NST itself takes 20 minutes, 10 to 20 minutes, and all of these will take also another half an hour odd. So 1 घंटा लग जाता है biophysical profile करने में. So MCI का question is classical modified biophysical profile. Please do not forget this one. That is amniotic fluid index plus the non-stress test. This is what is asked in exam many times, because biophysical profile takes a lot of time. This will take around 15 to 20 minutes only, and that's why we do more modified biophysical profile. Why? Because it is just as good and it is shorter duration of a test. So amniotic fluid index के ऊपर बहुत questions आते हैं, तो उसके बारे में बात कर लेते हैं थोड़ा बहुत. Amniotic fluid index, all of you will have this question, so I thought we will deal with it now itself. So amniotic fluid maximum at 32 to 34 weeks, and at 40 weeks it is actually reducing. So 32 to 34 weeks it's around 1000 ml, and 36 weeks it is actually now reducing 800 ml, and at around 40 weeks it's around 600 to 800. A lot of people say that also, but 600 ml is what we teach you. So the maximum is at 32 to 34 weeks, and only in your exam, MCA exam, only the choice came. And I remember that question because hundreds of students told me when we were doing this revision that 28, 32, 36 and 40. When is the amniotic fluid index maximum? And only this 32 choice was there. 32 to 34, both are correct, because the highest is around actually 33. 32 to 34 के बीच में peak आता है. So that's why we say they will give you either 32 or 34, but in your exam it came as 32, the choice. That's why I'm teaching you that if they ask you one, you must mark 32. Only in MCA exam it came, I think 3 years back, and all students said, sir, 34 was not even in the choice. So both are actually correct, and 32 has come in your exam. That's when the Likert is maximum, and 36 weeks it is reducing. That's why we say 36 weeks pe the uterus is relaxed. 36 weeks pe uterus is relaxed, and the Likert is reducing, and the baby is bigger. Baby is getting bigger now. So that's why 36 weeks pe we do the external cephalic version. That's why external cephalic version is done at 36 weeks, because that's the time when the Likert is now reducing and the baby is bigger. So if you turn the baby, he'll stay turned. All right, 10 minutes dinner break. अरे अभी तो break दिया. अभी तो ब्रेक दिया गाइस. थोड़े से क्वेश्चन रह गए, उसके बाद एक लंबी ब्रेक ले लेना यार. यार तू ब्रेक ले ले यार. You can see it in the recording. What do you say? Not happy? अभी मत लो यार. 10. I think we just gave you a break, and it's 9:15. I think another half an hour, 45 minutes, we should be able to finish. So this is the interpretation of the biophysical profile. So biophysical profile, if you see here, biophysical profile, the 10 by 10 is the normal fetus, 8 by 10 is the normal with a normal AFI. 8 by 10 with normal AFI is a normal fetus. 8 by 10 with a decreased AFI is hypoxia, asphyxia rather. And 6 by 10 with a normal AFI is equivocal. You can repeat it. But 6 by 10 with decreased AFI is a hypoxic baby. So I said 6 by 10 is equivocal if the amniotic fluid index is normal. So remember, this is the perfect, the complete interpretation of the biophysical profile. I've given it to you. You can keep it with you and you can read it again. But remember the basics which I gave you. 10 by 10 is best, 8 by 10 is acceptable. Of course, the AFI should be normal. And then 6 by 10 is equivocal. You must repeat it. But 6 by 10 is equivocal if the amniotic fluid index is normal. Otherwise, without a normal AFI, that is also bad. Okay, you can read that. I'll take a quick swig of water. Right. A 30-year-old lady with primary infertility is being assessed for ovulation. She has regular menstrual cycle. A day 3 transvaginal sonography shows multiple growing follicles, serum level of which hormone can help you confirm ovulation. So yes, we discussed this partly in the earlier questions in this revision session. And you know, when the woman ovulates, the progesterone will be high. We discussed endometrial biopsy earlier. So serum progesterone will tell you that she is ovulated. So day 21, progesterone levels, if they are more than 3 nanograms per ml, then it is ovulation. So this is progesterone. Now what is the best test? Best test, you know, if you want to know the test which is available, then we say best test for detection of ovulation is the laparoscopy. Now this gold standard and the best test and the first test, like this, the equations will not come in the exam. In exam, they'll give you a situation. A woman wants to check ovulation, which is the best possible test which can document the ovulation best. Obviously, that is laparoscopy. You do the laparoscopy, you see the corpus luteum, she has ovulated. But how do you usually document ovulation? Like today, I had some, it's a Tuesday, it was my OT day, and by the time my fellows start the OT, you know, 8 o'clock they will go to the OT, and by the time I reach 8:30, I start the cases. Half an hour I'll be doing the follicular monitoring. And every day, something like 11, 12 patients I did follicular monitoring. So you think I did 11 laparoscopies today morning just to check whether they're ovulating or not? Not at all. So the usual method, the OPD method of checking ovulation is by ultrasonography, the follicular monitoring. So this is the usual method. How do you check ovulation day in and day out? Usually in the OPD by an ultrasound, by transvaginal sonography. But if they ask you the best possible documentation is laparoscopy. Everything, wherever you can put a scope, that becomes the best procedure. But can you do it for every patient? Obviously not. So this came in the MCI exam. PID diagnosis, laparoscopy. Ectopic diagnosis, laparoscopy. Endometriosis, laparoscopy. So laparoscopy, wherever you can do, is the best diagnosis. But do you do laparoscopy for all PID patients? No. While doing a laparoscopy, you see inflamed uterus and tubes. It's a best diagnosis. While doing a laparoscopy, I see a corpus luteum. Best diagnosis. So they'll ask you very good language in the exam. Don't get nervous. So you are saying laparoscopy, but they are saying it is the serum progesterone level. Somebody else is saying endometrial biopsy. ऐसा नहीं होता है. They'll ask you very clean, straightforward question in the exam. There'll be no ambiguity. Only the guides and the recalls and the number of us which are teaching you, that confuses you. 35-year-old multiparous woman presents with dragging sensation in the lower abdomen. On examination, second degree uterocervical descent is noted. Prolapse. How is a second degree prolapse defined? Yes. Now that is descent of the cervix up to the vaginal orifice, and just coming from its place in the vagina is known as grade 1. To the vagina, grade 2. Outside the vagina is grade 3. So just coming up to the vaginal orifice is known as grade 2. Okay. So to the orifice. See here, if it is like this, now if it is coming halfway to the orifice, see, this is grade 1. If it is coming till the level of the orifice, see, like this, that is grade 2. and if it is coming outside the vagina, that's the grade 3. And now it is totally outside the vagina like this. The uterus is outside the vagina and you can get above it. That is what is known as a procedentia. So this is normal. This is grade 1. This is grade 2. It is still the vaginal orifice. Grade 3 coming outside the vagina, and grade 4 is the procedentia. This is the simplest way. Nowadays, the best way, the best classification is the POPQ. POPQ will also be used to tell you this only, but I've just mentioned that the best classification is the pelvic organ prolapse quantification system. Fortunately, how you do it and how the assessment is done has fortunately not come in any exam so far, but the name POPQ has come. So I'm not teaching it right now. It's going to take around an hour or so for you to understand the POPQ. So just know the name, and this is how the result of that is the grading of prolapse which I've given you. Chalo. What type of uterine fibroid is depicted in this image here? So you must know the FIGO classification of fibroids, where you are seeing all the fibroids start in the muscle, that is type 4, and then when they go outside 5, 6 and 7, and when they go inside, so from 4, 3, 2, 1 and 0. So remember, 0 is inside the mucosa, submucosal, and type 7 is subserosal. So this is what, where you see the uterus here and you see a peduncle here, pedunculated large fibroid from the surface. So that is what is known as a subserosal fibroid, subserosal or type 7 fibroid. So you must have a quick look at the FIGO classification of fibroids also. It is a regular NEET question, but subserosal, submucosal to aapko bhi pata hona chahiye. It's not that MCI exam is a lesser exam, but MCI exam will have a somewhat more number of easier questions. The topics are the same and the classification and everything is the same. Just that the total number of questions are easier. That's all. Otherwise, you also have the tough level of questions which are coming in the MCI exam. So what anatomical anomaly is shown in this image? Now this is a very straightforward image of a biconvex. Two horns of the uterus are there, and then there is a common cervix here. So that's why it's a biconate uterus. Septate will look something like this. Septate will look something like this. All right. So there will be a septum here like that. So the best possible way, this is a biconate uterus. The best possible distinction is by a laparoscopy and a hysteroscopy. Laparoscopy and hysteroscopy is the best possible distinction between a septate and a biconate uterus. And of course, on HSG, there are a lot of things. In HSG, this intercornal distance is more than 4 centimeters on HSG, and this intercornal distance is less than 4 centimeters on hysterosalpingography. And this angle on hysterosalpingography, this angle is acute in a case of a septate uterus, and it is obtuse. See, it is obtuse in a case of a biconvate. All right, but the best distinction, please don't forget, the best distinction is always the laparoscopy and the hysteroscopy. Right. What is the procedure performed using the instrumented depicted here? It's a very smart question. Instrument image based, we have, I think it has already been made live. I'll just see and give the link in this chat. The image based has been made live. If it has not been made live, I'll check tonight and tell you. The image based, the complete questions in 2 segments. The team decided to make it live for you guys, so that also you can have a quick revision, because if I start doing that, it will take a lot of time. So image based, I got you this image here for this session. This is a tip where you can see there is a hole with some serrations. So you can go in the uterus and do a curette of the uterus with that. This is the Randall's curette. Randall's curette. Randall's curette for a endometrial sampling. Endometrial biopsy, endometrial sampling, you can say that. Randall's curette. Identify the type of pelvis shown in the image. nice and rounded cavity. See this cavity here also you can see. See, if you see this cavity, just like the picture given there. Okay, can you see here? Can you see that? Nice and round cavity here. See, nice and round cavity. This is a nice gynecoid pelvis, round cavity. Now, if you see the gynecoid pelvis, that is the most common type of pelvis. So, gynecoid pelvis is the most common. Now, what are the other types of pelvis? So, if you see the gynecoid is the most common, the second most common is the anthropoid, and the rarest pelvis. The rarest pelvis is the platyploid or the flat pelvis. So, gynecoid has a good round cavity, and anthropoid, the side walls are parallel. So, that's why no rotation possible in this pelvis. That's why this is a favorite MCI question. So, gynecoid pelvis, if there is a baby which is coming with occipito posterior, suppose there is a occiput, sorry, suppose this is the occiput, this arrow is the occiput, it can rotate, rotate and rotate to anterior because nice gynecoid pelvis. So, rotation is possible in this one. But if there is a gynecoid, if there is an anthropoid pelvis, this rotation is not possible. This rotation is not possible in a case of a anthropoid pelvis. So, no rotation possible. So, that's why occipito-posterior delivers as occipito-posterior, which I showed you earlier, which we call it the phase 2 pubis delivery. Phase 2 pubis delivery. I showed you that earlier. Quickly, I'll show that to you again. So, this is the occipito anterior which is coming out. Now, suppose it's an anthropoid pelvis and it stays occipito-posterior. I told you occipito-posterior also delivers, but when it comes out as delivery, occipito-posterior, this is occiput posterior. If it comes out in delivery, can you see the face of the baby? It is looking at the maternal pubis symphysis. See, the face is looking here to the pubic symphysis. So, phase 2 pubis is seen in a case of a anthropoid pelvis. No rotation is possible. Android is a male type of pelvis. See, the front walls are narrow, and platyploid, the anterior posterior walls are narrow. So, remember this diagram at least. So, anthropoid has parallel, side walls are parallel. Android, the front walls are converging. See, it's a male type of pelvis. Platyploid, anterior posterior flattening is there. So, platyploid, you'll see a face presenting part. Right. कौन सा part कभी समझ में नहीं आया? There's a slightly more delay today. I think you have gone ahead and you are still, I think, 2 questions behind. So, never mind. You can always ask me questions and I'll keep answering. So, please tell me किसका ये part मुझे समझ नहीं आया. Which one you are reading? You can tell me. Okay. All of the following are true statements regarding the instrument shown. Okay. This is the instrument shown. What are the true statements regarding that? So, this is the MVA syringe. This is the manual vacuum aspirator syringe. Now, this is a hot shot question in MCIs, and it is used for MTP till 12 weeks. Yes. Can be used without electricity. Yes. It's got a very nice system where you can see there are 2 flanges here. Can you see here? There are 2 arms here, upar or either. So, when you pull out the syringe like this, when you pull the syringe, the piston like this, the arms open up and they'll rest at the base of the syringe. So, it will stay pulled. ये खींचेगा खींचा रहेगा. उसकी वजह से there will be continuous suction. So, that suction which is made will make sure that this syringe will have at least 600 to 660 millimeters of mercury pressure. So, that will cause a good suction on the baby. All right. So, what is wrong? Can be used without electricity? Yes. Capacity is 30 ml. No, the capacity is actually 60 ml. This was MCI question. Pressure generated is around 600 millimeters of mercury to 660. That is correct. Okay, so that's a fairly simple question. Of course, this is attached to a Carmen cannula. A Carmen cannula is used, and this Carmen cannula goes into the uterus. The baby is here, and that baby is sucked with the negative suction which is made in that syringe. So that common cannula, the size of the common cannula used is the gestational age. So 8 weeks pregnancy है तो 8 size common cannula use किया जाता है. Right. So pre-swab test is being performed in which the middle swab is stained. From the given clinical history, where should be the leak suspected? So yes, pre-swab test is formed. So when a woman comes to you with a dribbling of urine, that dribbling of urine is known as a incontinence. That dribbling can be because of a fistula also. It can be a uretrovaginal fistula. It can be a vesicovaginal fistula. So yes, when there is dribbling of urine, mostly you are going to think of vesicovaginal fistulas most commonly. All right. So we say vesicovaginal fistula. That's the most common fistula you will see, and that is mostly because of obstructed labor. It is because of obstructed labor. I'll try to tell you a little bit about this obstructed labor. So in this, what do you see? That when there is a obstructed labor, what is the meaning of obstructed labor? In spite of good contraction, the head is not delivering. In spite of good contraction, the head is not delivering, and this head is very big. So this head compresses. Can you see? The head compresses the bladder against the pubic symphysis in obstructed labor. So obstructed labor अगर आपने labor में diagnose कर लिया है तो उसका there is only one management, that is cesarean section. Cesarean section, nothing else. Even in dead baby, even if it is a dead baby and it is obstructed labor, you have to do a cesarean section only. Now, if it is an obstructed labor which is neglected, let's say in a village, and there is a compression of the bladder neck against the pubic symphysis, that causes the ischemia here. It causes the ischemic necrosis. It causes the ischemic necrosis of the bladder neck. And then this ischemic area, because the bladder, the compression by the head, this ischemic area will slough off in 5 to 7 days. This sloughs off in 5 to 7 days, and it presents with dribbling of urine. So dribbling of urine presents in 5 to 7 days because the ischemic area will slough off. So that is what is the presentation because of obstructed labor. Now, when there is this presentation in 5 to 7 days, these cut ends are ischemic. So do not repair it immediately. These cut ends are ischemic. So if you put the sutures, on a ischemic area, then they will become a much bigger defect, because if you put sutures now, she's come to me 1 week after delivery in the village and she's got a vesicovaginal fistula. So the cut ends were ischemic. ये ischemic थे तभी तो slough off हुए ना. Now they are ischemic and I put the sutures. It will make a much bigger fistula. What was just a fistula will become the gateway of India. It will become so big. So that's why we say if there is a fistula, do not, it is because of ischemic necrosis. So do not repair it immediately. You wait for something like 3 months. Yes, 3 months तक wait करते हैं for scarring. Wait for 3 months for the scarring of these tissues, and then whatever sutures you put will stay, will sit there and prevent the woman from having any more dribbling. So for 3 months, she'll be wearing diapers. She'll have continuous dribbling for 3 months. But you wait for the, or you can put a catheter. A catheter will divert most of the urine. Some leaking will be there for which she has to wear a diaper. But yes, 3 months you have to wait. And the constant wetting of the thighs will cause excoriation. Chota ulcers ho jata hai. So we put zinc cream on the thigh and the vulva to prevent the ulcer formation. So wet thighs, when they rub against each other, they'll cause small ulcers. Isn't it very distressing situation this? So 3 months of scarring and then you do the repair. I hope you'll remember that. Now what is a 3 swab test? Now 3 swab test is to localize the fistula. 3 swab test, you put methylene blue in the bladder and put 3 cotton balls in the vagina, and you make her walk for 5-10 minutes. So depending on the site where the fistula is, the cotton ball will get blue in color. So if it is a high VVF or a low VVF or a mid VVF, you can make out. So this mid-vaginal VVF is the most common VVF which you see, and it is because of the obstructed labor. Obstructed labor is the most common cause of this mid-vaginal VVF. The high VVF can be because of vaginal surgeries like gynecological surgeries like hysterectomies, even forceps. And low VVF can be because of injuries, trauma, can also be because of radiation. Okay, but mid-vaginal VVF, that will come in the exam, you should know that. And 3 swab tests will tell us. Now, what is the best test? Now, that is what is something which you people will answer wrong. Best test is not 3 swab tests. 3 swab test is a good OPD test. And all of you understand also very well. कि methylene blue डाल दो bladder में and यहाँ पे 3 cotton balls डाल दो and tell her to walk. And the ball which gets blue in color, that is the site of a fistula. This is one test you understand also easily. But the best test is not this. Best test is to put a scope. Yes, everywhere scopies are best. So put a scope into the bladder and go inside in the bladder with a cystoscope, and then you see the site of the fistula best. The best test is always the cystoscopy for the localization of a vesico-vaginal fistulas. There are many other fistulas. I'm not going into the detail of that right now. Chali. Let's move on and see something else. A 34-year-old Rh negative woman delivers a Rh positive baby. Indirect cum test is negative during the pregnancy. By when should anti-D immunoglobulin be given postpartum for maximum effectiveness? So yes, mother is negative and the baby is positive. Moment the baby's positive blood comes, she will get sensitized to the positive blood, the D antigen. Rh positive means the D antigen will come into the mother and mother will make anti-D. So before the mother gets sensitized, you give the anti-D. So the anti-D which I give as an injection, वही पूछ रहा है वो कि anti-D कब देते हैं? Before the mother recognizes the D antigen. So delivery हो गया. Moment the delivery happens, yes, you can see, I can try and explain to you. Moment the delivery happens, the placenta is here, the placenta separates and the blood of the baby goes into the mother. Now the mother has got contaminated by the D antigen. She was about to make the anti-D, but you gave the anti-D from outside in an injection. So before the mother recognizes, you should give the anti-D from outside to neutralize the fetal D antigen. So yes, before the mother recognizes. So mother takes 3 days to recognize the D antigen. So within 72 hours is the best. Within 72 hours is the answer, is the best time to give the anti-D. You can give up to 4 weeks for some benefit. Some benefit is up to 4 weeks, okay, but best is within 72 hours. Now, let me show you something. The pregnancy management, because a lot of times this question also comes in MCI exam. So, what is the antenatal management? Suppose the mother is Rh negative and the father is Rh positive and they come to the OPD. Even in the first pregnancy, the mother can get sensitized during the pregnancy because of a small transplacental bleed can happen. Even in the first pregnancy. Don't say first baby always survives. First baby mostly survives. So, chalo, फिर से शुरू करते हैं. Mother negative, father positive, they come to the OPD, do the indirect cum test at the diagnosis of pregnancy. This checks for anti-D, antibodies. Moment the mother comes to the OPD and she's Rh negative, I'll do the ICT and the ICT is negative. That means the mother is not exposed to the D antigen so far. So, this pregnancy is looking like a safe pregnancy. So, if ICT is negative, that means the mother is not yet sensitized to the D antigen. Do the monthly indirect cum test from 20 weeks. 20 weeks पे ICT is negative, 24 weeks में ICT is negative, 28 weeks में ICT negative, 32 पे negative, 36 पे negative. That's how the pregnancy is continued. 40 weeks पे do the delivery plus give the anti-D. एक चीज याद रखो, the KB test, clear habit kit test is done to check the exact amount of anti-D you have to give. That is also one extra point we should learn. After delivery, give anti-D within 72 hours. But find out how much blood from the baby has gone to the mother by the KB test, quantitative test. You find out how much blood from the baby has gone to the mother, give the exact amount of anti-D. यहाँ तक हो गया? Now, we also give a prophylactic anti-D at 28 weeks. How much? 300 micrograms anti-D is given at 28 weeks also, like a Suraksha Kavach, like a prophylactic anti-D. You know what happens at 28 weeks and beyond? Transplacental hemorrhages can happen during in the first pregnancy. Thoda sa blood because of small injury on the abdomen. She sits with a jerk on the bed also, she can have that. She has a coital relation, she can have that. Chota sa bleed can happen during pregnancy around 28 weeks and beyond. So what we say, at 28 weeks, you put a anti-D into her body. give her an anti-D in the body, and moment the D antigen comes, because of whatever event, moment the baby's D antigen comes, you've already given prophylactic anti-D into the circulation. So that's what was your question. What is the prophylactic anti-D? This is MCI question. That's why I'm trying to tell you. I know you're getting tired, and some of you who've been sitting from the beginning are now saying ki kab khatam hoga, kab main dinner khaunga. But guys, that's why I said after today no more gynae reading. I've tried to cover all the topics. So gynae knobs finish. Ab दूसरे subject भी पढ़ने यार. तो याद रखो prophylactic anti-D you give at 28 weeks and after delivery. So that is what your question came. Prophylactic anti-D. 28 weeks, give 300 micrograms, and then at delivery, again you give 300 micrograms. Right. So that's about this. Let's move on. A 32-year-old woman has placenta covering the internal os on ultrasound at 20 weeks. She has no bleeding. What is the next best step? So 20 weeks pe, yes, at 20 weeks pe, it was a case of a placenta previa. So later in pregnancy, when there is effacement and increasing in the size of the uterus, this placenta actually could go up because this part has got effaced and it has made the lower segment. So cervix has got effaced. So the placenta, which is actually placenta अपनी तरफ से ऐसे move नहीं करता है. Placenta is attached where is attached, but the cervix has got effaced. So with the effacement, the placenta may move up. So what was initially a placenta previa may become a normal placenta later. So plan elective cesarean at 38 weeks? No, not required. You will check. So advise termination of pregnancy now itself? No, not at all. Repeat ultrasound at 34 to 36 weeks for placental localization, because what was a placenta previa earlier may go and become a upper segment placenta. Remember, vaginal examination is never done when you know it's a case of placenta previa. This is one question which came in NCI, that if a woman has come with placenta previa with vaginal bleeding, don't do a PV. That was your question, whether you'll do a PV or not. Obviously, you will not do a PV. All right. Okay, Harish Swami, thank you for the comment. Maybe it's hopefully I'm trying to finish as much as possible. Thanks, guys. Do not matter. Okay, let's move on. A 26-year-old woman with 34 weeks of gestation presents with watery vaginal discharge. Pooling is seen in the speculum examination, which is the most specific for confirming the rupture of membranes. Now, remember, premature rupture of membranes is a drastic situation which can happen, and you may have to do a termination of the pregnancy because infections can happen. When the bag ruptures, vaginal infections can go into the uterus. So yes, 34 weeks pe gestation pe agar watery vaginal discharge hai, and if it is premature rupture of membranes, so the risk of infection risk is very high. So 34 weeks में तो डिलीवरी कर सकते हैं because the lung is mature. Before 34 weeks question आएगा तो बहुत complicated answers हैं. So that's why they are not asking in NEET also and MCI exam also. So after 34 weeks is the rupture of membranes, you can deliver. And how do you know it's actually a rupture? You can put a speculum and see the water collecting. That is one thing. But sometimes we don't see it so clearly. The woman comes and says, "Sir, when I was sitting in the house, I had some gush of water, and I see the vagina. Examine, अरे vagina तो dry है, तुम्हें पानी आया था कि यूरिन तो नहीं छूट गया था?" अरे, I don't know, sir. So how do you realize that it is actually leaking and not micturition by a sudden event of loss of urine? So yes, you can take this fluid from the vagina and you can do the nitrogen paper test. So if it is blue in color, then that is alkaline pH in the vagina, and with the alkaline pH, you know it is premature rupture of membranes with the alkaline pH. Ferning test, again it is because of premature rupture of membranes. Ultrasound for amniotic fluid, reduction in amniotic fluid index will also tell you that the patient has a rupture of membranes. but the specific test, that is why more specific test aa gaya. So that is the PAMG1. Yeah, it is written here, PAMG1 test. So this is a NEET exam question, the placental alpha microglobin 1 test. This is present only in the amniotic fluid. So that's a specific test. So if it is coming in the vagina, then it is definitely a test. So आजकल आ जाता है कि जो इसका जो sensitizing, इसके जो reagents होते हैं, we put it in a pad and apply the pad on the vulva and tell her to walk around for some time. So if it is coming in the vagina, it will come in the vulval pad and the indicator test will come positive. So PAMG1 is the specific test. That's what all of these will tell us. Yes, there is right now one patient in my ward, and patient conceived with infertility treatment, and we were supposed to shift her to the gynae department, but she decided that she'll deliver somewhere else in the city, somewhere else far off, because she's from a very far off place. I'm not telling any names. But what happened? She thinks she has ruptured a bag of membrane. She gave some fluid out with a gush. Now she's right now in my hospital. She came to me and I examined her today. She has a cervicitis. There is some blood in the vagina and the blood is alkaline. So the test, nitrogen paper, when I put in the vagina, it is becoming blue because of the alkaline pH. But there's no fluid. So I said, yes, maybe you burst some fluid because of some vaginitis. Now there is some bleeding. I don't see any leaking coming out. And I do the ultrasound, I see the Liker is 14 centimeter AFI. I've kept her, I've not delivered her. She's only 26 weeks. I'm not going to deliver. I'm going to see her for the next few weeks, few days. And if she's fine, I'm going to send her home. This is what we do practically, guys. ये सिर्फ पढ़ाने के लिए नहीं है. हम PAMG1 थोड़ा एक्सपेंसिव है तो इस पेशेंट के लिए हमने नहीं किया. बट पढ़ाने के लिए इतना बता सकता हूँ, दैट इज द मोस्ट स्पेसिफिक टेस्ट. ये नाइट्रोजन पेपर टेस्ट, लिटमस पेपर टेस्ट हम लोग करके मोस्टली एल्कलाइन पीएच पता चल जाता है. एल्कलाइन पीएच, इट इज सजेस्टिव ऑफ एमनियोटिक फ्लूइड. So let's move on and see something else. A 23-year-old woman presents with acute lower abdominal pain. Ultrasound shows an enlarged 10 centimeter size ovarian cyst which has an absent Doppler flow. So it is very simple that when a woman has an acute abdomen and there's a large 10 centimeter cyst, so this can undergo a torsion. When it undergoes a torsion, obviously the blood supply here will stop. So absent flow on Doppler. Doppler will show me some red and blue flow going up and down from the ovarian ligament. If that has stopped, then we know that the patient has got a torsion of the ovary. So this is a classical torsion. So what do you do for this torsion of the ovary? Immediate laparotomy and do a detorsion. Sometimes if we do this in time, she has acute pain, we go inside and untwist the ovary, then we can save the ovary. But sometimes it has have a torsion for a very long time and you see a totally black ovary. I wish I could show you more videos, but too much of time will be taken. So torsion of the ovary will show you a totally black ovary which is necrotic now. Old torsions, you have to generally do a total oophorectomy. But untorsion and the tissue color becomes from a bluish haze, it becomes pink in color, then we can just take out the cyst and save the ovary. So try detorsion first. All right. A 24-year-old woman undergoes medical termination of pregnancy at 8 weeks with mifepristone and misoprostol. She has persistent bleeding and ultrasound suggests a retained tissue. Now, this answer has been given wrong by so many people, and so many of your students have asked me this question. I included this. What is the most appropriate management? So, incomplete abortion hua hai. Matlab, you've given the MTP pill at 8 weeks, but there are still some products. So, products will eventually expel out? No, don't wait. She'll get sepsis sometimes. Instrumental evacuation or the DNC is the best method. You're making sure, see, you've done a procedure and still it is not completed. You must make sure by doing a DNC under anesthesia. Medical evacuation with increased dose of misoprostol or misoprostol डाल के फिर से try करो. ये सब half-baked measures will make her bleed a lot and she'll get into anemia, and that can be torrential bleeding sometimes. So when the products are half inside and half expelled, it is best to remove it for sure now. Because medical abortion is very good for how many percent of patients? 99% of patients will abort properly with medical abortion till 7 weeks, 95 till 9 weeks. After that also, if something is retained, you won't do continuous medical management. You'll make sure that you'll complete it by a DNC. So yes, only 1% patients will come back to you with retained bits. Do a complete evacuation by a DNC. So don't say this and don't say injection methotrexate to degenerate the remaining nonsense. You'll do a curettage. Okay, chalo. A 34-year-old woman has postcoital bleeding. Speculum examination shows an unhealthy cervix. What is the single most important initial investigation? Guys, this we already discussed. What is the most common presentation of cancer cervix? Postcoital bleeding, and the cervix is looking unhealthy. Please don't do a screening test here. There is a symptomatic patient with an unhealthy looking cervix, so you will do a colposcopy. Pap smear is a test for a normal looking cervix to do a screening test. When an asymptomatic patient comes, I do a screening test. But when the patient is symptomatic, postcoital bleeding, what is the most common symptom of CS cervix? Postcoital bleeding. She has come to you with that. अगर वो करके आई है तो उसके बाद भी you're going to do a screening test like PAPS? No, you will do a colposcopic directed biopsy of the cervix. And if this is non-conclusive, this was INICD question, mind it, okay? If non-conclusive, if it is non-conclusive, then you have to do a cone biopsy. You have to do a cone biopsy, then you have to do. This question is already come in your INICT, guys. And तुम लोग PAPS में बोल के छोड़ देते हो. So if there is a postcoital bleeding, and the next thing you do is colposcopic biopsy. If that is not conclusive, you have to do a conization. And pap smear is a 48% to 62% sensitive test. It is not a very great test. It is a good test to reduce the number of CS cervix, definitely, but it is not as sensitive. So you may miss some bad lesions by a pap smear. Okay? Chalo. So staging of CS cervix, yes. I've given you the staging. Please remember, I've given you color coding here. So stage 1 is limited to the cervix here, and then stage 1A is microscopic cancer. Only by biopsy you can find out. But if it is invading less than 3 millimeters, 1A1, more than 3 millimeters but less than 5 is 1A2. And if it is clinically visible, it is 1B. So still limited to the cervix, black for black. Limited to the cervix, black staging. And if it is seen to me, then it has become microscopic, say macroscopic. Macroscopic is less than 2 centimeters B1, 2 to 4 centimeters B2, and more than 4 centimeters B3. And now, if it is involving the vagina, upper vagina 2A, lower 1/3 vagina 3A, look green code. Please, इस staging को याद रखना है आपने. आपकी books में staging is over 2.5 A4 size pages. All that I've given you in just half a page here. So green is for the vagina, upper vagina 2A, lower 1/3 vagina 3A. Parametrium involved 2B, parametrium involved till the wall, till the pelvic wall 3B. So please, 2A is vagina and 3A is vagina, 2B is parametrium and 3B is parametrium. Okay, be careful. I've given the color coding also. Now, when the growth is from the cervix to the vagina to the parametrium, can you say 3B? Then the ureter gets compressed and there is the hydronephrosis. So 3B has hydronephrosis. That is the most common stage with which women with CS cervix come in India to the OPD. सबसे कॉमन स्टेज क्या होती है जब CS सर्विस के साथ पेशेंट आता है हमारे पास इंडिया में? जब वो पेल्विक वॉल को जाके ग्रोथ इन्वॉल्व कर देती है, सिवियर पेन होता है, एंड द पेशेंट कैन नॉट सिट एट होम एंड शी कम्स टू द हॉस्पिटल. By the time a CS service comes to the hospital, mostly we see a 3B, and there is hydronephrosis already happening. So yes, most common stage presentation is that, and then pelvic and parotid lymph node is C1 and C2, and bowel and bladder involvement. Now, when we say C endometrium and C ovary, the staging I've given to you, I'm showing all of that staging here. You may have to read it yourself also a little bit, but remember, C endometrium is staged by a surgery. CS cervix is staged clinically. This is having a clinical staging, but only cancer in gynae which is staged clinically is CS cervix. C endometrium is staged surgical staging. Matlab, if there is a C endometrium, I know by a biopsy. I've done a biopsy, I know it's a C endometrium. I will do a hysterectomy, and with the hysterectomy specimen, the uterus goes to the path lab and they'll make incisions and see whether it is involving only the endometrium. The path friends will tell me if it is involving only the endometrium, it is stage 1A1. If it is less than half of myometrium, still stage 1A1. Going more than half of myometrium, 1A2. See, all of that you can see here. Then cervical stroma involvement. Path friends will tell me this report. If it is involving the vagina, 2B, 3B, serosa, 3A. So depending on what report the pathologist sent me, I will have the final staging. But if it is a cancer, what do? I do a hysterectomy and send the specimen to the path lab. Path lab friends will make multiple sections. They'll make multiple sections of the uterus and they'll see how much is the involvement and then give me the final report. So it's a surgical staging. Remember, vaginal involvement is the one which they keep asking you. Then ovarian cancer, again, that is also surgical staging. And this you have to do something called the staging laparotomy. We have to do a laparotomy plus optimal debulking surgery. Optimal debulking you have to do. So staging laparotomy and optimal debulking. Take out as much as you can. So ovarian tumor is there, you take out the tumor, and she's 70 years, you take out the other ovary and the uterus. But she's only 17 years, young girl, 19 years with ovarian tumor, take out the disease ovary, save the normal ovary and the uterus. So whatever is optimal, you remove. Along with that, you will do ascites ka cytology. Then ascites agar positive aa gaya, so see, it becomes 1C3. And then if the uterus is involved, it becomes 2A. And if the adnexa is involved and the other pelvic organs are involved, we say it is 2B. Abdomen is involved, we are taking biopsies from the abdomen. We are taking omentum, we'll send. So if the abdomen is involved, depending on the abdomen involvement, we'll get the staging. So this is again a surgical staging. So steps of staging laparotomy. This has come in your exam. What are the steps? It's a detailed discussion, guys, not the forum to do that right now. You must know the steps of staging laparotomy. You make a vertical incision, take the ascites for cytology, do a clockwise assessment of the growth in the abdomen, and then you take the omentum and send it for the sampling, and you'll take peritoneal biopsies, lymph node biopsies. Those are the steps of staging laparotomy. Please see that chapter, okay? The steps of staging laparotomy. It has not come in the last 3 years, but it has come in your exam. Okay, so all these three together I've given you so that you can do a comparative assessment. I'll move out from the screen so that you can see like that. You can do a comparative assessment of all the three stagings. All right, chalo. A 27-year-old woman with heavy menstrual bleeding has a normal size uterus. She is hemodynamically stable. What is the best first-line drug to control the acute heavy bleeding? She's non-pregnant. Obviously, we are making sure that you know that she's not having bleeding in pregnancy. So yes, all of you know, agar fibroid se bleeding hai, cancer cervix se bleeding hai, and agar cancer endometrium se bleeding hai. So all of that classification of bleeding is known as the palm coin classification. Palm coin. Coin mein coin hota hai. So polyp, adenomyosis, leiomyoma, and malignancy. Then coagulation defects, ovulatory defects, endometrial causes. So these are the structural defects, and these are the non-structural causes. So structural causes and non-structural causes of abnormal uterine bleeding. So abnormal uterine bleeding ke PIGO classification is the palm coin classification. So if a woman is having fibroids and bleeding too much, we say she is having abnormal uterine bleeding because of leiomyoma, AUBL. Agar adenomyosis ki wajah se, to AUBA. So these are structure change ho gaya. Polyp aa gaya, adenomyosis also 12 centimeter, 14 centimeter size uterus. Leiomyoma mein structure change hai, malignancy mein hyperplasia hai, structural change hai. Agar coagulopathy hai, clotting time is bad. There is no structural defect. So structural and non-structural, and this is how we say adenomyosis ki wajah se AUBA, leiomyoma ki wajah se AUBL. So this is abnormal uterine bleeding. These are the causes. Now fibroid, what do? You do myomectomy in a younger woman. She wants to have pregnancies. Older woman, you do hysterectomy. But abhi kya karoge? She's bleeding. Profuse bleeding karke aayi hai. Immediately in emergency, in anemia, you're not going to do a hysterectomy. So you have to stop the bleeding. Even if she's got malignancy, she's come with bleeding. She's got a polyp, she's come with bleeding. She's got a coagulopathy, she's come with bleeding. So any abnormal bleeding, you stop the bleeding first. So pakka treatment depending on the cause which you find out. But how do you stop the initial bleeding? So first line management is always the NSAIDs and the antifibrinolytics. So tranexamic acid is the answer to this question. Okay, agar NSAID hota, that is also the first line drug. So first line, the first are the NSAIDs and the tranexamic acid, antifibrinolytics. Okay, and the second line treatment are the hormones like progesterones and estrogens, and third and the last line are the surgical management, which could be the DNC, and it could be the ablations, and can also be the hysterectomy. These are the mostly we are able to stop the bleeding by the NSAIDs and antifibrinolytic and sometimes hormones. Then अगर emergency में जरूरत पड़ा तो surgical management like DNC, ablation and hysterectomy भी करनी पड़ती है, but that is rare. So you stop the bleeding first, and mostly this is enough, and then you do the pakka treatment of the causes. So what is the first thing you give? You give the tranexamic acid, right? What are you guys asking me? Okay, a 32-year-old woman with PCOS and infertility is obese. What is the single best first step to improve ovulation and fertility outcomes? By God, finally one simple question and one simple answer. First line management in always in PCOS is lifestyle modification, weight loss, and weight loss itself 15% will ovulate. 15% ovulation will happen just by the weight loss. 15% ovulation will happen just by that. Right. A 30-year-old woman presents with secondary amenorrhea after a history of curettage for an abortion. She has no withdrawal bleeding after estrogen progesterone challenge. Most likely diagnosis. ये तो repeat हो गया question. Secondary amenorrhea after curettage for an abortion. So slightly similar question which we did earlier, and that is Escherman syndrome. Okay. So if you have a PCOS or PMOS, then progesterone. If progesterones are given and stopped, progesterone से secretion हो जाएगा, you give it for 5 days and stop, then there will be shedding, bleeding happens, bleeding occurs. So this is done, bleeding occurs many times by just by this. So yes, remember, if you give progesterones and on stopping progesterone she has bleeding, that means estrogen were already there, and that's why your progesterones worked. That's why progesterone withdrawal will work when there is estrogen already present. That can happen in PMOS or PCOS. But if giving estrogen and progesterone still not bleeding, that means the endometrium is totally destroyed. Then the answer is Escherman syndrome. All right. What if the patient is already low weight? Okay. That's a good question. That's a good question. He is asking me a question about the PCOS. Yes, lean PCOS is known to happen. Lean PCOS is known to happen. Why not? So, we've asked you about the classical PCOS with the obesity. So, losing weight will increase the insulin sensitivity, and a lot of women will ovulate. Now, if she is having low weight, lean PCOS, depends on what she's come to me with. She's come to me with 32 years and she's not having children, I'll give her letrozole or clomiphene citrate. If she's come to me with, sir, I have 2 children, but I want regular cycles, I'll give her COCPs. And if she says, no, sir, I'm only 17 and I'm having this hirsutism, I'll give her anti-androgens. I'll not tell her to lose weight, obviously. Yes. So, lean PCOS is a very well described situation, can happen to a lot of girls. Chalo. Sir, till what time? Maybe I've got a few more questions. Let me just. I'm blocking your view for a minute. Don't get upset. It's not going off air. Yes. I'm still here, guys. Not to worry. Very much here. very much here, guys. I'm just seeing the questions which you guys. Okay. Where were we? Okay, let's quickly do a few more questions. I know rather long questions. You guys must be needing to revise your things also. I'll just tell you the answers now. Maybe I'll reduce the teaching content for some time. Okay, a 25-year-old woman has a history of one previous lower segment cesarean section. She's now 39 weeks and wants a trial of normal delivery. Previous cesarean, can you do normal delivery? Which is the most important contraindication? Previous LSS transfer scar is we can do. Previous classical cesarean, we cannot do. Interpregnancy interval of 18 months. Yes, more than 1 year is okay. So this is fine. Maternal age 25 years also is fine. So which is the most important contraindication? Classical cesarean we cannot give. So when you give a trial for previous lower segment cesarean section, the only thing you're worried about is the rupture, and rupture is 0.5 to 2% only in previous LSCS. But in a classical cesarean, the rupture is 8 to 10%. That's why we don't give in this one. So this one you knew well. A 29-year-old woman has a 7 weeks ectopic pregnancy. She is stable. Beta HCG is 1800. No fetal cardiac activity and adnexal mass is 2.5 centimeters. So HCG is 1800 and it is 2.5. So what can you do? So I told you for this you can do a medical management, and that can be a single dose methotrexate therapy. This we already discussed. Methotrexate for medical management you can do, but why not multiple dose? Higher the HCG, we can give multiple dose. Suppose it is let's say 5000 and you want to do medical management, then it is better we give a multiple dose. You give 4 doses on day 1, day 3, day 5 and day 7, and that multiple dose will also be need to be given with some leucovorin rescue. All right. So a 43-year-old woman, para 2 live 2 with abnormal uterine bleeding has a simple endometrial hyperplasia without atypia. Without atypia on endometrial biopsy, what is the best management? Remember, hyperplasia in a 43-year-old woman. Hyperplasia happens because of estrogens. So hyperplasia without atypia and hyperplasia with atypia, they are two different things. So with atypia, you can do a hysterectomy. Without atypia, you can do progesterone therapy. So without atypia, progesterone therapy and a follow-up biopsy after a few months. And if it was with atypia, then hysterectomy if had atypia. Yes, you know this one very well. This question came in MCI exam Jan 2025. So remember, if there is a hyperplasia with atypia, you have to do hysterectomy. But hyperplasia without atypia, you can conserve the uterus by high dose progesterone therapy. A 32-year-old female, para 2 live 2, comes to the OPD with her husband requesting contraception advice. Which of the following is best, is true about the vasectomy procedure? So 32-year-old, para 2 live 2, and vasectomy is done. So vasectomy for the husband, when it is done, what is true about the vasectomy procedure? True. Provides immediate sterility? No. Semen analysis required for confirming azoospermia? Correct. Increase risk of prostatic cancer significantly? Nonsense. It is reversible in all cases with guaranteed fertility? No. It is not reversible in all the cases. It is only up to 30% reversibility. वैसेक्टमी, वैसे ट्यूबेक्टमी अगर करो, किसी का अगर फेलोपियन ट्यूब काट के ट्यूबेक्टमी करके रीनास्टमोस करो, अप टू 80% सक्सेस होता है. बट वैसेक्टमी रिवर्सल इज नॉट सो ग्रेट, 30 to 35%. Yeah, my surgeon friends will generally say around 50%, but it's still not 80%. So vasectomy reversal is not as great as tubectomy reversal. All right. So provides immediate sterility is wrong. Semen analysis required to confirm azoospermia? Yes. Only then we say. So 3 months or 20 ejaculates. Okay. 3 months or 20 ejaculates are required to empty the vas. The vas which is distal, जहां पे हमने वास को काटा है उसके आगे वाला जो पार्ट है वहां पे स्पर्म्स रह सकते हैं for 3 months or 20 ejaculates. So when this time is over, 3 months or 20 ejaculates, after that we do a semen analysis to confirm azoospermia. A 24-year-old primary graduate labor develops variable deceleration on CTG. What is the most likely cause? So we discussed that earlier. So variable deceleration is because of, yes, variable deceleration because of a case of, yes, it is because of umbilical cord compression. Okay, this we've done, we'll not waste much time. A 28-year-old woman at 8 weeks of gestation presents with vaginal bleeding and a closed cervical os. 8 weeks pe bleeding matlab abortion is the thing in your mind. Ultrasound shows a viable intrauterine pregnancy with cardiac activity. So the baby is alive. So the uterus has the live baby inside the ultrasound, and when I do a per vaginal examination, I see this os is closed. This os is closed, and the uterus is the size it should be. So this woman is threatening to abort. This woman is threatening to abort. That is why it is called a threatened abortion. All right, what's a missed abortion? Missed abortion. You do the ultrasound, you see a live baby. And then after 4 weeks, you do the ultrasound, you see the baby is dead. It's a crumpled ball of tissue here, nothing you see. So there is no pain, and there was no bleeding. No pain, no bleeding. So that is what is known as a missed abortion. Right. These are simple things, so I think we can run through them a little bit. A 30-year-old multiparous woman presents with heavy postpartum bleeding after delivery of placenta. Uterus is soft and boggy. What are the most likely cause? Atonic PPH. अब PPH की बात करे बिना हम लोग जान नहीं सकते थे. All right. So yes, if a woman who has delivered is having atonic PPH, what is the management? Please. Most common cause of PPH is the first 24 hours के time में जो होता है, and that too within the first 1 hour. That's why the 4th stage was made. Actually, there are only 3 stages of labor: pain, delivery of the baby, delivery of the placenta. There are only 3 stages, but developing countries, we made a 4th stage because we lose a lot of women to PPH. So 4th stage is examination of a lady for PPH for 1 hour. That is the most common time. So first 24 hours में primary PPH, after 24 hours में secondary PPH, and that first hour PPH is mostly because of uterine atony. Now, bleeding from any part of the genital tract is PPH. Uterine atony is the most common cause. Cervical tear also can cause. Vaginal laceration because of forceps, and vaginal hematoma. Vulval hematoma question came in INICT. There are 2 liters, 2.5 liters vulval hematomas I've taken out. So these hematomas, yes, sometimes juniors don't take the apex. Whenever you go to your internship and you're doing an episiotomy, the episiotomy का apex होता है ना, उसके ऊपर एक stitch लेना होता है. Just above the cut, the top of the apex, you have to take the feeding vessel might be there. And if you don't take that, you may have a vulval hematoma. And vulval hematoma can be 2 liters, 2.5 liters sometimes. And that also is known as a PPH. Bleeding from any part of the genital tract after delivery is PPH. Most commonly it is atonic PPH. Now, PPH management, all of you know, active management of 3rd stage of labor, and that has got some components which are a cause of a lot of distress amongst all of you, but we must finish this today itself. And whenever you have a doubt, come and read to this session of our revision, and I'm sure that you will not get any more doubts. I'm telling you very categorically and very clearly that oxytocin is given at the time when there is delivery of the anterior shoulder. Moment the head comes out and the anterior shoulder comes out, then we know the delivery will complete, because the head is the broadest part, next broadest part is the shoulders. So moment the baby's anterior shoulder comes out, you give the oxytocin. So oxytocin is given 10 international units IM after anterior shoulder delivers. After anterior shoulder delivers, then you do a control contraction, which is also known as the Brandt-Andrews technique. And then after that, are you going to do delayed cord clamping or are you going to do early cord clamping? So yes, you can do a delayed cord clamping, which is done in a country. Early cord clamping is what is given in your Williams. So we do delayed cord clamping. Why do we delayed cord clamping? Because our babies will gain 1 gram of hemoglobin because of delayed cord clamping. So yes, oxytocin is given after the delivery of the anterior shoulder. Then you do the delayed cord clamping or the early cord clamping. That is before this. It is done here. And in our country, we do delayed cord clamping. So first is this, second is this, and third is the delivery of the placenta. So just to revise that when the baby's anti-shoulder comes out, give the oxytocin, then you do delayed cord clamping to increase the hemoglobin 1 gram%, and then you do a control cord traction, give a traction on the cord and give a counter traction on the fundus. That is the Brandt-Andrews method. Now guys, this delayed cord clamping does not increase PPH. ये याद रखो. Early cord clamping also does not cause any harm in the PPH. It does not reduce the PPH also. So you may think delayed cord clamping may cause more PPH. Early cord clamping may cause more lesser PPH. There is no relation. So this has no effect on the amount of PPH. So this is the least important component of the active management of third stage labor, because the next one, uterine massage, is very important. So these three are the part of the active management of third stage of labor, and delayed cord clamping is done in our country because we want to increase the hemoglobin. But classically, if you read your Williams, it is saying you do early cord clamping. So उसी में Williams में ही लिखा हुआ है कि early करो, delayed करो, it does not harm the baby, does not harm the mother by any increase or decrease in PPH. That understood? Uterine massage has to be done. Now you keep telling me that sir 2012 में आ गया था कि WHO says don't do uterine massage, फिर 2020 में कुछ आ गया, फिर अभी latest कुछ आ गया, uterine massage नहीं करना है. But you see, the health ministry of our country is the one which I'm going to listen to. And even in Williams Obstetrics written that we promote uterine massage. Williams Obstetrics, which is an American book, we say we promote uterine massage with the warning that the evidence is not very strong. That is written in Williams Obstetrics. So I'll follow what is given in the books and what is done in my hospital and all the medical colleges. And that is what I'm going to show you here. In every medical college, you can go and see active management of third stage of labor. This is what is given. All medical colleges must have this. Oxytocin, control cord traction. Oxytocin, control cord traction, and uterine massage is done. Okay, and see what is written here. I'll show in highlight. Of course, it is from the Ministry of Health and Family Welfare, and see the highlighted part here. What is written there? For use in medical colleges, district hospitals, and first response units. This chart is there in all the hospitals, and I inquired with 2 of my students who are actually professors now. I'm not going to tell you the name of the colleges, and they are top-notch medical colleges of the country. I called them before this revision also just to confirm, have they removed the posters and put a new poster by WHO saying that don't do uterine massage? Have they changed that? कहते sir आप ये 6 महीने में एक बार क्यों पूछते हो हमसे question? They are my students. I keep asking them just to make sure that what I'm working in a hospital which is having DNB. So I'm not in the medical college sometimes, you know, but I keep going to take the exam so many times and I keep seeing this poster. But I just called my resident who is now a professor and asked, what is happening? So लगा हुआ है poster, अभी भी लगा हुआ है. I said, no, I have to teach my students just to make sure that the poster is still there. So nobody is changing the poster for the next 2-3 years. When the health ministry decides, when the teachers in all these medical colleges change their mind, we will tell you a new answer. Yes, there are updates, they keep coming. ऐसा नहीं बैठे हुए हैं हम लोग कि जैसे WHO बोलेंगे हम लोग बस उस टाइप करके एक पोस्टर बना देंगे और आपको दे देंगे. So keep the updates in mind. They may ask you what is the recommended update. Maybe they'll ask you something like that. लिख देना uterine massage मत करो. आज तक आया नहीं है वो क्वेश्चन. uterine massage कब करना ये जरूर पूछ लिया NICT वालों ने. So yes, this was the question. Arrange the sequence. I don't think you can read that. So I'm just telling you what is written here. This is the set of questions which came in NICT 3 years back. Arrange the sequence for third stage management. Check for the second baby, oxytocin, control cord traction and uterine massage. इसको किस ऑर्डर में करना है ये क्वेश्चन पूछा है INICT वालों ने. करना है तभी तो पूछ रहे हैं ना यूट्राइन मसाज. नहीं करना है बट फिर भी ऑर्डर बताओ. So order is ABCD. That's all. First the check for the second baby, then only give the oxytocin, then you do control cord traction, and then you do uterine massage. Early or delayed cord clamping is not part of it. It is not part of the poster also which I showed you. And this is the World Congress which I was part of this World Congress which was done for PPH management. It was done by the College of, yes, I can tell you these names at least because Lady Hardinge Medical College and the RML Hospital in Delhi conducted this World Congress, and one day was dedicated workshop for PPH management, and this is what was taught there. and this is because it's an international conference and I am quoting from that. So active management of third stage of labor, oxytocin, control contraction, uterine massage. New entries, carbetocin. I agree. Yes, instead of oxytocin, if you use carbetocin, good enough. Right. The WHO update, which has come recently, they say what is the definition of PPH? All of us know that more than 500 ml in normal delivery is PPH, and more than 1000 ml in a cesarean section is PPH. This is the classical definition, and we also teach you significant bleeding. Significant bleeding is more than 1000 ml of blood loss after any labor. That is what is significant bleeding. So these are the definitions which we always know. Now WHO said नहीं यार देखो 500 ml से ज्यादा तो होता ही है, but 300 ml से ज्यादा भी अगर होगा with pulse rate more than 100 or shock index more than 1 or systolic blood pressure less than 100, so that is also a PPH. So yes, ये definition तो हम आपको बहुत सालों से पढ़ा रहे हैं कि any significant bleeding which can alter the homeostasis of a woman is known as PPH, because a woman who is a solid, well-to-do, healthy lady who's got a hemoglobin of 14 grams, if she loses even 1000 ml, nothing will happen to her. But a woman who's got a low hemoglobin of 7 grams and she loses 300 ml, she may have significant loss in her body's homeostasis. So yes, even if 300 ml is there, with these findings, we say it is a case of a PPH. Okay. So yes, these are the new things. By the way, all you interns who are watching this, and all your students are going to become interns immediately in the next 7-8 days. When you go to internship and you go to some of you will get the first posting as gynae. Please write this somewhere. Check the blood pressure of 10 patients. 8 of them in the antenatal clinic will have a BP of 90/60 or 94/60. Already हम लोगों का BP 100 से कम ही होता है. हमारी प्रेग्नेंट लेडीज का, पतली पतली औरतें होती है जो प्रेग्नेंट होती हैं, ऑलरेडी उनका BP 100 से कम है. तो हमारी पेशेंट तो डिलीवरी से पहले PPH करके बैठी हुई है. अगर हम ये वाले क्राइटेरिया लगा देंगे, अभी कहीं नहीं लगाने वाले ये क्राइटेरिया, ओके, कहीं नहीं लगने वाले. हमारे पेशेंट का BP वैसे ही 94/60 होता है. तुम जाके देख लेना भाई. गो टू इंटर्नशिप, यू विल प्रूव व्हाट आई एम टेलिंग यू नाउ. तो ये नहीं होता कि WHO ने बोला हम फट से हमने टाइप करके डाल दिए, पोस्टर निकाल दिए. होगा रिकमेंडेशन, अगर अप्रूव हो जाएगा तो डाल देंगे, समझा देंगे आप लोगों को. लेटेस्ट अपडेट क्या है, अगर ये अपडेट ही पूछ ले आपसे तो लिख देना यार, कोई नहीं पूछने वाला है. ठीक है, चलिए आगे बढ़ते हैं. A 26-year-old woman at 32 weeks presents with painful vaginal bleeding, tender uterus and fetal distress. Most likely diagnosis tender. Painful bleeding and uterus is tender. That is because uterus is bruised because of a blood clot. There's a blood clot behind the bladder. There's a blood clot behind the placenta here. There's a blood clot behind the placenta here. So this blood clot is going to cause bruising. The blood clot can find its way into the uterine muscle and cause bruising. That's why bruised uterus will be tender, and that's why the patient will have painful bleeding and tender uterus. That is what is a abruption. Okay, there might be fetal distress. Yes, fetal distress might be there, not always. If there is fetal distress, I will do a cesarean. Otherwise, in abruption, I always do a normal vaginal delivery. We always try to induce labor in abruption, but no conservation in abruption. No. Plasma previa conservation can stop bleeding in 90% of patients. You know that, McAfee-Johnson regime. But abruption में conservation नहीं करते हैं, because problem with abruption is DIC risk होता है. This clot can cause DIC. This clot can consume the clotting factors and trigger the extrinsic coagulation cascade, and DIC can happen. So that's why in abruption we say no conservation. Okay, delivery is the answer. And yes, if there is distress, there is maternal homeostasis getting imbalanced and she's getting more sick, then we can do a cesarean. I'm not saying that we don't do cesareans. Try to do a normal vaginal delivery. If there is a problem with the baby and the risk is too much, we'll do a cesarean also. But don't say abruption is equal to cesarean. That is something which I have not taught you. Okay, chalo. A 29-year-old woman has severe postpartum hemorrhage, unresponsive to uterotonics. What is the surgical step? First surgical step. Please remember, PPH में first surgical step. Remember, the best drug is always carboprost. Oxytocin is the drug of choice for prevention and treatment. If that doesn't work, we'll go up to giving methyl ergometrin, misoprostol, carboprost. So carboprost is the go-to drug. अगर carboprost भी काम नहीं करेगा, कार्बोप्रोस्ट है, कार्बेटोसिन अलग है, कार्बोप्रोस्ट अलग है, ऑक्सीटोसिन कार्बेटोसिन अलग है, दे आर वन कैटेगरी ऑफ ड्रग्स। कार्बोप्रोस्ट प्रोस्टाग्लैंडिन है, दैट इज द गो टू ड्रग। अगर वो भी काम नहीं करेगा तो फर्स्ट थिंग इज द बैलून टैम्पोनाड, फर्स्ट थिंग इज द बैलून टैम्पोनाड। ऑलराइट, इंटरनल iliac artery ligation, remember that is what is a very important question. The posterior division and the anterior division, the branches you should know. The posterior division has only 3 branches: superior gluteal, iliolumbar and lateral sacral. So what are the other branches? The other branches are the anterior division. So by exclusion you can answer this question. All of the following are the anterior division branches except, all the following are the posterior division branches except. By exclusion you can answer. If you remember at least the posterior division: superior gluteal, iliolumbar, lateral sacral. Short gills. Fishes have gills, so short gills. Okay, fine. Now, if there is principle of internal iliac artery ligation asked, I'm not writing it but telling you, we don't ligate the artery here. No, we don't ligate the complete internal iliac artery. We also don't ligate the posterior division. No, we ligate only the anterior division. We ligate only the anterior division because the uterine artery is the one which is bleeding in the PPH. The plasmal base is bleeding. So we ligate not to stop the uterine artery. We want to reduce the flow. So we just ligate it strong enough to reduce the flow. Internal iliac artery, the anterior division is ligated, and the anterior division ligated strong enough to reduce the flow, not to stop the flow. Please don't do that mistake. We reduce the flow, and sluggish flow promotes thrombosis, and that stops the bleeding. Rewind and play again if you didn't understand. We are not stopping the flow, we are reducing the flow, right? Chaliye. A 28-year-old primary graduate, 34 weeks, presents with blood pressure 170 by 110, severe headache, visual disturbances, epigastric pain, urine protein 3+. What is the most definitive management? Please be careful. I did not say convulsion. So she's having hypertension, she's having proteinuria, preeclampsia. Along with that, she's having signs of impending eclampsia, imminent eclampsia. Eclampsia hone wala hai. So yes, you know there is gestational hypertension, blood pressure is high. With proteinuria, there is pre-eclampsia, and with convulsion, there is eclampsia. And you know the drug of choice for eclampsia is magnesium sulfate for the convulsion, labetalol IV for the blood pressure, and delivery for the management of this condition. The best management is delivery after when a woman has convulsion. So this is the outright basics of the management of the patient with hypertension. Now sometimes you can find out in this stage something called impending or imminent eclampsia. Imminent eclampsia. This is not a stage which is defined, but you know it is the findings which is telling me that she is about to throw a convulsion. So that is what is written in this question. Imminent eclampsia ho raha hai. She is about to throw a convulsion. So the management is just the same. If she throws a convulsion, what do? You give magnesium sulfate, labetalol, and delivery. So if it is imminent eclampsia, again same management. It is the same management. Prevent the convulsion by Maxell. Rather than treating it, is better to prevent it. IV labetalol to reduce the blood pressure and plan the delivery. So this is a case of imminent eclampsia. So immediate delivery after stabilization, magnesium sulfate, continue pregnancy with antihypertensive. No, she's having visual disturbances, epigastric pain. No, we have to do delivery. So stabilize by Maxell and labetalol and plan delivery. So immediate delivery sounds like a cesarean. I'm not saying that you'll always do a cesarean. No, you can do normal delivery also. So maybe the choice could have been worded better. Stabilize and start the delivery process. That would have been a better answer. So you answered C, all of you. Very good. A woman at 32 weeks of pregnancy presents with pruritus predominantly over palms and soles without a rash. Okay, fine. No torch, nothing. Na? Torch infection nahi, rash वगैरह नहीं है ना. Serum bile acids elevated. Bile acids elevated यार. तो बस हमें लग रहा है कि bile acids elevated है, bile salts भी बड़े होंगे, तो bile salts cause the itching because of इंट्राहेपेटिक कोलेस्टेसिस ऑफ प्रेगनेंसी, IHCP। वो जो मैंने आपको एक्यूट फैटी लिवर ऑफ प्रेगनेंसी बताया था ना, डिफरेंस बिटवीन हेल्प, उसी में IHCP भी पढ़ाया हुआ है, ठीक है। उसके भी फाइंडिंग्स देख लेना, आपकी इसी वीडियो में थोड़ी देर पहले दिए हुए। सो इंट्राहेपेटिक कोलेस्टेसिस ऑफ प्रेगनेंसी, IHCP, this is going to cause itching because of bile salts itch. BSI is the mnemonic, bile salts itch. बहुत सारी itching. Those who are not knowing Hindi, I'm so sorry. Bile salts itch, if you remember, that is enough, because bile acids भी आ सकता है चॉइस में, bile pigments आ सकता है, bilirubin आ सकता है. So please say bile salts itch. बहुत सारी itching. That's how I remember. Right, a pregnant woman at 32 weeks of gestation has a umbilical artery Doppler showing absent end diastolic flow. What is this what is this strongly going to indicate? So yes, first there will be systole, diastole, systole, diastole. This is what is normal. This is the normal Doppler, systole and diastole. And then if there is systolic flow and there is absent diastolic flow, that is what is this absent end diastolic flow. This is what is a severe compromise. It's a severe compromise. Okay, you must deliver in 1 or 2 days. And then the last one is there is systole and reversal diastolic flow. Systole, reversal diastolic flow. If there is a reversal diastolic flow, then that is a imminent death. That is imminent death of the patient. So reversal diastolic flow, reverse diastolic flow. The baby is about to die because there is no flow in diastole. So yes, end diastolic flow, it's a severe placental insufficiency. All right, severe placental insufficiency. 30-year-old woman with previous cesarean section present in labor with severe abdominal pain, cessation of contractions and fetal distress. Uterine contour is lost. Most likely diagnosis. Now, this is what is very different from abruption. Abruption is a pain abdomen but tender uterus and the BP is high. Abruption is classically associated with high blood pressure. This patient is having loss of contractions. After patient was in labor, the contractions have stopped and the uterine contour has changed. So yes, this woman has a previous LSCS and now the uterine contour, there is a scar here. Patient was being given a trial of normal vaginal delivery and the scar has ruptured. So uterine contour has changed. It has now ruptured here. It is ruptured here, so it has gone on the side and the baby has come out in the abdomen. So you will feel the baby very easily in the abdomen. So that is a rupture uterus. Now please, this question, I don't know how many of you asked me in all the forums where I'm associated and on also the PW sites. Please remember, first sign in the mother and first sign in the baby, उसे अच्छे से लिख लो, उसमें confuse नहीं होना है, ठीक है? When we ask you the first maternal sign, please answer about mother, not about the fetus, first of all. First maternal sign, obviously anybody starts bleeding, uterus ruptures, what is the first maternal sign? Maternal tachycardia, obviously. When anybody loses blood, will try to compensate for the blood loss by increasing the by increasing his or her heart rate. So mother is losing blood because of the rupture uterus, there will be maternal tachycardia. Then there will be maternal bradycardia, hypotension, shock and death of the mother can happen. But the first sign is always maternal tachycardia. What is the first fetal sign? The baby has come out of the uterus. See, it has come out of the uterus and there is a cord attached somewhere here in the uterus. So this cord will first get compressed between the baby and the uterus, and then the cord will get compressed between the uterine ruptured areas, and that cord compression will cause the variable deceleration, and then will cause the late deceleration, and then will cause the fetal distress and death. So variable deceleration, late deceleration, distress, and then death. First sign is not bradycardia of the baby. First is variable deceleration. So maternal sign first is maternal tachycardia. Fetal first sign is variable deceleration. And when I ask you the maternal sign, don't answer me fetal variable deceleration or fetal bradycardia. All right? Be very careful. Chaliye. A 28-year-old woman at 22 weeks has painless cervical dilatation on speculum with bulging membranes and no contraction. painless expulsion of baby at mid trimester. Second trimester में painless expulsion of fetus. Best management to prolonged pregnancy is a emergency cerclage. Yes, painless expulsion of the fetus. तो क्या होता है कई बार the bag is bulging out. So the baby is like this, but this bag is bulging out. So the bag is bulging out like that. Here, see. See, the bag is bulging out like this. So what we do, we take a wet cotton swab on a sponge holder and gently push this inside. Keep the patient in a head low position in the OT, push this inside and then put a suture. So before we tighten the suture, we take this out and then we tighten the suture. So that is what is known as a rescue encirclage. Oh, rescue is actually the word used for a failed cerclage and then you do repeat. So you can say emergency cerclage. That is a better answer. All right. According to the MTP Act, what is the legal upper limit for termination of pregnancy with the opinion of 2 registered medical practitioners in special cases? Wait a minute. ये थोड़ा सा गड़बड़ क्वेश्चन पूछ लिया भाई. According to what is the legal upper limit for termination of pregnancy with opinion of 2 registered practitioners in special cases? Oh God, थोड़ा सा controversy आ गया यार जाते जाते. So yes, 20 to 24 weeks. Now you know 2021 में बोल दिया था कि up to 24 weeks तक MTP कर सकते हैं. So 20 to 24 weeks, if you're doing an MTP, you have to ask of 2 doctors' opinion. That all of you know. Now there is no upper limit in special cases. Like there's an anencephaly. You diagnose. Sometimes women who are coming to us, yes. नहीं, careful यार. Question कुछ और है इसमें. Don't keep jumping to the answer C. Please be careful. Special cases आ गया ना. So normally क्या होता है? कोई भी पेशेंट अगर MTP करने आएगा, anybody comes for an MTP says, sir, I got a test done in the NIPT test done, and the NIPT shows me there's a risk of Downs. Then I did an amniocentesis, and 22 weeks I've got to know that my baby has Down syndrome. And Zellweger and Down syndrome is there, not Zellweger. Down syndrome is there. So I want an abortion. So 22 weeks, 2 practitioners will do the abortion. There's nothing special in that. You can do if there are some anomalies. Contraceptive failure only till 20 weeks. Now there's an anomaly which was diagnosed on a fetal echo. There's a large VSD, and the mother says, "I want a healthy baby." Can do abortion at 24 weeks. But now the woman comes to me and says, sir, my ultrasound is showing at 26 weeks that I have a VSD in my baby. I'm not going to abort. VSD can survive also. All of that is before 24 weeks. After 24 weeks, only special cases. I do the ultrasound. A woman has come from the village and she never had an ultrasound in a pregnancy. She came to me for a fever. I do the ultrasound and see pregnancy में fever तो था. I do the ultrasound and see the baby is having an anencephaly. Now that case cannot continue pregnancy because the baby will never be surviving. So that is a special case. We have to discuss with a gynecologist, a radiologist, a pediatrician, and then a government appointed person. Can be a women's right person, women's and child welfare department se ho sakta hai. Can be a civil servant, somebody who is a government appointed person in this board, and then we can do abortion even at 28 weeks, even at 30 weeks. So there's no upper limit for special cases. So yes, that's slightly tricky question. 2 डॉक्टर्स को सुन के आपने 20-24 आंसर दे दिया. थोड़ा सा उससे ऊपर वाला क्वेश्चन था. Okay, no upper limit. But yes, you cannot ask me for an abortion if the baby is just a Down syndrome. Down syndrome babies will survive. So after 24 weeks, if there's a small VSD, small VSD, or let's say there is a large cleft lip and palate, but the baby can survive with surgery, isn't it? There's a gastroschisis, he can survive. I will not do abortion. But if a gastroschisis come to me before 24 weeks, we can go ahead and do an abortion. After 24 weeks, only special cases. So this was slightly tricky, right? Understood? Okay. All right. A 52-year-old woman presents with solid ovarian tumor, elevated estrogen levels, and postmenopausal bleeding. What is the most possible diagnosis? A tumor which causes postmenopausal bleeding. So yes, granulosa cell tumor makes estrogen, can cause postmenopausal bleeding, but no, I'm so sorry, granulosa cell tumors can cause postmenopausal bleeding, but not so common. What is the more common tumor which can cause? It is a tumor which is the Brenner tumor, more likely. The epithelial tumors are more likely to come when a woman is having postmenopausal, because epithelial tumors present in that age group. So granulosa cell tumor is a correct answer, but Brenner is also correct. But in the age group which is the postmenopausal, I'll go with Brenner. Granulosa cell tumor also makes estrogen, can cause precocious puberty in young girls, menorrhagia in middle-aged women, and can cause, but granulosa cell tumor का age group ये नहीं है. Classically, it is not the postmenopausal. So there are two right answers, and the best answer is Brenner tumor. 29-year-old woman has missed periods and has a positive pregnancy test. Ultrasound shows a gestation sac but no yolk sac or an embryo. Best next step to confirm the viability. She has missed the period, positive pregnancy test is there. Ultrasound shows a gestational sac but no yolk sac or embryo. So you can wait for some time. There is a pregnancy. One ultrasound, you never say it's an abortion. Yes, it looks like that maybe there is no baby going to come, but who knows, it may be a delayed ovulation and delayed implantation. So we say, do MRI for better understanding? Not really required. Start termination process? Definitely not. Injection methotrexate? What nonsense. It is not an ectopic, this is an intrauterine sac. Repeat ultrasound after 1 week. So this is not wrong, but this is more than enough. Repeat ultrasound after 1 week, right? A 28-year-old woman develops sudden hypoxia, hypotension in DIC during labor shortly after rupture of membranes. What is the most likely diagnosis? So yes, rupture of membranes and she goes into DIC. There's no bleeding, there's no inversion of uterus. So yes, कई बार ये क्वेश्चन आता है कि इंटर्न ने डिलीवरी करी और उसने प्लासेंटा का कॉर्ड जोर से खींच दिया, उससे इन्वर्शन हो गया. So inversion से you can see the uterus inverted and the patient goes into shock. So inversion you can see. But here there is no delivery yet. Rupture of membranes हुआ, patient goes into shock. That is classical amniotic fluid embolism. Classical amniotic fluid embolism. That is, everything is fine, mother suddenly dies. Very classical, drastic होता है. So ध्यान दीजिए that inversion में there will be history. They said, you know, I was very upset. Intern does a delivery. मतलब interns will do wrong work only. ऐसा नहीं होता यार. Intern would have gone and pulled the cord and caused an inversion. So yes, that question has come in the exam, but they should say untrained people doing delivery can cause more inversions, right? RH aluminized pregnancy. Which Doppler test is most useful to detect fetal anemia non-invasively? तो RH isomization होगा. Mother is making the anti-D. Anti-D will cause hemolysis in the baby. So how do you know hemolysis is happening? Anemia will happen to the baby. So yes, earlier we used to do amniocentesis. उसमें bilirubin बढ़ जाता था. Hemolysis in the baby, bilirubin come in the amniotic fluid, but that is invasive. Amniocentesis needle डालना पड़ता है ना. So non-invasive क्या है? Baby is having hemolysis. So the tachycardia of the baby will happen and the baby will have a brain sparing. Brain में ज़्यादा flow जाएगा. So when the blood flow to the brain specifically increases, the middle cerebral artery velocity of the blood flow. So the peak systolic velocity of the middle cerebral artery, if it increases more than 1.5 times of the median value, if it is more than 1.5 times of the median value, we call it the multiples of median, MOM units, multiple of median units बोलते हैं. So if it is more than 1.5, that means it is significant hemolysis and significant anemia. All right. Yes, most of you got that correct. A 30-year-old woman at 24 weeks has cervical length of 18 millimeters on transvaginal sonography and a history of prior spontaneous preterm birth. This we've discussed many times today, I think 3 times. So you can do a cervical encerclage. Right, guys, I think that's more than enough for the day. I think you must be exhausted. I'm good for more if you want. I'm very much here. If you have more questions, I've kept a few empty pages. If you have more questions, go ahead and shoot, man. I'm waiting for you guys. Come, let's see what you guys are asking me. Thank you, Saransh. Very sweet of you. Akhilesh, thank you. Thank you. PDF will come. I will save this obviously and I'll send it to my team immediately before I leave this studio for my dinner. I'll do that. So thank you so much, guys. Lovely having taken a session for you. I hope I've done a lot of discussions. A few questions I did not repeat what we did in the last predictor series. So those who have not done the predictor and have come only for this one, please look at the predictor maybe at 2x speed, and you can probably also revise the remaining a few questions. I hope you do a very good exam. Be confident, guys. Come on, अब डरना नहीं है, ऐसे छटपटाना नहीं है. सर मैंने जो पढ़ा मैं भूल चुका हूँ और मेरे को तो लगता है कि मुझे कुछ याद ही नहीं आएगा. मैं तो बड़ा नर्वस चल रहा हूँ सर. सर मेरे को ना बहुत ज़्यादा सर मुझे पता नहीं कि मैंने क्या किया है सर पिछले 6 महीने से. अरे यार पढ़े हो यार, पढ़े हो. जब खड़े होगे ना, when you get up from your table, finally, last time when you read and you're about to sleep for that 6 hours before the exam, पढ़ा है मैंने, नॉन स्टॉप पढ़ रहा हूँ, 6 महीने से पढ़ रहा हूँ, घर बार को छोड़ चुका हूँ, खाना पीना छोड़ चुका हूँ, पिक्चर क्या होती है पता नहीं है, कोई प्राइवेट लाइफ ही नहीं मेरी. मेरा पेट्स जो मेरा डॉग बैठा हुआ है घर पे, वो बेचारा मेरे लिए वेट कर रहा है, मेरे को पता ही नहीं. तो कितनी सारी चीजें छोड़ के बैठे हो यार, पढ़ ही तो रहे हो. तो कॉन्फिडेंस दो कि पढ़ा हूं. दुनिया में nobody can say that I have completed medicine का कोर्स. सबसे बड़ा सब्जेक्ट है. You can go ahead and do rocket science, but it is still what we have devised, and rocket science could be a huge topic, but medicine is limitless. You have to pass some papers in your engineering, in your MBA. You have to pass those papers. The device is there in front of you to read and finish. More you read, better you do. But medicine is limitless. The human body is your course. We can pick up any artery and ask you a question on that. So please do not get upset. We will ask you the questions which make you a doctor. We will not ask you the questions which will fail you and not make you a doctor. We will ask you what is at least required. That's why we say stick to the core basics. Stick to the core basics. Anyway, अब तो टाइम ही नहीं रह गया एक्स्ट्रा पढ़ने का. बेसिक्स ही रिवाइज कर लो, 19 नोट्स पढ़ लो गाइस, एंड ये मैराथन्स अटेंड करते रहो. अच्छा रिवीजन भी कर देते हैं हम आपका. ऑलराइट, सो ऑल द बेस्ट गाइस. आई विल सेंड यू अ वीडियो प्रॉब्ली फॉर द लास्ट बिट ऑफ पेप टॉक. अब नहीं करते हैं, हम जाके खाना खा के थोड़ी देर पढ़ के बिफोर 1 o'clock सो जाओ. ठीक है. All the best guys, do a very good exam and see you in the PW forum. Whenever we are having this, we are having a party guys. All of you are joining me. Okay, God bless you.